Right. Well, good morning, everyone. I just want to make sure that Dr. Farooq. Good morning. Looking.
Oh,
You always put me to shame. I always think when I come on these webinars, I should be wearing a tie as well, but I actually put a shirt on
you know,
today, which is
which is something, I think we should we should agree that it's still something. So well done.
okay. Well, good morning, everyone, and welcome to our fourth or possibly even fifth Aligner webinar. And as always, it's an honor and a privilege to have Dr. Farooq Ahmed with us again today. Dr. Farooq, I hope you're well, and thanks once again for giving up your Saturday to share your knowledge with us.
That's my pleasure.
For those of you I haven't met yet, my name's Biju Krishnan, and I am one of the founders of CFAS Smile True, as well as being the clinical director. I've been qualified now for, God, almost 30 years. And for the majority of my practicing career, I've been very interested in minimally invasive cosmetic dentistry. And it was because of that interest that I first came to use aligners, as well as other orthodontic techniques, for over 15 years now, really to help with the smile design process. I'll be one of the team that will be helping you with your cases, your treatment planning, and I'll talk more about this later on in the webinar. Just a few housekeeping points then before we start. There's a lot of people on this webinar this morning, and undoubtedly there will be a lot of questions. If you do have any questions, I would kindly ask that you use the Q&A function at the bottom of the screen as opposed to the chat function, and that way everybody can see what you're asking. If you're asking the question, the chances are there's many people that have the same question, and when we reply, everyone can see the reply. Also, if you do have any questions, I would ask that you write them down first before posting, as it's very likely that Dr. Farooq will cover this in his talk. We have ample time for question and answers throughout the webinar as well, okay? So don't worry if you're not sure about anything. There'll be plenty of time for us to clarify any of the points that are raised. Also, this webinar will be recorded and sent out to you again for reference, so don't worry if you miss anything, you have to leave early, or you just want to go over the material again. Okay, enough from me. I'd like to introduce Dr. Farooq Ahmed, who's a consultant at Guy's and also in private practice. I first met Farooq on our orthodontic diploma course, and as you're about to find out, he is an exceptional speaker, and he's got a very wonderful approach, a very refreshing approach to teaching orthodontics that I'm sure will give you guys a lot of confidence in starting your aligner journey. And I've also, Farooq, been really interested in your podcast series, which I think it's absolutely fantastic. For those of you, I'm sure, please do mention that on your talk, because I think it's great.
I do. I will always promote myself. I think that's pretty much guaranteed. But thank you for it, and thank you for hosting this again, Biju, and with the CFAS team. It's great to be here with you guys to talk to you about a passion of mine, which is orthodontics, but specifically within orthodontics, aligners are things which I really find interesting. And I've been on a journey myself in education over the past 6 years after I qualified, and really today is my way of sharing that knowledge with you guys to talk about tricks, so you guys can go on Monday morning and produce your first aligner case with that confidence. And I think it's great that we are working together. So I just want to explain our relationship. So I'm external to CFAS. I'm not employed by CFAS, and I come today as an external educator. And part of the reason why our relationship has continued, my relationship has continued with CFAS, is because of the support that they offer in the laboratory side, as well as having a clinician-driven advice service as well. And for me, that's a key component to any form of new clinical procedure that we're carrying out, is that it's well supported and well taught to begin with. Hopefully you guys will get the latter. I definitely know you'll get the former, which is good support during that process, which is what's brought us here today and this morning. I'm just going to share my screen. Biju, I'm just going to ask you to be my quality assurance check that it's all working.
Yep, that looks good.
Perfect. Let me just get that into presentation mode.
Great.
Excellent. Cool. And audio is okay, Biju?
Sounds good.
Fantastic.
Thanks.
Cool, guys. So the agenda for today. So we're going to be going through an introduction of aligners. We're going to have a break around about 11:15. And then the late morning session, we're going to be looking at our first case setup. We're going to get straight down to it. Part of today is also to give you guys the overview of the entirety of the process. That includes consent and taking records, which we'll delve into some detail with. We'll break for lunch for half an hour, and then we'll come back in the afternoon where we'll go through a further 4 case setups. So we'll see a variety of different types of arrangements where we can deliver that predictably with aligners. We'll go through some of the clinical side of using aligners, and the 2 main bits to them are attachments and interproximal reduction, which, if you haven't done before, sound quite intimidating, but actually once we've broken it down, you guys will see it's really straightforward. It's a bit of composite. It's using essentially a glorified polishing strip. We'll have a break then, and then we'll move on to then looking at the end of the journey for patients. The retention, how we ensure that the great result we've got is maintained for them, not only for 6 months or for a year. Actually, it's a lifelong retention process, so we keep that result for them. They keep having that nice smile. We'll go through some tips, some troubleshooting, and actually what is the journey of the patient from their perspective. So you guys are well informed to tell them, well, this is what's going to happen when you go through your aligners from A to Z. Cool, I'm going to make and this is the disclaimer. So just to be explicit, that the contents and knowledge provided in this course today are mine and mine only. I'm external speaker to CFAST. I'm not employed by CFAST. I'm not endorsed by CFAST. Now, this lecture has developed over the number of iterations that we've had. Biju and the team have put input into it, and I really appreciate their input into the process. It has been kind of bona fide, and what I agree is correct has come through into lecture today. So it is, yes, it's my knowledge base, but actually I've gathered that from different resources, and CFAST have contributed to that, and I want to make sure that's accredited to this process. Okay, so this is so this picture on the left-hand side is me under lockdown. So I was bored, and I essentially started a podcast in orthodontics, and it summarizes key lectures in orthodontics. I've started doing a blog now, so we cover some educational points. It's relatively brief stuff, and for me, it's a way of expressing what I've learned. Because the journey can be quite convoluted in different bits of orthodontics, and sometimes it just needs to be brought down to a summary, and that's how I learn, and I really wanted to share that with people, so feel free to have a look at that. I work as a consultant at Guy's Hospital and have been so for the last 3 years, where I lead on teaching aligners to postgraduates, orthodontists, orthodontic trainees who now are going through the 3-year structured program. I work in private practice in the West End and also in North London, and that pretty much occupies my entire week and some of my evenings as well. My contact details, guys, so I'm accessible, and please feel free to reach out to me. It's great the conversations I've had with you guys and the previous people who attended the course. And again, I very much value that conversation. I really feel, now, Biju, correct me if you disagree, and I really invite Biju to contribute as and when he feels into this presentation, is that education for me is very much a conversation. And the conversation is had, yes, from somebody with perhaps a bit more experience and knowledge base to people who perhaps have less so. But in that conversation, there'll be questions that happen, and it will be the same today, that there'll be a question which I will not know the answer to. Hopefully Biju does, but if we don't, we will then go and learn that information, and then we'll make sure we get back to you on that piece of information, because education at adults is a conversation for me. And I really value you guys coming today to participate in this conversation. Okay, guys, so no photos, and I want to be explicit about this. The clinical photos that are going to be in this presentation today have been given permission by the patients to be shared for this particular session. They have not given permission for it to be used anywhere else. So please don't take any images of the clinical photos. Now, you'll see in the corner on the top right side, hopefully, of your screen, that there is a photo taking image as well. So there are key slides which I feel are ones to really take on board. This lecture is recorded, which is great, but if you want to have that summary of the lecture and engage with the process, please take some snaps as we're going along so you can recall that key information as and when is needed in your clinical practice. So this is what today is about. It's about teeth, and it's about smiles, actually. And patient comes in on Monday morning and said, I don't like my teeth. Now, as dentists, we'll now diagnose that from a smile assessment perspective. There's a few things going on here. There's wear to the teeth, there's a black triangle that's emerged, and there's also this imbrication, this crossover of the upper central incisors. And what we're talking about today with aligners is how can we deliver this predictable outcome? how can we take this patient from having that imbrication, that crossing over of the upper anterior teeth, and give them anterior alignment taking place? This is what we're going to be focusing on today, how that process is delivered. Now, this is where I want to make clear my opinion on the matter, is that whether we are a specialist or consultant or general dental practitioner, I don't think titles are the way to access good clinical outcomes. I really feel as though this is where we digress from that. And it is now about passing over education and you guys absorbing that and taking it forwards. And I'll describe my own journey when it came to aligners. So I did my 3-year specialist training course in Manchester, became a specialist in the GDC, and then I started to learn aligners. I did my first online setup with a case and I had no clue what I was looking at. I presumed I would do because I've done 3 years of training, but that didn't transpire. Then I contacted one of my general dental practitioner colleagues. And said, well, you know, who's got more experience than I? What is it that I'm looking at here? And then they broke it down. And again, part of today is going to be passing on that information I got right at the beginning, so you guys have that going forwards. Now, this is where I think also we've got to bear in mind that you guys can now take this smile journey further. This patient didn't come in saying, I don't like the overlap between my 2 central incisors. Please, can you upright the teeth? They came in saying, I didn't like my smile, right? So with that, we have aligned the teeth now. Okay. But now this patient's come back to see me and I'm the orthodontist and said, actually, Farooq, you mentioned I got a bit of wear on my upper lateral incisors and I know the tips of the central 2 front teeth aren't quite right either. Something going on with my upper right canine. What can you do about that now? And I'll say, great, there's lots of things that can be done. I can't do them. Let me pass you over to our cosmetic general dental practitioner colleague, who's now going to take you further forwards, perhaps with some bleaching, perhaps with some bonding, to then take care of the remaining of what their concerns were. And what I find is that patients will come in, they'll come in concerned about the appearance of their smile, will straighten their teeth, and at the beginning they had no interest in bonding, they had no interest in bleaching. But actually, when patients undergo courses of treatment of orthodontics, they do become sensitized to their teeth. And at the end of their journey, it's remarkable how many of them now do want to go for bleaching and bonding, where at the beginning, actually, just straighten my teeth, I don't care about anything else. So it's a conversation to continue to happen. And I feel as though general dental practitioners are really at the ideal position to take patients on that journey, because you guys can then offer them the bleaching and the bonding and complete that smile journey. Okay, so today, aligners. So what are they? Well, this is an online setup of a case, and this is simply how aligners look. They will straighten the teeth. But how does that work in a progressive sense? What are the stages in us achieving this outcome? Well, this is how aligners actually break down. Aligners are a series of different dental casts which have been modified, which then sequentially move the teeth from the beginning on the top left side to the bottom right side, where we achieve complete alignment. So each one of these are very distinct and clear stages where the patient has a new aligner to change into. The process itself is very much a digital one over at CFAST, and to be honest, I think delivering it with any company now, if it's not a digital process, it's a questionable process. And the reason for that is the way aligners work. So to go from the left side to the right side, we are imparting a force onto the teeth. Now, here's where there's always a bit of kind of step down to orthodontic terminology, and I feel as over the decades of the profession establishing itself, part of it has been to establish our own language so we can talk amongst ourselves, but perhaps to not engage with other dental colleagues. And I feel that's not quite right. So I am going to use some of the orthodontic terms, but hopefully we're going to translate that as well. So 4 systems. So let's describe the aligner. We've got a picture of it on the right side. I am now going to stop the screen share so I can do a visual demo, which will be very underwhelming, but I mean, I quite like it. Cool. So hopefully the screen share stopped. I'm introducing a plastic ruler. Cool. This will be our liner for the purpose. Here we have a USB stick in shape of a tooth, which will be a real tooth for the purpose of this demonstration. And essentially, the plastic is going to bend and stretch and is going to start to push on the tooth. Once we've got that engagement taking place, we are then going to have this process happen. Oh my God, it's not a good demo, is it?
Once we've got the engagement taking place and the tooth doesn't fall out the mouth, we then have this process taking place, where the plastic carries on pushing on the tooth to go back to where the plastic originally was.
That is genius. Have you patented that?
No, I haven't, but I'm definitely going to. For me, the bit where it dropped as well, I mean, that's like social media.
We'll cut that out of the recording, don't worry.
I'm just going to go back to the screen share. By the way, guys, I do that every time, and each time Biju will come with a bit of a dig in there. I'm going to carry on. I like it. Okay, cool. So that was the description for force system. Essentially, the plastic is pushing against the tooth until the tooth moves to where the plastic wants to be. So if I can now, there we go. So what's going on here? So we've got the picture before when the aligner has just been put in, and we've got the picture after the aligner has done its job. And we can see very clearly there's this overlap, which has now disappeared from the tip of the incisor. Just going to get a bit of laser pen on the equation. So we've got this bit here where the plastic isn't quite fully seated. And that's the image of the plastic essentially stretching and bending. It's changed in its shape. But once the plastic has done its job, actually it's going to be flush to the tooth surface. The tooth has done what the plastic wanted. There is 0.25 millimeters of movement per aligner with the CFast aligners. So when I described earlier on that it's a digital process, and actually it really should be a digital process, it's because actually manually moving a tooth 0.25 millimeters is a real challenge to do predictably. And I feel only really can happen if we're using a digital planning software service. So this is it. This is the aligner, and it's pushing on the teeth to be able to move them. Now, in my mind, I have John, who's our lab technician at CFast, essentially a small version of him pushing on the teeth. Now, you may not wish to have that in your mind, but for me, that is essentially how the process works. Little John's pushing the teeth. Now, when it comes to tooth movement, there are different types of orthodontic movement possible. Here we've got a list of the 5 main types. We've got tipping, intrusion, extrusion, root movements, and bodily movements as well. Now, in this variety of orthodontic movements, when it comes to alignment, actually we're looking at tipping movements. Now, that's a really good thing when it comes to our anterior aesthetics. Here we have a linear description of these same ones. Now what we're going to do is describe, well, what do aligners do well and what do they not do well? We know when it comes to tipping movements or alignment, it is relatively a predictable process. Intrusion is okay for individual teeth. Let me start to move further down the line where root movements and extrusion are not particularly predictable when it comes to aligners. Now here's the same process, here's the same tooth movements, and what I've added into it is expansion, because expansion does feature with aligners, but not historically when it comes to those traditional orthodontic movements. So I've added it into the equation here, and actually it's a relatively predictable movement. Not quite as much as tipping, but it's not far off it. And that's because mostly expansion is a tipping movement. These two types are merged together when it comes to orthodontics. But so we have clear in our minds, we can do these 2 movements very specifically well, and the movements on the right-hand side of the screen aren't going to be predictable. So we should essentially try and avoid them for our anterior alignment cases. Any case that does require that, actually we're looking at more complex movements. We're thinking of potentially going on further training experience to gather it, or we're thinking of referring on. So on the left-hand side, we've got a car which is being pushed by me because it's quite an average person, and actually it's relatively easy to do. We've got all of our wheels. We know we can do that relatively easily. Now on the right-hand side now, things are hard. We're missing a wheel. It's going to be tough to deliver that. And we're going to get frustrated, patient's going to get frustrated, unless we have done, let me get this out of the way, unless we've done further training. Now this is an image of Biju after he's been to the gym. So having undergone further training in orthodontics means that actually we are able to deliver it, but it needs that further training to do it. That image in the corner there to take a picture is to take a picture of Biju, really, because I think it's a great one of him. Now, when it comes to rotating teeth, we've mentioned that it's a predictable process, but you know, the world isn't black and white. So there are some teeth that are better for alignment and some teeth that struggle with alignment with aligners. So let's break it down so we understand why. So here we've got a door. If we wish to move this door, we're going to push on one side of the door. Now, the reason why opening a door is easy is because the door is relatively flat. So now when we look at tooth shape, to try and make some sense of this analogy, is that we've got a central incisor. A central incisor is relatively a flat tooth. So if we want to align this tooth, we can push on the distal side. We can also push on the mesial side. We've got a flat surface. It's going to derotate quite predictably. However, if we look at canines and premolars, the analogy is more of a rock, a round circle. It's quite difficult to push this predictably and get it to move in one particular direction when you're pushing from the side. And that's what it's like with canines and premolars. When we try and push on them, because the surface is curved, we're not quite able to push in that perpendicular way, the same way we'd open a door. So we're less likely to know exactly how it's going to move, and it's going to be far less efficient. And that's why here we're looking at just alignment of teeth, and we can see the numbers are different. For 73% for the anterior teeth, and actually for canines and premolars, the posterior teeth is around 40%. They don't move particularly well with aligners. That's going to feature when we come to looking at some of our case setups, where actually we've decided not to align posterior teeth, so we can just align the anterior teeth, and therefore our treatment is far more predictable. Aligners versus fixed. So in this conversation, I'm not here to say that aligners are the only way, but it's important to understand a little bit about fixed and what the differences are between them. Patients are very commonly going to ask, well, why not go for ceramic appliances? Why don't we think about something else? Especially if they've Googled getting their teeth straightened. So what are the advantages of aligners? Well, they are aesthetic, and that has to be said. They are an invisible component to orthodontics, which has increased their popularity massively. With ceramic appliances, there's still something on the teeth which can be seen to a degree. It's reduced, but it's still there. Lifestyle-wise, so one of the biggest challenges with fixed appliances is the fact that they are getting involved when the patient is eating and chewing. You've got to watch their diet, got to avoid certain things to not break the brace. But aligners are different to that, because you take the aligners out when you eat and drink. So that's a real change for patients undergoing orthodontics by the virtue that they can eat and drink whatever they please. Risks. So both aligners and fixed appliances carry iatrogenic risks. There are things that will damage the patient's teeth and the roots and the surrounding structures. However, aligners have a reduced risk relative to fixed appliances. When we go through the consent section later on in the day, we'll go through the numbers as to, well, what is the risk like? Now, I've got to be clear here. I feel as though sometimes when I describe this, it sounds as though aligners don't have risks and fixed do, so therefore to be safe, go for aligners. That's not the case. It is less risk with aligners, but they still hold certain iatrogenic risks for patients. When it comes to the clinical management with aligners, control is the feather in their hat. And I'll draw the analogy of placing an implant. Not that I do any implants anymore. The idea of placing an implant freehand versus placing an implant with a stent is the equivalent example between fixed appliances and using aligners. With aligners, we have the stent essentially. We have the plan as to where the teeth are going to move, and it's going to be delivered in that fashion. The only shortcoming that can take place is if we don't fully insert the implant, i.e. when it comes to aligners, is if we haven't, the tooth just won't quite move where we planned it to move. It either will move or it won't move. It won't move in a third direction. Now, when it comes to placing an implant without using a stent, we're at the liberty of our hands and perhaps our creativity, understanding of anatomy, and so on and so forth. So we can get the implant in the absolutely correct position. It could be that we don't quite insert it fully, or we could go into a third direction. We could put it in the wrong place. We could now start to create a fenestration going through buccally, palatally. There can be other things that happen. Now, that issue is not possible with aligners because it's essentially a stent. Let's have a look at cases next. Cool. So we're going to go through an assessment of a patient. Now we're going to be looking at it from an orthodontic perspective so we can see how aligners interact with it. Now I I remember when I started orthodontics, and for me it was, well, I just want to put the braces on. Yeah, this other stuff about assessments, we'll do it later when it comes to my exams, but actually let's just do braces. And as time goes on, and I think this is true very much in dentistry, we realize that actually the power in our clinical delivery comes to our power of our diagnostic skills. And orthodontics is not dissimilar in any fashion. So our assessment and how robust we are allows us to be so much more predictable in our outcomes. We can have a better conversation with our patients. If we pick up a lower 4 that's rotated, we can talk about leaving it and describing that to them. But also we can communicate far more effectively with the laboratory, with Biju and the team. When we get clinical assistance, we're able to have a better conversation. And we don't just talk about communication as the key to avoiding complaints. Well, I also feel communication is the key to us getting good clinical outcomes, especially when we're trying something new. Now, when it comes to the orthodontic assessment, which we're going to go through next, when we were putting this course together, I have my own assessment form. And what was great was that with Biju and the team over at CFAS, they also have their aligner evaluation form. And what was great is that actually we crossed over on nearly all of these accounts. So we've got 2 kind of independent clinical practitioners now who essentially are doing the same thing when it comes to assessment. And hopefully that gives you guys confidence that this is what you do need to know. When I go through the next series of slides, whatever is in red are clinical parameters to avoid doing aligner treatment on. And we'll pick up on those as we go through it. So let's start off from the outside. We're going to look at our clinical assessment. What is the skeletal relationship of the patient? So a skeletal 1 is essentially where top and bottom jaws are in harmony, where the chin point lies on this vertical line. With this vertical line, if the chin is behind it, then actually it's going to be class 2. And if it's anterior to that line, it's going to be a class 3 component. So this patient, as we're looking at them, the patient's chin is behind that line, and therefore it's going to be a skeletal 2 case. What's important to note is that so far there's no red lines which are there. We're just observing the patient so we can know where their skeletal pattern is. We're going to look inside the mouth now. We're going to get straight to the orthodontic side of it, which is the molar classification. Now, appreciating we probably did this as undergraduate, let's just recap the process. We're looking at the upper molar, and we're looking specifically at the mesial-buccal cusp tip. We're looking at that relationship between the lower first molar and the mesial-buccal groove. When we put these 2 guys together, the mesial-buccal cusp of the upper first molar lies in the mesial-buccal groove of the lower molar. And that is our class 1 relationship. Now, if the upper molar is anterior to the mesial-buccal groove of the lower molar, therefore it's going to be a class 2. Now, if the mesial-buccal cusp of the upper molar lies now behind the mesial-buccal groove of the lower molar, that's going to be a class 3 relationship. So here's in summary molar relationships. And that's quite straightforward to do when we're looking inside the patient's mouth. Now, what I tend to do in my practice is that I will try and do this first, even if the patient only wants anterior alignment. And it's because it's quite easy to then get distracted by the crux of the case. It's about the anterior teeth, it's upper left 2, which is flared. But actually, having that comprehensive assessment evaluation form from CFAS is a key way to ensure you have a good conversation, both with the technician, but also with the patient. Biju, I'm sorry, is it possible to perhaps put that evaluation form onto the chat so the guys can have a look at it?
Yes, I'll do that. And actually, when we do the follow-up email after this webinar, we'll attach that to the email. So you'll get all the resources.
Perfect, thank you. Excellent. So that's our molar classification. So let's now take this into the clinical. So we're looking at our patient here. We're looking at the mesial-buccal cusp, to recap, of the upper first molar and the mesial-buccal groove of the lower molar. Those 2 are on top of each other. In our little aid memoir on the bottom left, we can see that's our class 1 relationship. Next is canine classification. I think this is always a bit of a murky area because it doesn't seem to have as much oomph in the textbooks and perhaps in our undergraduate training. So let's just recap this. The basis of this is to evaluate not only the very back of the mouth, but also looking at the mid-arch as well. So it does form a key part of actually evaluating a case, to know what the back teeth are doing, what the middle teeth are doing, of course, what the front teeth are doing, which we'll come to shortly. So for this middle tooth assessment, we're looking at the canine, and we're looking specifically at the upper canine cusp tip. Our lower landmark that we're looking at is the embrasure space between the lower canine and the lower first premolar. And again, putting these two guys together, we either get a class 1 relationship, upper cusp tip in the lower 4-3 space. Now, putting that together with our knowledge now base of class 2 and class 3, we can appreciate class 2 is when the upper canine is anterior to that embrasure space, and a class 3 is where the upper canine tip is posterior to that space. And that indicates our class 1, 2, and 3. So let's have a look at our patient. So we can see here the upper cusp tip lies in that embrasure space of that lower 4-3 region. It's going to be a class 1 case. I'm going to evaluate both sides, of course. Now, going to the very front of the mouth now. So the bits that perhaps the patient's got interest in, we definitely have an interest in as well. And we're going to evaluate it from an incisor relationship perspective. So what are we looking at here? We're looking at the cingulum plateau of the upper central incisor, and we're comparing that to the lower incisor tip. If the lower incisor tip lies on the cingulum plateau or just beneath the cingulum plateau of the upper incisor, that's our class 1 case. If the upper central incisor lies the cingulum plateau lies anterior to the lower incisor tip, that's going to be our class 2 division 1. Now, when we have an upright upper central incisor, here we can see in the diagram, we've still got the cingulum plateau anterior to the lower incisor tip. So it's still going to be a class 2, but this time it's class 2 division 2, essentially because the tooth is upright as a central incisor. And looking at our class 3 case. So a class 3 case is where the lower incisor tip is anterior to that cingulum plateau. Cool. Again, here's one to have a look at, guys, to just demonstrating what is the different incisor relationships. So we're looking at cases, and I think study models are great. Now that we have digital study models and we do our online setups, it's really, really simple to assess this. Even after we've done the clinical assessment, we can check it again using the digital models. And we're simply looking, do those low incisor tips lie on that cingulum plateau of the upper centrals, which they do for this case. That's a class 1 incisor relationship. So other occlusal components we want to look at. We want to look at the overjet. And this is a key parameter. If the overjet is significantly increased, we've got to make the patient aware. You've come in concerned about your smile, partly it's to do with your top teeth sticking out. You've got buck teeth. And if we count anterior alignment, they will remain in that position. We'll straighten them and we'll neaten them up. But the patient needs to be aware of that. And the only way we can really start to have that conversation with them with objective information is by carrying out the occlusal assessment. So let's have a look at the overjet. The overjet is from the upper incisor tip to the lower labial face of the incisor. And we simply measure this horizontal distance. It's very common to use a ruler. Now, it is required to use a ruler for this. Now, these rulers aren't challenging to acquire, but they do require some thinking. If we try to use a typical endodontic ruler, for example, for measuring off K-files, is that usually they don't start off on 0. Now, the easiest way is to buy a specific ruler, which starts off bang on 0. So it's very easy for you to make that measurement. If there's a bit of a gap, which I find tends to be on the endo rulers, is that you then find that you've got to make a substitution and try and work out what the number is. It just gets a bit less clear. So get a specific ruler just to measure the overjet, which starts from 0. If you Google or look in TOC or look at Henry Schein, there are specific rulers for measuring overjets, which are simply rulers that start on 0. Now, when it comes to looking at the overbite, we're looking at the vertical relationship now. Still the same two teeth, the upper centrals and the lower central incisors. And we're looking at what is the vertical overlap. We measure this now from the upper incisor tip to the lower incisor tip. Now that becomes a bit of an odd one to actually physically measure. So we'll usually look at percentages. So we're looking at, well, how much coverage of the lower incisor does the upper incisor give? Now, if it's 20 to 40%, that's going to be an average overbite. What we also want to know is it complete or incomplete? So if we go back to the image here, what we define by complete and incomplete is if it's making contact with hard tissue. So here we can see that the low incisor tip, which is our reference landmark, is contacting the cingulum plateau. It's a complete bite. If there was a gap between the low incisor tip and the cingulum plateau, that's an incomplete bite. Now, when we start talking about increased overbites, typically a mild increase is 40 to 50%, as we can see. Moderate is where it's 50 to 70%. And actually severe is when it's 70%. So guys, if we go back when we described looking out for the red highlighted images to avoid aligners, it's the severe cases we want to avoid it on. Now here we've got that typical case where it's almost a complete overbite that's taking place. And this requires more management. And again, this goes into that side of the spectrum when we describe predictable and unpredictable movements, is that now actually we need to engage, we need to think about it being more complex, undergo further training, and have a really deep conversation now with the support team to say, actually, can we now deliver this case predictably? And if you haven't done that, then actually it's probably best to pass that case on to somebody else. Now, Farooq, why is deep bite such a challenge? Well, let's go over it. We know when it comes to using aligners to intrude teeth, so we've got over-erupted teeth, we want to intrude them now to correct our deep bite, we can only do it predictably at 3 millimeters. For deep bite cases, it's going to be significantly higher. There's also soft tissue effects to bear in mind as well. So let me just show you a couple of pictures here. So this patient's got a deep bite. He's also got spinach in between his teeth, but let's focus on the deep bite. His smile is a strange one, but when he smiles, he doesn't show much of his upper incisors. The typical smile from an aesthetic perspective is to show 100% of the upper incisors. Now he's showing about 60 to 70%. So in intrusion, we've got to decide, are we going to move the upper incisors up and the lower incisors down, or just do one of those? If we were to just intrude the upper incisors in this case, we're going to diminish his upper incisor show further. On the other side of it, we've got this patient who's got a gingival smile. It may be advantageous for us to intrude her upper incisors because it's going to reduce her incisor smile. Deep bites. So we realize now that deep bites are a challenge from a planning perspective. Predictability of intrusion is a challenge, but also when it comes to putting on the bonded retainers. Now at the end of today, we'll go over this in detail about how to put them, but essentially planning for them means there has to be some space to be able to do it. An average overbite allows space to be able to put on a bonded retainer. If the patient still has a deep bite at the end, because we haven't been able to get that predictability, because it's quite deep, there's no space to put a bonded retainer on. Then there's question marks about stability long term. So if we're not able to do it, then actually let's not go for treating this particular case to correct the deep bite. And stability, and this is a hallmark picture of getting the angles of the teeth correct, relatively orthodontic in its nature, but the idea is that deep bite stability is a challenge when it's so significant. And we now have to start thinking about some root movement to help make it more predictable. And again, now we're looking at the more challenging movements with aligners. And as I say, further training or passing it on to somebody else to then treat. Crowding. Now, this is probably the build-up to what we are looking to treat our patients for. It is pretty much what patients come in asking about. It's resolving the crowding. So let's do our assessment of it. It is an assessment of the mesial distal widths of the teeth compared to the overall arch length which is present. Now, the discrepancy between those two indicates the amount of crowding which is present. Now here's a bit of a cheat. This sounds quite arduous. I'm going to get a ruler out, measure each one of the teeth. I'm going to be there forever. But actually looking at contact point overlap gives us the same information. So here we can see there's overlap, about 1 millimeter of each one of those two teeth. It's about 2 millimeters of crowding. Looking at the lower arch, we're looking at all the overlapped contact points. And this is contact points add up to about 4 millimeters. So therefore, we're able to, in a much simpler fashion, quantify the amount of crowding a patient has. So where do we stand when it comes to now delivering this with aligners? Well, mild crowding is 1 to 4 millimeters, which actually feeds into majority of cases. That's great with aligners because we can create space, and we create space through interproximal reduction, proclination, and expansion. Now, those three methods have limitations as to how much space can be created, and it falls very neatly into the 1 to 4 millimeter category. What happens if we've got more crowding? Well, if there's 5 to 8 millimeters of crowding, it's defined as being moderate. Now we're looking at doing more things to be able to align those teeth, potentially distalizing teeth, potentially carrying out extractions, and using more complex mechanics. So now things are going a little bit grey, a little bit amber, I suppose. And severe crowding. So severe crowding is 8 millimeters plus. This is typically when we are looking now at extraction therapy as part of their treatment. Now, it doesn't mean it's not possible to do with aligners, but again, it's falling into the further training / referring on for some more clinical experience before delivering it. Crossbites. So crossbites is where we have an incorrect buccolingual relationship between teeth. And we can see on this right-hand side, we've got a crossbite present between the upper lateral incisors, going all the way back to the first permanent molars. Now, the question is, why is that important? Let me show you this case. And this is one where, even with my postgraduate trainees, we can sometimes miss, and I tend to be a hawk to look for any centerline discrepancies. Let me explain why. Here we have a case where there's a crossbite on the left-hand side. The upper left 3 is in crossbite. Now, here is the patient in their centric relation. Here we can see there is an edge-to-edge bite with that canine. If I can now draw your attention to the centerline here. In the first image, the lower centerline appears to be to the left-hand side. And this is a patient in centric relation or intercuspation. Now, with the patient in their retruded contact position, we can see the centerlines are coincident. And that really feeds into our planning for this patient's case. They don't have a centerline discrepancy. They have a crossbite with a displacement on the left-hand side. And that's important because it may then feature in how we plan to move the teeth. We described initially with aligners, the main advantage clinically is the fact that it's a controlled system. But actually, you've got to know where you're planning to move those teeth to. And if we miss something like a crossbite and displacement here, the centerlines aren't going to be where we initially expected them to be. So with all cases with displacements, I will always ensure I take photos in both centric relation, so centric occlusion or ICP, as we can see at the top, intercuspation, and also in centric relation or retruded contact position at the bottom there. And that feeds into the conversation I have with the laboratory. I can say I'm going to expand these teeth, and we know the crossbite is going to correct to this retruded contact position. Buccal corridors. So part of our assessment is also looking at patient's smile. As we mentioned before, they've not come in saying it's the crooked teeth, they've come in mentioning it's their smile, which is an issue. So buccal corridors are looking at the gaps between the posterior teeth and the commissure. Now, on average, it's between 13 to 17%. Now, there is ways to alter that as a process. Orthodontics, I will go out and say, has limited contributions to that process. We can change the patient's buccal corridors if they have a crossbite. But without a crossbite, expanding to try and resolve buccal corridors has some instability to it. There's nothing to keep that expansion there. But it's important when we're having the conversation with the patient, we have made this assessment. So we can say whether or not orthodontics can or cannot make a difference to it, but also tend to start describing other options. They may think about having buccal veneers done in a composite or ceramic format. There are other things we can then start to think about and explain, well, this is what we can do for your smile here and now, and also this is what we can do further down the line for your smile. Center lines. So I think one of the challenges with centerlines is that we tend to just look intraorally when it comes to doing the assessment. And here we can see there is a discrepancy. The upper centerline is where it is, and the lower centerline is to the right-hand side of the upper centerline. But that's not actually what we want to do in isolation. What we really want to do is know where the upper centerline and lower centerlines are relative to the patient's face. So we've got to go extraoral to do this assessment. We want to draw a line down all the patient's mid structures, the midpoint of the nose, the midpoint of the philtrum, and then look at where does the upper central incisor lie to the patient's mid face, and then do our assessments of our center lines. So here we find the upper centime was correct. The lower was to the right side. And again, this is where the ruler comes out. We make a measurement. It's 3 millimeters. Shape of teeth. Now, the shape of teeth form a key factor to aligner treatment. Typically, we're going to be looking at using interproximal reduction for our alignment. But actually, some teeth it works well for, some teeth it doesn't work well for. So let's work out what that is. So triangular teeth are ideal teeth when it comes to doing IPR. Ovoid and barrel-shaped teeth are great as well. The teeth to be questioned are square teeth or rectangular teeth, and most definitely conical shaped teeth. Now that information itself is there and you guys can absorb that. But actually I want to explain why, because it's far easier to understand why that's the case of good or bad, rather than having to necessarily learn all the tooth shapes. So here we have a typical tooth. Now, if I can draw your attention to just the enamel component to it, at the cervical aspect, enamel is the narrowest. And at the incisal aspect, enamel is the thickest at the interproximal area and also on the incisal edge, but we're focusing on the interproximal side. So when that breaks down, we have different areas where taking enamel off is safer and different areas where taking enamel off is not so safe. And this is how it works. Cervical aspect, we want to avoid doing reduction. Incisally, we're happy to do more reduction. And we have this scale to indicate that. So let's now go back to tooth shape, which is what the premise was. Well, actually triangular teeth, they meet at the incisal tip. So therefore it makes sense. We've got the most enamel there. We can do healthy IPR, or we can do a reasonable amount of IPR. Now, when it comes to looking at the inverse, when it comes to looking at conical shaped teeth, actually their contact point is far more gingival. Here where you know there is the least enamel present. So for these guys, we're on the red side of the spectrum where we need to avoid doing IPR. Now, again, in having conversations with delegates who attended this course, I've had some contact and they mentioned, well, actually, Farooq, I looked at the lower central incisors and laterals and they were conical, or square shaped. And actually, Farooq, is it safe for me to do any aligner treatment? It's not a contraindication to aligner treatment. It's a contraindication to doing IPR on those teeth. And we'll show a case later on where, after having that conversation, we've added it into the course now, where actually we have a case where we've got conical low incisors. We still did some IPR, but we moved it to the canine teeth. We've got massive amounts of enamel that we can do. So it's simply about isolating which teeth we want to be carrying out IPR on. Cool. We'll whiz through these last couple of slides, guys, and then we'll have our well-deserved break. So dental assessments. So we still want to be looking at other components of our assessment. Soft tissue display, as we mentioned with a deep bite case, is that we need to make that assessment before we plan our case. Now, I've mentioned here caries, tooth wear, restorations, and periodontal status. And that sounds, well, obviously, Farooq, we're dentists and you're the orthodontist. But I find that there sometimes is this separation, this mindset that actually I'm doing some aligner treatment now and I'm not doing dentistry. And we've got to make sure we are still doing our comprehensive dental assessments of these patients. There is a risk for patients undergoing aligner treatment. That's minimized if they have very good hygiene and good dental health from the outset. So we still need to stick to our basic parameters, health first, and really aesthetics is secondary. Periodontal status, so as mentioned, BPE here, looking at recession and making an evaluation. I put down here gingival biotypes, and I found this great slide from this paper by D. Rook. And what it shows is different gingival biotypes. Now, this conversation is based upon whether or not we can move the teeth forwards, whether or not we can procline teeth. We mentioned there's 3 ways of creating space for mild cases: IPR, proclination, and expansion. Now, one of the parameters that helps us work out whether or not we can procline teeth is looking at the health of the gingiva. Now, these 3 very specific gingival biotypes indicate different amounts of proclination. The one on the left side, the thick, flat biotype, is wonderful. Massive connective tissue. We can push those low incisors forwards with a real confidence recession is very unlikely to happen. Next, we've got a thick, scalloped biotype, which is in the middle there. So what we can see here is that the keratinized gingiva is relatively thick. There's no shine through taking place of that gingiva. It's scalloped, which means it's well shaped to the low incisor cervical aspect of it, the cemento enamel junction. Now, on the right side is the one to perhaps pay the most attention to, the thin scalloped biotype. So what does that mean? It means that keratinized band of gingiva is thin. And how do we work that out? Well, it's usually relatively translucent. When we're probing it, we can essentially see the shine through of our periodontal probe. We can see it's got a really scalloped area, which means that it's very close to that cemento enamel junction. And these are the cases where if we do carry out some proclination, due to the lack of connective tissue which is there, or the robustness of it, we're very likely to get recession taking place. So these are the ones to make sure we've assessed and we've put them into our biotype category. Are they thin scalloped? Now, the good news is most patients don't fall into this category, but I can quantify it for you. It's about 40% of patients that do. So although it's not the most common, actually it's relatively frequent in the minority of the people that we will see. And TMD assessment. Now, TMD is one to, I think TMD is a really interesting topic, and I feel as though that people will sit on one side of the TMD argument or on the other, and I'm not going to sit on either side of it. We're going to go through the evaluation of it because it's an important part of picking up pathology. So in summary, we want to look for crepitus, looking at mouth opening and lateral excursions that are taking place. Do they have normal mouth opening and normal function? Looking at deviations that are taking place. Now, actually, when it comes to things that are contraindicating our treatment, it's a history of TMD and a current and active pain for patients. The relationship between the two has not been shown to be clear between orthodontic tooth movement and TMD. But what we do know, for patients going through any acute TMD symptoms, it is not wise to carry out orthodontic treatment at that stage. Now, if that then resolves, they're in remission, and actually they're on top of their pain and management symptoms, we have a diagnosis. Once they have cleared that time, actually orthodontic and anterior alignment can take place, but not in the acute phase. And when I mentioned to patients who have had a history of TMD, I'll say, great, it's cool, we've got it all sorted now, you're in a good place, we can start it. But if it does re-emerge during your treatment, we will take a bit of a holiday with your aligners. We'll wear them just as retainers over a period of 4 to 6 weeks to let you get back on top of it, because orthodontics can exacerbate it if it is present. Want to use a ruler to assess the mouth opening. Now, the key questions that tend to come out is, can orthodontic treatment be used to treat TMD? And the answer to the question is, there is no strong evidence to support that. There is contradictory evidence, but there isn't anything that says if you do this, you will resolve a patient's TMD from an orthodontic perspective. Can orthodontic treatment cause TMD? So these aren't patients who are in the acute phase, these are just the average patient without a history of TMD. And the answer to the question is no. We know that TMD is prevalent in the population, and the patients who have had orthodontic treatment or are having orthodontic treatment, the prevalence is the same as it is in the population. So there isn't a cause and effect to it. Cool. Radiographs. Are radiographs required? And I think this ends up being a grey area again, I'm afraid. It kind of suits TMD, I think. TMD and radiographs go together. So let me clarify when it comes to taking radiographs. For nearly all patients, I will take an OPG. However, when we look at the guidelines here from the British Orthodontic Society, it states in healthy patients with healthy dentition, orthodontic treatment may be carried out without the need for radiographs. Okay, so why am I saying something different to it? Well, let me explain. Also, the guidelines go on to say radiographs are only justified after clinical examination when there's a net benefit to patients. Well, let's see. Well, what are the justifications for taking a radiograph? Caries, restorations, there's a pathological component to it. Any history of trauma and a history of any form of orthodontic appliances. We mentioned right at the beginning, orthodontic appliances do cause iatrogenic effects. They do cause some form of damage and harm. So we need to assess that. And it usually relates to the roots, so we need to take an X-ray for it. Now, suspicion of root resorption is the key component for me to assess whether or not it's safe to carry out orthodontic treatment on these patients. Now, in those categories, we can see that most patients will fall into something at some stage. So for me, I feel it's a likelihood that patients will have a radiograph taken. And I tend to stick to OPGs. Now, there are good points and bad points about OPGs, but the main reason for me, it gives us a global view. When we're using our aligners, we may just be moving the anterior teeth. However, the aligner is going to go into all of the teeth. So if there is something going on, I want to know about it. And this gives me that global view. When it comes to then seeing some root resorptional, sorry, let me start again. When it comes to looking at incisor teeth, they may not show on the OPG. I really want to assess the root status of these guys. Now, 40% of patients who are coming now for adult orthodontic treatment have had orthodontic treatment in the past. So it's incumbent upon us to investigate these incisors specifically to see if there's any root resorption. So this is what I typically do. I will take an OPG. If I can see the central incisors and it comes out well, I go, fine, I've made my assessment. If it's grey and unclear, like it is on this OPG, I will then take periapicals of the upper 2 to 2 and also the lower 2 to 2. And what am I looking for? I'm looking for a root resorption. I'm looking for a reduction in root length. I'm looking for a change to the root shape. Is it blunt at the end? Is it no longer following the typical anatomy that we see? So here's a case, and Biju kindly shared this radiograph with me. We can see the lower incisors. As we get close to it, there's a massive amounts of root resorption of those lower incisors. And this is now going to be a contraindication for us to carry out any form of aligner treatment on this patient. Again, it doesn't mean it's a no forever for these patients, but it means it should be handled in a way where there's control of forces taking place and someone's had further experience in managing these patients. And sometimes I will treat patients with this level of root resorption, but it's usually in a multidisciplinary environment where I've also planned for the loss of those teeth and we've got a plan in place as to what we're going to do if and when those guys fall out. So in summary, guys, as to what to avoid. Now, there's not much on this list. We've been through a whole host of orthodontic parameters, of dental health parameters, and actually we've only got a list of the 7 to avoid. Are severe bites, severe deep bites, severe crowding, complex cross bites. We're going to avoid doing IPR, planning IPR on square and conical shaped teeth. Any form of active disease, TMD, and patients who've got root resorption. Cool. Guys, I'm going to pause there. So I appreciate I've been rabbiting on for some time now. We will bring the break in now. And if we can get you guys back in, say, 15 minutes, Biju, if that works out okay?
Yeah, that's great, actually. Yeah, so we'll take a 15-minute break. And then what we'll do is maybe just before we start, Farooq, there's a few questions which might be good to cover at this stage. So we can do that for 5 or 10 minutes before we start the next section. That's okay.
Perfect. So 11:15.
Yeah, if everyone comes to back around about 11:15, that'd be great. Thanks a lot. Right. So are you okay for a few minutes just to go over
Yeah, let's do it.
answers pertaining to that first section? Can you hear me?
I can hear you well, Biju.
Yeah, you okay to go over the Q&As now, yes?
Let's do that. Let's do it. I think it's great. Let's make it dynamic so people do. Sorry, guys, please do ask questions going along. We'll aggregate them and then Biju will find the right time to ask them. So please do.
Right. So from Poonam, how do we predict changes in overjet or overbite if both central incisors are at different proclinations?
That is a question which is a great one, but that comes down to our planning as the clinician. So we have to then decide. We've got, essentially we're describing this environment, this situation. We've got two incisors at different overjets and therefore overbites and at different angles. So actually, do we bring them both into the middle, which we'll see some case setups of? Do we bring them all forwards or do we bring them both backwards? And partly that decision-making process is based around some of the other occlusal factors. We will determine that information clinically and we'll write to the laboratory, please retrocline both incisors to match the upper right one to the left one or vice versa. So that decision actually is down to what we want to achieve. Now, some of those are more complex movements if you want to significantly change an overjet. Some of them are slightly easier movements. But yes, if we are wanting to find out where those incisors lie, the reality is that we will choose that ourselves as the clinician. And I think the good thing about the laboratory is that we can then ask the laboratory to do the setup. We can then ask for another setup if we wanted to change that. Now, there are some costs involved with that process. But for me, at the same time, I feel as though being visual, sorry, trying to find the right words, with the patient is great for them, but also for us from a planning perspective. We can see what outcomes we're going towards, and we can see if we are then delivering it. So I think it falls in two ballparks there, as to one, do we make the one is that where are we going to move the teeth to, and the second thing is, well, let's see it so we can think if it's the right thing or not. And it gives ourselves the opportunity, which is why I like aligners, because you have the planning stage, which is quite involved, but actually you can change it and alter it as you please. And then when you're happy with it, then go ahead. So yeah, that would be the answer to the question, is that you are the person who decides that.
Great. From Buran, is a recent history of chronic periodontal disease that is now controlled and stable an area to avoid?
Yeah, so the answer off the bat is, as long as there's no significant bone loss, then that's fine. And you're happy that it is stable with respect to the periodontal probing depth. So as long as you're getting less than 5 millimeters in your depth, and there's obviously no bleeding and probing, and plaque scores and bleeding scores are low, then it's all good to go ahead. Well, the challenge comes is if there has been significant bone loss, that does start to change some of the biomechanics of the equation, and essentially we need to put much lighter forces on those teeth. They are the cases. Again, I'll put forward to the forum, I'd get Biju's input and the clinical input from CFAST to then say, okay, well, what can we do to try and make these forces lighter on these teeth? And if they've had over 50 to 60% of bone loss, then really that's a case to then think about referring on. That then needs to be managed in an environment where there is some periodontal support along the way, but also the orthodontic biomechanics needs to be altered as well.
That's great. Interestingly enough, we had a case just this week where John and I, John's just on. John is the manager at the lab, so I've just made John a panelist, so we'll hear from John later. But we had a case earlier this week where one of the dentists did want to exert slightly lighter forces on the tooth, so we adapted the aligner treatment for that. So slightly less movement per aligner, and so that's something that certainly we can do. Question here from Sifakur and from Shoaib, similar sort of questions. Can we take periapicals instead of an OPT? And I was told we need radiographs of all teeth, as you can't guarantee you won't move posterior teeth at all.
Yeah, so I mean, I'm going to give my thoughts on this, and then Biju, I really value your thoughts. So for me, I don't think one can replace the other. One of the challenges with periapicals is that unless you're being really reproducible at which position you're putting them on, any sequential ones may not be at the exact same angle, but also you're absolutely right, you miss out some teeth. And orthodontic forces, when we're using aligners, are on all of the teeth. And if we're planning not to move certain teeth, there's a slight difference in process. Essentially, when you move one tooth, there is a force across the entire aligner, although it may be very small. So that assessment still needs to take place. Are these teeth ones which are healthy and safe enough to have orthodontic forces? We need to look at their root status, the bone support which is there. So for me, an OPG allows me to have that global view. But don't get me wrong, I won't never take an a periapical. For my OPG, if the center incisors, for example, aren't quite clear, or there's something fishy which I'm suspecting on a periodontal pocket on a lower 6, I will then supplement it with periapicals. So that's my approach, OPG and then plus or minus periapicals. What's your thoughts on it, Biju?
Yeah, that's exactly what I would say as well. The main problem that most of us have with OPGs is the anterior teeth, the incisors, because quite often you get superimposition of the spine there, and you just can't see the apices of those teeth. So it depends on the quality of your OPGs. If that area is unclear, then go back and take periapicals. Because that's the area more often than not where you have root resorption in patients that have had orthodontic treatment in the past or trauma. So you really want to be clear at the anterior region, and that's the region more often than not that OPGs don't show up. So I'm exactly the same as you. Luckily, I work in a practice where they're very good OPGs, and I can see that area clearly. But even then, sometimes we have a nurse who takes our OPGs. She gets the angle sometimes wrong, and you miss out some important areas. So yeah, use OPGs as a starting point and then take periapicals as and when. And again, just following on from that, from Shoaib, he said, is it justified to take full mouth periapicals if you don't have access to an OPD?
I'm not too sure about that one, Biju, because of the radiation dose which is there. I'm not too sure. What's your thoughts on it?
Well, interestingly enough, I work in a couple of practices, and one practice does have an OPG, the other one doesn't have an OPG, and where we don't have the OPG, I refer to a place or, near the practice that does OPGs, and there's lots of centres like that. So I still prefer OPG over full mouth periapicals.
Yeah, and I'm the same. One practice I work in doesn't have an OPG. I will send it to a local orthodontic practice, which has an NHS contract, quite a large one, and then they'll take the OPG for me. So I think there's always ways to access an OPG, and I perhaps wouldn't go for full mouth periapicals as my first port of call. I think I would still stick to the OPG. And again, it perhaps features as part of that conversation to have with colleagues. If you wish to show them you're querying something, it's far easier to read and understand when you have relative bone heights and root levels for cases. So yeah, I think about referring out like Biju does.
Yeah. Is intrusion and alignment of supraerupted teeth achievable?
Yes and no. So the question comes down to how many teeth are supraerupted and how much intrusion is required. What I would say is that when we looked at the table about what's predictable and what isn't, intrusion featured reasonably high, but it's all within an envelope of amount of tooth movement that takes place as well. So for example, if you're going to try and intrude a supraerupted upper right 6 where there's no opposing tooth, that's quite a difficult movement to do. The 6 has got very large roots, adjacent teeth have much smaller roots. So then there's question marks over how we're going to then deliver that. So that is one to query, and I would take some records, I would send them in and get some more clinical input. For example, if it's one lower central incisor, which is supraerupted, actually that's really easy to then predictably do. Adjacent teeth are really big, adjacent teeth are quite large, and you've got lots of posterior teeth as well. So then we start to go down a, well, yes and no question, and I would get some clinical input at that stage to it.
And I suppose similar to that then, I'm not sure if you're going to cover this later or not, but so what about anterior open bites?
Oh, okay. So actually I didn't feature anterior open bites in this, so maybe that's something for me to then consider, but anterior open bites are always question mark cases. So aligners have a nature to them, which actually lends themselves quite nicely to anterior open bite cases. Perhaps the reason why we haven't featured it too highly is because anterior open bite cases aren't that common to come across as well. So today we're hopefully giving you the building blocks to deal with the majority of cases. With the anterior open bite cases, as I've perhaps alluded to with the supraeruption as well, is that it comes down to the amount of movement you're planning to do, and also which teeth are involved in the process. So perhaps I'll probably try and dig out some photos. Yeah. We've treated some AOB cases really quite nicely, and some of them are really simple. Actually, some of them are more complex, where again, I'll probably think about referring on or getting some further training before attempting them. But yeah, let me see if I can dig something out at the end for that.
Actually, let me just share my screen, because this is a case we finished last year, actually, which is quite a good one, just to show you what can be done. Again, it sort of depends on the type of anterior open bite as well. If it's a more of a dental open bite, that's obviously going to be easier than a skeletal open bite. But can you see that screen there?
Yeah, we can see that.
So this was, I didn't think we'd get that good a result, but it just shows you what can be done in certain cases. But you've just got to differentiate the type of open bite as well. This is also hugely unstable, so especially if there's a tongue thrust happening there. So again, indefinite retention, both fixed and removable. But yeah, it can be done. It depends on sort of the etiology of the open bite.
I think that's one of the things with AOBs, because they aren't that frequent and they do vary in what the cause of it is. It becomes very difficult to say, okay, we'll do this and we'll resolve the AOB. And I think that's one where we've got to investigate things a bit further, get some more clinical input into it before we make the decision yes or no. Whereas I feel sometimes when it comes to deep bite cases and increased overjets, we generally have a kind of protocol in place for those cases. They're more common, and actually the etiology seems to be relatively similar. But AOBs, yeah, I put them into the grey category until I've got more information.
Absolutely. Is there an age limit for expansion?
Oh, not that I've limited myself to. So yeah, I mean, I've got a patient at the moment who's in her 70s. We're doing some aligner treatment for her, and it involves some expansion. So there's no limits. I think if I can try and piece of perhaps why the question came out is that expansion takes place in two ways. It's either dental expansion, where we are tipping the teeth, as I put down in one of the slides, or expansion where we try and bodily move the teeth. Now this latter, the latter option of bodily moving the teeth is an orthodontic unicorn. To be able to do that is great, but actually it's quite difficult to achieve, specifically in the adult population. So once you've got skeletal maturity, say the age of 15, 16 plus, it's very difficult to achieve bodily movement. It's more than likely going to be tipping movements that take place. And tipping movements are relatively predictable. The question then comes, is it safe to do that? So we mentioned about gingival biotypes, right? So we've got to make sure that assessment takes place, not just for the low incisors, but also for the teeth we are expanding on. And if they've got recession defects already, actually it may be clinically possible, but it may not be the best interest of the patient.
Great. Are we okay for one or two more?
Yes, let's do it.
So from Chi then, we have a question. Quite often we see patients who have extremely proclined, crooked and crowded teeth. Would they benefit by orthodontic treatment before going for gingival recession correction? And when should one be careful in taking these cases, i.e. the amount of recession?
Yeah, so when it comes to the amount of recession, I generally have a rule of thumb is if it's 3 millimeters plus, then we need to get the periodontist involved. We need to have a more detailed conversation about what we're going to do. Now I work in two separate environments. So one is a specialist referral practice. So I'm spoiled there. I will refer to the periodontist, and more often than not, we will do some form of observing and maintenance treatment. Actually, very few cases, we will then have a graft taking place beforehand, and then I'll carry out the orthodontic treatment. So that tends to be my ballpark figure, if it's 3 millimeters or more. Now, it also depends on what tooth movement we're planning as well. So if we're planning to, they're already proclined, we're planning to procline them further for a reason, we are risking that gingival biotype there and the recession defect getting worse. But actually, if we're planning to bring the teeth back through IPR or extraction therapy or something of that nature, we're only ever going to improve things. We shouldn't really be able to make things worse at that stage. So it depends on two categories there, the amount of recession and so forth, but also the planned tooth movement in the case.
Yeah. I think a lot of the other questions, I think you're going to answer in the next section. So should we carry on?
Perfect.
Okay.
Perfect. Let me get my screen share back on. Cool, Biju. You okay seeing that?
Yeah, that's fine.
Great, guys. So we're going to go through case submission, and then we're going to look at an actual case. We're also going to look at records and consent, and then we'll stop for lunch. So that's going to be the plan for this section. So here we have the CFAST submission form when it comes to clear aligners. Now we can see here there's some information there about the different types of teeth to align, whether it's going to be 2 to 2, 3 to 3, and 5 to 5, and also the pricing structures there as well. The key bit from my side is what we're going to tell the laboratory. How are we going to convey information to them? Oh, so let me just grab my laser here. What are we going to populate here? We've got this massive box and there's information that we want to put into it. So this is the acronym I like to use, which is SLAM, which is also a dedication to the 90s pop band 5 and their classic hit Slam Dunk the Funk. So how are we going to piece this together? So we're going to look at SLAM. So S is for space, L is for limitations, and we're going to look at attachments and tooth movement. So when we're starting off, the biggest thing is about space. We described the 3 methods already about IPR, proclination, and expansion. And I tend to be very clear in the terminology that I'm going to use for it. For IPR, I'm going to say I want all my space requirements to be resolved through IPR, or mostly, or minimally, or no IPR at all. And we'll see a case which has the nil in. I'll also specify which teeth. We spoke about assessing the tooth shape in our assessment form. And actually, if the low incisors, for example, are conical, actually I'm going to say no IPR on the low incisors, move it to the canine teeth. Conversely, if they're quite triangular, I want to try and focus in on those teeth. So please carry an IPR lower 2 to 2, upper 2 to 2, which tends to be the majority of my cases. Proclination. Again, I'm going to use the same terminology. Do I want the space requirements resolved through proclining the teeth? Actually, I want to have little proclination or nil. Now, generally, if I'm not planning to do any significant proclination to manage my space, I generally tend to tick the box for minimal. and just lets the lab have some leeway to move the teeth a little bit in that direction, so they have some allowances for it. And expansion, the exact same process. So that's space. Next, we're going to go into limitations. Now, here are the 5 key occlusal parameters that we've gone through in our assessment. And I'm going to convey to the laboratory what I want to have happen to the occlusion. So, for example, for the overjet, we're going to say correct the overjet by 1 millimeter, for example, if it's increased. When it comes to getting things not 100% correct, say the overjet is 9 millimeters, I'm going to improve it by 1 or 2 millimeters. I'll say improve the overjet by 2 millimeters. And then the lab know they don't need to get that 9 millimeter overjet down to the average of 2 millimeters. They only need to change it by 2 millimeters. Buccal segments. Typically, buccal segments, we will be maintaining them. They're starting off class 1, even potentially class 2 or class 3. But because we're focusing on anterior alignment, I don't want the laboratory to change that buccal segment relationship. So I want to maintain it. When it comes to centerline, I tend to take different outlooks to the upper and the lower. For the upper centerline, if it's in the mid face, I want to ensure it's maintained. For the lower centerline, I'll usually say accept. Now, there's a difference for those terms. For maintain, it is to keep it where it is. So if in the alignment of the teeth, the upper centerline was to move to one side or the other, the laboratory would carry out IPR to ensure it stays where it is. For the lower centerline, there is no real aesthetic consequence to the lower centerline moving to one side or the other side. And I've got some clinical cases will show where that's taken place. So I generally say for the lower centerline, accept wherever it goes, either to the left or to the right hand side. Same when it comes to cross bites. Now, when it comes to the A in SLAM, it's about attachments. Are there teeth that I don't want the lab to put attachments onto? And they usually tend to be teeth which are heavily restored through either have bridges or implants on, things that can be difficult to put attachments onto. A movement. Which teeth do I not want the laboratory to move at all? And again, it tends to be localized to teeth with implants on or with bridges. Dentition of implant restorations or bridges. Cool, so we're going to go through the case setup. So this is our case. Here are our clinical photos, and now we're going to break down the SLAM details for this particular case. So we're going to start off looking at space. Now for IPR, I've written down here mostly upper and lower, and it's 3 to 3. We're going to look at the other components as well, but let's start off focusing on IPR. Now, one of the things with IPR is that for class 1 cases, typically the main way we want to treat this case is through IPR. And I'll draw the analogy between taking a conformist approach to occlusion in our restorations and restorative work and taking a reorganized approach. When we carry out IPR, we are essentially keeping the teeth in the soft tissue envelope where they are. We are straightening them up, but essentially in the soft tissue envelope, both labial and lingual, they are staying in that position. That is the most stable position for teeth to be in. Now, when we start moving teeth backwards and forwards, proclination, expansion, we are now starting to change that soft tissue envelope around those particular teeth. So tip is class 1 cases, default is to stick to IPR. Now, when it comes to when it comes to proclination, so when it comes to proclining the upper incisors, we've got no real need to procline them. The patient's already a class 1 case, as we saw from our assessment. So we want to keep the upper incisors relatively where they are. We've gone for minimal changes to it. The lowers, we've got to make a decision because these 3 low incisors occupying different positions in a labiolingual fashion. So we've got to choose where we want that to be. How do we make that decision? Well, if we were to draw a line to essentially connect the teeth, then we can see, well, where is the average line for these particular teeth? We can see that it's midway between the lower left one and the lower right one. So that's what we'll communicate to the laboratory. Can we please have the lower incisors proclined? So they're midway between those 2 teeth. That will retrocline the lower left one, it will procline the lower right one, and they'll meet in that midway point. Expansion. There's no cross bites in this case, so therefore it's going to be minimal changes in the expansion setting. Great. Next, we're going to have a look at some of our occlusal limitations. So here we've gone for overjet, and I've put down here maintained the mesial of the upper left one. Now, Farooq, you said the overjet was average for this case, so why have you now written something which looks reasonably involved? I just want to clarify why. When communicating the laboratory, if we say maintain the average overjet and the upper incisors are crowded, on some teeth the overjet will be slightly increased, other teeth the overjet will be average. So I now want to communicate a landmark that the laboratory and I will agree on as to what's taking place with the overjet. So here we go. We're looking at this patient now. If we look at the mesial of the upper left one, that's where the overjet is average. If we look to the distal side of the upper left one, actually the overjet looks quite large between the upper incisor and the lower incisor labial face. So I've simply told the lab now it's the mesial aspect of that upper left one, and we both know that it's going to be maintained to the average degree. When it comes to the overbite, so more often than not, a deep overbite is attributed to the lower incisors over-erupting. So here we want to resolve that through intruding the lower incisors to resolve this patient's mildly increased deep bite. Now the patient has got differences here in the gingival zenith of the upper arch. Now this is a good time point. Before anything's been submitted, I tend to get the photos up and I'll show the patient their gingival heights. And it tends to be a conversation around that, and also restorative work as well for wear. And I'll say, well, is this something that you wish to have addressed? And if it's something that they do, we then start talking about having some periodontal surgery potentially at the end of the orthodontic treatment. Buccal segments, they're class 1. We want to maintain those segments. Center line, okay, so this is what I was being a bit pernickety on. So I want to maintain the upper center line for this patient. I don't want it to move. It's got to stay where it is. It's in the mid of the face. The lower, I'm happy for it to move. And you might say, well, Farooq, why don't you just maintain it? If you're going to maintain the upper, just maintain the lower. My rationale behind it is to maintain a center line, to maintain any feature. If there's some crowding, usually warrants having more IPR take place, more space requirements. So I want to limit the amount of that I need to do, so I'll accept it. Not of any aesthetic consequence, of no functional consequence. Cross bites, there are none, so there's nothing to populate for that bit. There's no restrictions on the teeth. We've got no crown, bridge, implant work, and there's no teeth that don't need to be moved. Right, let's have a look at the online setup for this case. So I'm now going to, in a very slick fashion, transition into the web browser. So if I say it's positive, then it will hopefully come across that I'm not fumbling like I actually am. Perfect. Biju, can I just check you can see that?
Yep, that's fine.
Great. No, sorry. That is the wrong one. Still very slick though, guys. I hope you guys can appreciate how slick it is.
On the recording, it'll be phenomenal.
Yeah. Cool, Biju, can I just check you are now seeing a setup?
Yes, it's just uploading that. Yep, perfect.
Right, perfect. Okay, cool, guys. So I'm just going to go through this setup here with CFAS. So one, it's great that it's a digital setup here. There's a link that you guys get given to your setups, which you can also share with patients as well. So it's really quite nice. Now there's a whole host of companies that do aligners, as you guys will be aware. And there's different online setups. Some of them are quite involved, and I feel as though for most cases there's information which you don't need and makes it a bit challenging to read, and some which are really too simple. It's just a click and a play, and you don't really get to manipulate, change things, and get some more information from it. I think they've got a really good balance here with CFAS. I know it's been developed over time as well, to give a bit more information, so to give the right information. So credit to you guys. Great. So I'm going to talk you through what we're seeing here, the details on the right hand side, and then we'll look at the actual movements of the teeth that are planned as well. So the right hand side, very simply, it's just orientating ourselves. We get the upper and lower arches together. We can separate the arches to read them individually as well. Hide the gingiva. Now this scares me when the gingiva gets hidden, so I never tend to do this. So I put it back on, so I feel as though it's a patient's mouth. Then we've got attachments. So attachments here show where the bits of glue have been put on. Now, I like the fact that we've gone for blue in the color here. Sometimes the companies go for a clear color. It's not particularly easy to see from the image. And actually you want to show your patients, I want to see where they are. I don't want to make a mistake that I don't realize they're there. But also patients, when we're counseling them about their case, they need to know where the attachments are going to get on. I don't think we want to try and hide it from them. I also then complement this with a picture of showing them inside the mouth so they know that it is a clear image. Next, we've got IPR. So IPR here is what the laboratory have worked out where the IPR needs to take place. Now, when we hover over one of the details, it will tell us when the IPR needs to be done. So it says 0.2 before aligner 1 and 0.1 millimeter before aligner 3. Now we can digress from that. We can do all of it at aligner 1. As long as it's done by aligner 2, then we are okay. So that's the information that we're getting from IPR. We've got an occlusogram if you want to investigate what's going on with the occlusion. So if I can separate the arches, and we can see the contact points that are taking place. Not something I use that often, if I'm honest. And we can also now start to quantify things. And again, I think some of the simpler setups from the other companies don't necessarily have this information, but we can get a grid setup so we can now look at things and look at things moving relative to these lines. So for example, if we want to see a center line move, we've now got a vertical line to use as reference. And also we can measure things, which is also quite a powerful tool to have. We're then able to look at measurements between teeth and incisors and get some more information as and when we need it. So I like those features.
If I can just come in there, just regarding this treatment setup, because it's all web-based, you don't actually have to download any software. You can actually send the link to the patient, so the patient can actually view this themselves. So it's quite good having this web-based treatment setup as opposed to having downloading software. If you do send it, share it with the patient. Just let the patient know that the attachments are not blue. They're tooth colored. I did have a patient a few months ago that said they didn't want to go ahead because they weren't too happy with the blue attachments. And also with the IPR, you can see it on here, but you also do get a separate sheet that comes with all the lab work that details when and where to do the IPR. And I often use that, the IPR sheet. I sort of circle and tick off when I've done the IPR. So that just keeps me right as well. So sorry, just a few things I wanted to mention.
Yeah, and Biju, I mean, this is it. This is it. Two clinicians who do something similar. I'm the same. I'll always use the paperwork, and that's clinically when I'm doing the IPR, I will always tick it off there. And I think that's the most robust way of doing it. That's great. It's great we do the same thing. So if I can now go and show you the orientations. So we look at the front, we look from the buccal segments as well, left or right. We can also look from the inside as well. And that's really useful when it comes to looking at the whether it's complete or incomplete with the deep bite. So if we have a look again from the beginning, we've got our orientations now. We're just going to click play down here. And what we're seeing are the teeth aligning. Now, each one of these numbers here indicates a different aligner. So we've got 10 aligners for the top, and we've got 15 aligners down here for the bottom. When these case setups come, and I remember when I got my first case setup, I was looking at it, I thought, well, that's great. It's straight in the teeth. What do you want me to do about this now? How do I interact with this? But we've gone through our SLAM, so we've been pretty clear as to what tooth movements we want to take place. And part of the interaction now with this online setup is to ensure that that is being delivered. Also, if we now want to change or tweak something, we can now do that. So it's not that, oh, I've signed it off, I've taken my impressions and scan. It's in the system now. Oh, we still have opportunities to modify and change it. So if we start off by looking at the lower arch. Great. So we're looking at the lower arch here, and we're looking at these teeth aligning. So if we go back to our SLAM, we wanted most of our space requirements in the lower arch, if you recall, to be carried out through interproximal reduction. So let's have a look at that. So we'll get our IPR on. I'm just going to zoom out just a bit. So we can see the IPR has been carried out here, lower 3 to 3 as we prescribed. Now, aggregating these numbers together adds up to about 2.5 millimeters. Now, the amount of crowding we had in the lower arch with our contact points overlapping was 4 millimeters. So we can see most of our space requirements are being met through the IPR on the lower arch. Next, we looked at proclination, which is a key aspect of this case, is that the lower 3 incisors were essentially in different positions. And we asked the laboratory to go midway between the 2 lower incisors. Okay, so we go from there to there. It looks about right, but that's not good enough, is it really, to say it looks about right? Which is why we've got this wonderful feature, which is superimposition. Now, what purple is showing us is where the teeth started, and what is white at the end is showing us where the teeth have finished. So if I can just get you guys to focus in on those lower incisors, we can see the lower left one has retroclined a little bit, the lower right one has come forwards, and they've essentially met in the midpoint of those two. It's exactly what we prescribed. What's also useful to note is that back teeth have remained purple, and that's showing us that there's no movement taking place posteriorly. We wanted to maintain our buccal segments. We didn't want any real expansion in the buccal segments either. They've done what we've asked them to do for these low incisors. Cool. Let's now have a look at the upper incisors. Grand. So we've got a reasonable amount of IPR there. Notice we had less space requirements in the upper arch of about 2 millimeters. And we can watch these teeth then align. Now, I think one of the questions we had earlier on was about, well, what happens if the upper incisors are in different positions? Well, actually, we could have done 2 setups here. If we look at those central incisors, they're rotated mesopalatally. So now to correct their alignment, the distal aspect of the tooth has been rotated palatally. We could have also corrected these incisors by rotating the mesial aspect labially. So there's 2 ways we could have moved these teeth. Now, of course, we know that the overjet is average on the mesial aspect of the upper left one. So it's key to keep that guy where it is and rotate the distal aspect back. If we'd done it the other way, we would have increased the overjet. So I think it's so important that that assessment takes place and we're very precise when it comes to asking what we want. Now, again, if we and you go, well, that sounds like it's going to be quite a challenge to do and I'm not 100% sure about the assessments, that's okay. Because at this stage, we can look to see, well, what's actually happened to the occlusion? Let's see how things are. So if I can now orientate you guys, that's the beginning. Occlusogram, let's switch that off, too many colors for me. And we can look at things at the end. I'm going to switch the superimposition off just to try and make this a bit simpler. Cool. So we're looking at the end outcome of the occlusal relationship. Now, if we go to the beginning, we can see the increased overjet on the distal aspect, the overjet's average on the mesial side. And at the end, we can see now the distal aspect is the same as the mesial side. We've got this nice even overjet taking place. Assessing a case for me now, very much looking at the occlusal outcomes of what the lab has planned are key to it. Now, if, for example, the overjet was increased at this stage, I'd simply write an email back to the laboratory saying, guys, the overjet's a bit increased. Can we reduce that, please? And there we go. We resolved a potential issue that could come further down the line. Cool. And if I now just look at the front, the last bits I wanted to go through. So we've spoken about the overjet. Now I want to speak about the other limitations, which are the overbite. So if we bring these 2 guys together and look at the front. So the overbite is mildly increased and we decided we want to intrude the low incisors. That's the most common way it happens. Now at the end, the overbite is average. But let's see how that's happened. It's one thing to watch it, it's one thing to know how it's happened. So if we switch the superimposition feature on here, we can see at the end, we have intruded these low incisors. Recall purple is where they start, white is where they finished. Great, we've intruded the low incisors. That's how we wanted to resolve that. Now, when it came to looking at the center lines, we wanted to maintain the upper center line. We were happy for the lower center line to move. So let's have a look. So the upper center line, and let's put the grid feature on here. We can see that actually there's no real change taking place to the upper incisors, and the lower incisors move slightly to the left side. Nothing significant, but that's fine. When it comes to looking at the buccal segments, we can see that we've maintained the buccal segments. So if we look at the left side, let's look at the right side. Let's look at the right side, we can see there's been no changes taking place there. Great. So what have we done for this case? Well, we've carried out anterior tooth alignment. We've made no significant changes to the buccal segments. We've improved the overbite, and that's what we've done for this case. Great. I'm going to stop there with this one and go back. Equally as slick as the first time, I think this will be. Potentially slicker, I don't know if it's possible, to the presentation. Biju, can you see my presentation?
Yes, you're back on.
Okay, fantastic, thank you. So that was our case. Now I'm going to go through consent. Sorry. Now we're going to go through some bits and bobs about consent, and then we'll go through records to conclude with at that stage, just before lunch. Oh. Great. So consent. Now, we appreciate the value of consent when it comes to our conventional planning for our dental treatments, but orthodontics also features in that as a process. What tends to be slightly different to general dentistry here is that there are some options which we are not going to be exploring with this, we are not going to be committing to this patient for treatment. However, it's incumbent upon us to still describe and mention them in detail. So what are the treatment options for the average case? Well, there's comprehensive treatment, and that is typically orthodontic treatment where we are changing the occlusion, improving it, but also we've got a difference in duration. Now here I've put down 6 to 24 months, and that's because when I talk to some of my general dental practitioner colleagues, they describe comprehensive treatment as taking 24 months and involving 4 teeth to be taken out. That's not always the case. I think we don't pog all orthodontists into that same camp because it depends on the complexity of the case, right? What I can say is comprehensive treatment usually involves some more complex mechanics, potentially elastics, extractions, potentially surgery. There are more things which are involved. The duration can be questioned as to how long it's going to take. Then we move on to the limited objectives orthodontic treatment, which is what we're describing today, where we essentially accept the occlusion. We carry anterior alignment. Now, question marks, is it shorter here? And that's because there can be this drive to try and get things done as quickly as possible, but there are biological limitations to it. For me, no patient will ever receive treatment shorter than 6 months, because to get a good result where we've got full alignment, it does take some time. That will be the limited time for patients. Now, it's always important to go back to the, I would say, the salient advice to all dental treatments is to under-promise and to over-deliver. And timing is the biggest factor for patients when they are undergoing orthodontic treatment. So adding on time is the key side to it. Limited objectives usually involves non-extraction and it's less complex treatment. Now, what I'd like to do here is just express how I would wish patients to have this information. So, for example, I restore bridges. Now, a patient comes in and they've got a gap in their mouth. I'm going to talk to them about having implants done. Now, it would be, I'm not going to place implants, and perhaps few of us do. And some more of us may restore that implant. And then some of us, most of us, will probably provide bridges for patients. So there are 3 things there, but actually I may only be able to deliver one of those, but actually I'll still talk to the patient about an implant going in, what the process involves, restoring it, and also having a bridge. And if they wish to go for the implant, great, I'll pass them over to the people who will deal with that. If they want to have a bridge, great, they're back with me to have that done. Now, again, I think the idea is, from my side, is to put across that those should be given as equal options to the patient. And then as they choose what they wish to do. Now, I got caught out the other day where there was a patient who came in, he was a bloke, not particularly well kempt, and he said, I'm concerned about my lower front tooth. And he was pointing at the wrong one. So he didn't really come across that bothered. And he had a malocclusion as well, and I gave him options just to have anterior alignment take place to the lower teeth. And I also spoke to him about comprehensive treatment involving some teeth out and having some treatment for that, that golden 24 months, which orthodontics is. And he went away, and I said, well, he's definitely not going to be interested in comprehensive treatment. And he came back and he wanted to go for the full shebang and have 4 teeth out and go for lingual braces. So, I mean, it was really involved. And considering how he came across and what he described as his concerns, didn't quite seem to match that. And I think it's important to give patients that information. They have also the rights to change their mind and to reflect and think and Google and do the bits and bobs. So I think it's important to describe the comprehensive option. But also, of course, limited objectives need to be described in the details that we have. The last but never the least is to have no treatment. And it's important when patients come in, and typically the adult patient may come in and say, well, actually my lower incisors were straight when I was younger, they're getting crooked now, and I'm worried about them becoming more crooked. An option of no treatment, it's got to be clear to the patient that that process is going to continue. And in low incisors specifically, the late low incisor crowding phenomenon will continue throughout life for patients. They will become more crooked. Now, I don't like to sit on the salesman's chair and say, therefore do this or else. But I will tell patients, if you're happy with them now and don't want them to change, we can make you a retainer. It will keep it as it is, gives you time. And or we can correct it now, give you a retainer so in future it doesn't change any further. Now, I appreciate that we wish to try and get more and more patients in treatment, but actually those guys who do go for the lower retainers, I find will come back and have treatment at a later on stage, just from my own experience. And I feel that there is that goodwill that gets built up through actually saying the best thing for you, if you don't really want to do this, is not to do it. And then patients do impart trust to you when it comes to your clinical decision making. Consent. So patients need to be aware that they're going to be really active in the process of using these aligners. They're going to wear this aligner full time. Now, 22 hours doesn't say full time, but the patients need to be told it's full time. Because anything less than 24, sometimes they feel it is part time, which is 12 hours a day. There are going to be attachments that are going to be there. And again, I'll show them on their setup, but also I'll show them a clinical photo of attachments as well. They're bits of glue, they're stuck onto the teeth, they're not visible, but you'll feel them in the mouth is how I describe it. Interdental reduction, we're likely to carry IPR on your case. What is it? Well, essentially we use a coarse piece of floss to go in between the teeth to create a small amount of space to straighten them. We know that there is no damage to your teeth long-term with respect to decay, to food packing and sensitivity. Now that information that I've given you is from this particular paper. What's also to bear in mind is that doesn't mean that you can now wholesale go and do IP on all teeth. We've spoken about tooth shape. We still have to respect anatomy, and research is usually limited to a number of patients, 30 or 40, not to thousands and thousands. So we've got to apply both ideas for patients. Refinement. So when we get to the end of our aligner treatment, there's a likelihood it's going to be extended. They're going to have an extra aligner or two to be able to get the final correction done. What happens with patients when they see the stages, especially on the online setup, they think, right, exactly at number 14, I'm going to be finished. I don't have to have any more treatment after that. And I bang home to them that actually that's just the bulk of your treatment. We will still be doing some treatment after that. So they don't start a timeline which I can't meet. And retention. So Simon Littlewood, he's an orthodontist based in Yorkshire. He's done the Cochrane review on retention. And essentially what we know is that teeth will move throughout life. And retention should be a lifelong process. It's a commitment. So this comes back to our consent, right? At the beginning, we're talking to them about what happens at the end. And I now say that 50% of the journey of you having a great smile is for us to straighten your teeth. The other 50% is for you to keep them straight. And you will be doing that by looking after your retainers. How long should I wear my retainers for? As long as you want to keep your smile looking great. And that's a lifelong commitment. Let's go through the risks of braces, which I alluded to at the beginning when it comes to both fixed and aligners. Now here I've separated the two. We've got the most common risks on the left-hand side and the uncommon risks on the right-hand side. But I want to touch on them as well, so we have a clear idea in case a patient asks those questions. This information is again aggregated in the CFAS documentation when it comes to patient consent. And again, what I quite like about it, it mapped very closely to the consent form that I use, which I put together myself. So decalcification, so white spot lesions, these are commonplace. Now, if you have a look at this image, this is what I will show patients, not to put them off, but to inform them that actually it's a really significant risk to your teeth. The good news is aligners are far less likely to have this take place than fixed appliances. But even 1 to 2% means that actually it is happening on most patients, but to a very small degree. What I tell patients is that it's completely avoidable. This is not a consequence that you will have to have take place. However, your hygiene, your dental, your eating habits have to be modified to reduce the chances of this taking place. I speak to them about periodontal disease and loss of attachment. I'll show them this gross image, and again, I will say the same about decalcification. You are in control of this. Patients can avoid this. Even if patients have had historic periodontal disease, that's a question that we had, is that we know patients with significant history of periodontal disease, but stable, in their state will undergo no loss of attachment during orthodontic fixed appliance therapy. That also maps to aligners as well. However, poor oral hygiene in patients with no attachment loss will accelerate loss of attachment. So it can make the disease worse, which is why hygiene is so essential from the beginning. Now, black triangles are an aesthetic issue. So what is it? Well, it's this image on the top right-hand side. It's this black triangle, this embrasure space here where the dental papilla just hasn't grown. And that's very common to have happen when teeth are crooked. Predisposing factors are anterior teeth and triangular shaped teeth. Unfortunately, the most common areas are the upper central and lateral incisors. Now, what's interesting is that in the population, this does feature without any orthodontic treatment. It's about 15% of the population. What we know from the figures here is that around about a third of patients who have had orthodontic treatment will then leave with a black triangle. We're essentially creating this. And it's one of those factors which are present. Now, the question is, can we fix it? Can we avoid it? And the answer to the question is, it depends. If teeth are really triangle, like we can see in this bottom image, we are never going to be able to resolve that. We'll describe IPR later on, where we show a case where we can reduce the black triangle, but those are the terminologies I use very carefully with patients. I will tell them that your teeth are crooked. Their gums haven't grown fully where your teeth are crooked. When we straighten your teeth, the teeth will be perfectly straight, but unfortunately we can't regrow your gums. And I move that onto the patients, that it's the gums that haven't regrown in the area. If I'm planning to do IPR in the case, I will say we'll try and improve it and reduce the black triangle. But the likelihood is on your front teeth, there will be a black triangle left. And then show them images of black triangles on patients. And again, it sounds bad, but it's one not to avoid. And it's a bit like when we're describing comprehensive treatment. What is the worst case scenario? Well, the worst case scenario isn't that they don't take on treatment. The worst case scenario is that they do take on treatment and they come back to you after they've finished treatment and said, actually, you didn't mention to me that I could have got my overjet corrected. I now want my overjet corrected. And actually, that's not a conversation that you had with the patient. So it's very much about giving them the information. As I say, in my experience, and Biju, I wonder if I would probably hope it's the same for yourself, is that the more honest you are with patients about the options that they have and the risks that they have, the more they impart trust to you. They know you're not trying to sell them a product. They know you're trying to deliver them a healthcare service. And I think that does change how patients then trust and go with the people that they choose to go with.
Yeah.
Root resorption. So yes, Biju.
I know, I totally agree with that. Patients, at the end of the day, it's all about managing expectations. And I think if patients are unhappy with treatment, it's rarely that they're unhappy with the way you've done things clinically. It's all to do with, have you met their expectations? You know, and I think the more information you can give them up front, the better you can manage the expectations. And I'll talk a little bit about that later in the afternoon, and we'll also talk about different ways that we've developed to do consent as well. But yeah, thanks for that.
Cool, thank you, Biju. And also, what features, I think a key part of it is sending them that online setup so they can see their teeth. And what I will do is that I will send it to them, and then we'll have a conversation, usually remotely now during the consenting process, about, well, let me show you now how it looks from the side. Let me show you that the overjet is still increased. Are you okay with that? Here's an image of a patient who's also had an increased overjet at the end. Now you can see it clinically, you can see it on the setup. Do you still want to accept that limitation in your treatment? And I think that's a key part of it. And it's helping me as well explain to patients what's going on. It's difficult. It's easy to say, you're going to have an increased overjet, you're going to have class 2 buccal segments. It doesn't really translate into patient speech. So when we're looking at root resorption, so risk of it is that patients will undergo a form of external root resorption. Now, the good news is that as common as it is at 50%, it's really small. It's about 1 to 2 millimeters. The news on top of that is that when it comes to using aligners, it's much smaller. Now, smaller doesn't mean it doesn't happen. So patients have to be consented. Their roots are going to get shorter through having aligner treatment. Now, the reason why I've put down severe root resorption here at 4% is that it does take place. There are certain indicative factors. So one is short roots from the very beginning. Okay, cool. That's why we've taken our OPG from the outset. A history of trauma and previous orthodontic treatment. So for these patients, we're saying, actually, you've had orthodontic treatment before. Let's have a look at your root status. If it's really good and long, great, you're probably going to be fine. Actually, you've already had a few millimeters loss, you're probably going to have another few millimeters of loss in treatment as well. Let's bear that in mind. And then we start thinking, well, actually, what is the current root level? Do we need to now think about getting some more clinical input to managing this case, such as reducing the forces on the teeth or referring onwards? Cool. Now, relapse, again, I will speak about relapse. We've spoken about having some retention. I'll bang home that the retainers are lifelong. I'll also tell them that if they don't wear retainers, the teeth will become more crooked with time. And also describe to them the retainers that they're going to have, both bonded and removable retainers. And at the end, we'll talk you through what they look like, how we fit them, and the types of regimes we give patients with them. Unlikely risks. So TMD, we've already described as unlikely to take place with orthodontic treatment happening. And it's coincidental rather than causative from orthodontic treatment. Loss of vitality, very rare to take place. It's usually on teeth that have been previously traumatized. So I'll home in on that. Okay, you've got a knock to your upper center incisor. Cool, you may lose vitality there and have a root canal treatment. Orthodontics hasn't caused it, your trauma did. Orthodontics may accelerate the process. Discoloration of teeth, there's no evidence that aligner treatment and orthodontic treatment discolored teeth. However, patients do report their canines specifically looking darker, and I think it's to do with the attachments, the refraction of the light on the teeth. So I do mention to them, you may notice the difference in the color of your teeth. When we finish treatment, we remove the attachments, they'll be restored to where you started. Fracturing of teeth and restorations. Again, this now relates to the quality of the restoration. A tooth is going to undergo a force with orthodontic treatment. It's not going to be enough to ever damage a tooth in isolation. It has to be due to a faulty restoration. Ingestion of appliance. If they manage to ingest an aligner, I feel as though they should be studied in gross detail as to how that took place, because they really shouldn't be able to ingest an aligner. Ankylosis. Uncommon finding, but it's incidental and it's super duper annoying when it happens. I mention it in the consent forms because we've not moved these teeth. So we don't know if there is some underlying ankylosis. Extraordinarily rare to take place. It's happened 2 times in my clinical practice. I'm glad it was there in the consent form because we could refer back to it. And there are ways then to consider managing it and referring onwards for it. But at the same time, we've got to bear in mind that it's not we haven't caused it. This is the patient. You had something that we were not able to diagnose from the outset. We'll now discuss the options at this stage. Great, we're going to move on to records. So records, so we're going to start off by going through impressions. Now, both impressions and scans are accepted by the CFAS laboratory, which is great. We're going to go through impressions because I feel as though it's the basic side of it. And if you've got the impressions to fall back on, it's always a good one. I work in 2 practices. One I take impressions still, one will take scans. So it works in 2 ways. But I think it's important that we describe how impressions are taking place. So we're looking at 2-stage impressions using a silicone putty and a silicone wash. Why are we going to silicone? Why aren't we using something else? It's the same for our crown and bridge work, really. We're looking at something which is going to give us high surface detail and be rigid when we are transporting it and not going to undergo any warping. This is my preference, guys. Honeycomb, I love it. It's not the cheapest, but it works fantastically well. And I always go for the fast set, 1, because I'm impatient, 2, because it just means within 6 or 7 minutes, I've done both upper and lower impressions and we're out the door. Now, I quite like these orthodontic impression trays. I, of course, quite like orthodontics as well. So why do I like these as in comparison to the conventional trays? Well, there's a few things here that make my life easier. Now, the tray itself has got to increase depth to the tray. For our patients, they are all, relatively speaking, dentate patients. So it means we get to record all the details in and around the tooth. Also, the actual walls of the tray converge, which means that when we're taking our impression, we're far less likely to get any blows taking place. It doesn't eliminate it, but it means it's far less likely. Essentially, it makes my life much easier. So I do recommend having a look at these trays. They're available from OrthoCare, relatively simple and cheap to get a hold of. We need, in our 2-stage technique, we need to have a spacer, something that goes in between the putty and then the wash. We can buy something like Plicofol, which is really good stuff, expensive on the side, or we can use a lab bag. So actually Biju told me about this, and it works really well in practices where they don't want to make that extra expense, or essentially when I'm going to pay for it, then we'll use the lab bag. So we'll simply cut out a horseshoe shape and that will be our spacer. So let's now put this together. We're going to put our putty on our tray. We're going to use our separator, whichever one it is, the lab bag, or it's going to be the purpose-made one, and we're going to insert it. Now we're going to insert it, and I tend to, on insertion, press quite firmly, but also what I'll be doing is the excess I'll be moving posteriorly, so it's covering all of the teeth. Guys, I can't stress enough how all of the teeth have to be on the impression. If there are 7s, the distal aspect of the 7 has to be on the impression. If there's 8s, at least half of the 8 has to be on that. Why is that an issue? And I think we've got quite a good group today. So it was a question that was asked, well, tooth movements do take place in other teeth, but also if they're not covered by the tray, they can extrude, in which case they then start to change the anterior relationship, and we can create an anterior open bite, which nobody wants. So all teeth have to be on it. I insert the impression material, I then push it posteriorly so it's covering the terminal tooth. Nope. We then take off the spacer. My postgraduate at Guy's Hospital did not take off the spacer when we're taking impressions. It's not going to work, is it? And here we have that taken off. Now we can see that the tray has been extended posteriorly to cover the terminal tooth. Next, we're going to use our wash. We're going to ensure we carry out best practice. The nozzle is kept inside the impression material as it goes across. And we've got 2 minutes working time. So we've inserted a 2 minute setting time, sorry. We've inserted it, we're applying digital pressure. I tend to go for the premolar region, I'm pressing relatively firmly. I inform the patient I'm going to press firmly throughout the process and then take the impression out. Now, of course, at this stage, what are we doing now? We've taken it out, and this is part of the clinical side. We're assessing the quality of our impression. What are we looking for? Excuse me. Well, we're looking to see we've got all of the dental material. We've got all of the teeth, the terminal of the 7, can't stress it enough. We're also looking, because it's a 2-stage technique, we're looking at the color of what we're seeing. And what we want to see is a shine through. We want to see the material, the purple, shining through the wash material. It means that it's a really thin layer, which means we recorded that detail in high accuracy. If we don't, there's a lot of the orange material, for example. Wash material is never particularly robust in thickness. So therefore it will flex and it will change. And actually we haven't recorded that surface detail well. We then take a silicone bite to record. Now, what are the problems? Well, these are the common problems that take place. We tend to get drags, which do then impact upon the dental bearing area when we're using our putty. We can get drags that take place when we are inserting our wash material, and we can see the crack that's taken place here on the side. And here's what I spoke about the shine through. There's no shine through taking place here. That was not inserted with enough force, and therefore that's not going to be a good impression. Packaging wise, so we can download the free label from the CFAS website. Please do ensure that you keep the impression safe, pack it with tissue, and enclose the prescription in a separate bag. Photography.
Can I just interrupt for a minute there? I think this is a good point. This is a good place to bring in John Merchant. John, are you there? So while John's coming on screen,
I am here.
Good morning. Now, John's
Good morning, everybody.
John runs the lab side of things, and a constant bugbear of the lab is really impressions and impression techniques. So, John, maybe you can just quickly give us the lab's perspective on impressions.
Absolutely. Thank you very much, Biju. Firstly, I'd like to say we will reject impressions that are not of good enough quality. And I know that's extremely frustrating for you as practitioners because you've got to get the patient back, etc. But we only do it when we really have to, because we have to pay extra postage, we have to work the job twice, we have to pour the impressions twice into plaster. So we don't do it lightly. If we've got an impression that's marginal, we can always give you the choice. We can try and clean it up, but you do run the risk of it not fitting correctly with clear aligners. So with clear aligners, the impression has to be very accurately. But we understand that you can't always get the patient back. So we will let you take that risk if you want. But if it doesn't fit, we would have to charge again for making those trays. But we can just make the first one to try and not send you all of them, if that makes sense. With regard to the impression material, I know you all have your favourites, and I would encourage you to please take your impressions with the material that you like best. What you feel you get your best impression with is what we'd like you to use. We probably have more problems with putty and wash than most other impressions. I know that goes against the grain. The putty and wash is the gold standard, but not everyone can do it as successfully as others. So please use the impression material that you like. With the clear aligners, we are particularly fussy because it has to fit over the whole surface of every tooth. If you're having CFast fixed, you can get away with merger on the impressions. As long as it resembles teeth, we can get away with it and do you an indirect bonding setup with that, but not so much with the aligners. And obviously the intraoral scans are very accurate now. They've come on a long way in a number of years. So we do accept intraoral scans from all the major providers. We have direct links with Carestream, Medit, Itero, Trios, all the main labs. So we look forward to seeing your impression soon, guys. Thank you very much.
That's great. Thanks, John. I just wanted to, thought it was a good point to bring John in there because, like I said, impressions are, it's a common bugbear. I very much like taking putty and wash. It's my go-to. And I didn't believe John when he said that the impressions weren't great sometimes until he showed me a whole bunch of them. It's very hard. It's almost impossible for the lab to do anything with poor impressions. So if you can just sort of quality check your impressions, and if you're not particularly familiar with that two-stage technique that Farooq's mentioned, then just practice a few times, look at it, make sure you can see all the margins, because impressions for aligners is pretty much unforgiving. If it's not a good impression, we pretty much can't make the aligners, and it's a hassle for you to get the patient back in and take more impressions. So sorry, Farooq, I just thought I would mention that now.
I think it's a great time to input that information from the lab. Can I just check, are you able to see my screen changing?
Yes, I can.
Cool. I think what's interesting there, guys, is that it's a bit like a clinician who doesn't take on every case. It shows in parts that there's a rationale behind that. There's a quality behind it. And I think it's the same with the laboratory. A laboratory that doesn't accept everything, for me, is a laboratory that's annoying, but also a laboratory that are keen on their product being produced well, not on just your business. And again, it makes me feel much more confident and annoyed at the same time when that process takes place. Cool. So photography, guys, this is our last bit, and then we'll be stopping for lunch. So clinical photography. So it's not an absolute requirement when it comes to actually submitting a case, but I would state that it's an absolute requirement when carrying out any anterior alignment. It features part of our records. Consider it the same as doing a BPE. I think this is an essential component now of carrying out treatment. There's also the other side to it. There's a side where actually from a marketing perspective, we have before photos, nice after photos. It's something which features in part of our portfolio. And also there's a social media side and so on and so forth. So I think the applicability of taking photos outweighs the process of having to invest in the equipment, but also learning the process of it as well. And I've got a healthy warning light here. Cool. Can I just check you see my clinical photos?
No, we've still got your PowerPoint.
Oh, okay. Okay. So I'm just going to share that screen again. Great.
Yep, that's it.
Clinical photos?
Yeah.
Perfect. So this is what we want to produce, 5 intraoral photos. And how are we going to do that? Well, we're going to use a DSLR camera. Now, there's a variety of different things out there in the market, but I'll just break down the key components here. The key things we want to do is ensure that we've got a ring flash, so we're getting really good light in there, and we want to make sure we've got a macro lens as well. So I am not the most au fait when it comes to photography. I can take 5 intraoral photos of high quality, pretty much where it stops me in photography. Now, I got excited, Biju, when I actually got my DSLR camera. And I went to a wedding shortly afterwards, and I thought I'll be like the wedding photographer. I've got a DSLR camera. Honestly, they were so bad. I can literally just take pictures of patients' portrait photos. Anyway, so we want to ensure we've got a macro lens, and I will try and break down my understanding as to what that means. So a macro, we'll go over the settings and I'll describe what that means and how we use it. So when it comes to using our camera settings, we want to go into manual. I wanted to fiddle around with the aperture. So the aperture is the f-stop. Front photos, I use the setting 32, and for mirrors 25. Now, you guys will be able to see this. The information is readily available. Let me just explain why. So this is what the f-stop is. So a low number is the bottom image and a high number is the top image. And what the f-stop does, it increases the depth of field of the image. Essentially, we can see all of the Ninjago characters on this image. So when we're taking our photos clinically, what we want to be able to do is see the incisors and the molars in the same image. And that's why the f-stop is so important to be quite high. And we keep it at 32. Next, we want to fiddle around with the focus. There's two things will change, the focus and the f-stop. So the focal length will change. Now, I tend to stick to 0.49 when I'm manually using it, and I'll use 0 on the 0.49 and on the 9 on the 0.49 on the barrel. So these are relatively small changes that are taking place. And why do we do that? Well, focal length, as it sounds, gives us the proximity to the image. And the idea of having it set as I've described is that you then as a photographer will move backwards and forwards to get the image into focus. The reason why we want to do it that way is so we can create this, the image at the bottom, where the photo of the teeth takes up the entirety of the image. Now the issue with the photo at the top there is that actually we've got lots of other things. We've got a glove, we've got some cheek in there as well, things we don't want to see. And that means either we've got to sit there and crop the image afterwards, and even when we do that, we're going to lose some of the resolution of the image as well. Actually, it's far better for us to have the image well framed in our picture. And by using those settings, we'll ensure that that always takes place and we deliver the bottom image. We get really good images without us having to do any post-editing. Now, retractors are a key part of it. They don't cost much, but it's important that you get them. We've got to have cheek retractors, and I like to use a lip retractor and a mirror. And that's the armamentarium. Please ensure you get 2 cheek retractors because you are more than likely wanting to look at both sides of the mouth, not just one side. Here's my nurse who I gave a coffee to allow me to take these images. And we've put in the 2 cheek retractors. Now, how do we use them once they're in? Well, we want to put them in and pull them forward. So it's not just pulling them sideways so we can hurt the patient. You can if you wish. I did for my nurse, but also we're pushing them forwards. And that allows us to take these images without any of the cheeks getting in the way. What are we looking at when it comes to this photo? We're looking at for the occlusal plane to be horizontal. We're looking at the vertical, the center lines to be in the middle of the image as well. We're focusing in on the lateral incisors. If one tooth was going to be in focus, that's the one that we would choose. And the reason for that is with our settings now, f-stop 32, that will imply that we get the front of the teeth in focus and the back of the teeth in focus as well. Going across to the side now. So we're going to switch. We're going to go from using the big side of the cheek retractor to the small side. It allows us to pull further back on that side. We will then pull back and upwards, and that's the key part to get as far posterior as we can. And then we can get and see the first molars, and that's the key thing. We need to be able to see the first molars in the buccal shots to make that assessment. Again, the occlusal plane is horizontal and the canine is in the middle of the picture. And that way we've got all the information that we need from that picture. And the occlusal shots here. So we can see that we've got the lip retractor, which is in place. And we can see that I'm holding the mirror there. Now, the mirror itself can steam up, so you may wish to use some hot water. You can also get some anti-steaming wipes that you can buy from Amazon, which is pretty simple to use, and just wipe it down. Otherwise, the nurse can use a 3-in-1 to keep the steam off it. So what have we done here? Well, we've gone in and we're trying to ensure that we are keeping the premolars in the middle of the image. We're ensuring that we've got the first molars at least in the image as well. And we're holding the mirror, so we're getting a parallel image to the incisor teeth. And those are the key aspects of it. Now, it takes a bit of playing around to get this image. If I can take you back to the image here. When we're looking at the mirror that we can see there, we're getting all the information that we need. Now, if I was to cock my hand down or up, that angle would change and I'll start to lose some of that information. It's generally a 45-degree relationship between the mirror, the camera, and the upper teeth. And that then ensures we get that image in the ideal fashion. Common errors. Okay, so let's have a look at these. And Biju, thank you for sharing these. This patient, this guy has not got any retractors quite clearly. Got a mirror, no retractors. Here's another attempt to try and get to the back of the mouth. Got a glove this time. Maybe they don't have mirrors. And here we have one which is clearly not in focus, not of any diagnostic quality. Using intraoral cameras, which are attached to our chairs usually, isn't going to give us the quality of image that we need. Got a retractor, only got one, so we can't see the rest of the arrangement of the teeth. Other things, so not using a lip retractor for our occlusal shots, and also not using a mirror. Now, and Biju drew this analogy, and I'll steal it from him because it was great, is that if we were to give you a set of study models, what would we do to look at them? Well, we would look directly down at the study model at 90 degrees to make an assessment. We wouldn't hold it so we can just see the front teeth. We'll look occlusally down at that study model. And it's the same when it comes to our photography. We need to produce an image which gives us that diagnostic quality. And for that, you need to have a mirror to take the images. So we can get great images like this, which now are diagnostic. We can see all of the lower teeth which are relevant, and we're looking straight down at them as we would do with our study models. There's a great video on the CFAS website which goes over dental photography, and I do recommend you guys have a look-see at that. Scans, as we've mentioned, are accepted by the laboratory. I think it's great that it's open access. I know some companies don't allow that to take place, which I think is a real shame, and it limits clinicians into a certain ecosystem. But I think it's great. Digital scans are wonderful. My nurses are far better than me at taking them. I take a long time, but it's a great way forwards to go. Cool, guys. That brings us to the end, and I am on time. Fantastic. So it brings us to 12:30, guys. So we'll pause here for lunch. If
you want to take some questions now, or do you want to do that before we resume?
Yeah, should we take some questions now?
Yeah,
I think that would be a great idea. Let's take some questions now,
okay.
And then we can take half an hour lunch regardless.
Sure. Okay. So just trying to find ones that there's some questions on here which actually you are going to cover later on, so I'll skip those. Are aligners okay for 15 to 18-year-olds with moderate anterior crowding? From Samuel.
Yeah, it's a good question, isn't it? And I think if I was to give some background into orthodontics, very typically 20 years ago or so, it was confined just to the teenage group of population, and it was just fixed, and it was generally just metal. Then we had the rise of adult orthodontics, where we start to see things such as aligners, ceramic brackets, and lingual appliances, and so forth. And then it's now kind of, we've got children, we've got adults, and now the adult type of appliances are kind of starting to go into the younger population. The answer to the question is yes. There is no difference in the way both fixed and aligners work. They still both apply forces to the teeth. Biologically, there is no limitation in either younger patients or older patients. The question we had about expansion for an older patient is fine for tipping movements. The challenge comes more about the patient compliance. And that's the other side of it, is that this appliance, like any removable appliance, requires a patient to commit to wearing it. Adults will commit to wearing an aligner because they're paying a lot of money. Now, for the younger patients, it's usually their parents who are going to pay for it. So the motivations may well be coming sometimes from the parent, not from the child or the teenager. So that's where there's a question mark then. And that relates now to your communication skills to try and elicit, well, is this patient going to wear it? Are they doing it because mum or dad says so? But yes, I will treat young patients. I've got an 11-year-old who's having aligner therapy at the moment, and it's fine because they really wanted it, and it's appropriate for their malocclusion. I think it's important not to necessarily be steered by the patient to deliver a appliance as well. If aligners are unable to deliver that patient's treatment, then we need to be honest with them and tell them to move on to something else. And the way I see it, very much like a plumber. We have a task to do. We may need to use a variety of tools to get us there, and different tools, and we shouldn't shy away from that. If we just have that one tool, you know, the classic saying, if all we have is a hammer, then everything is a nail. So we need to bear that process in mind as well. But yeah, there's no limitations. These aren't confined to adults from a biological or orthodontic perspective.
Yeah, and if I can just add to that, the only thing I would just be aware of is if you are treating younger patients, children, then I think, as far as I'm concerned, my personal opinion is you shouldn't really be primarily looking at a cosmetic improvement. Really, you should be looking at an orthodontic correction, a comprehensive orthodontic correction. So just because a patient, a younger patient may want, a simple anterior correction, that's may or may not be the case. You need to look at, I think you need to evaluate children orthodontically. With many adults, it's fine, the growth is complete and they're not really looking for a functional correction, they're looking for a cosmetic correction. But I don't think you should, I don't think you should let a patient somehow think by giving them a cosmetic correction, you're actually treating an underlying orthodontic problem. So I think it's important that you differentiate between the two. And for children, I would always say they must have a comprehensive orthodontic evaluation. And if you don't have the skills to do that, then I would always refer.
That's a good point. I mean, there is opportunistic at that age group to have comprehensive orthodontic treatment. They've got growth on their side. There are other things which make those parameters easier to do. So yes, I concur to that. I think it's one to very much say, well, you've got to really not want that to have something else. As for the adult population, it is different. Their growth is finished. There may well be some limitations there as it is.
Okay, which forces are at higher risk of root resorption? I have a anterior-open bite case which requires 2 millimeters of anterior intrusion from uppers 2 to 2. These teeth have about 30% root resorption from previous ortho.
Yeah, so I mean, those are sending off the alarm bells really. So also if it's an anterior open bite, you're probably looking to extrude the upper incisors as opposed to intrude them. But the answer to the first question is the movement we know elicits the most root resorption is intrusive movements. So intrusive movements, usually specifically on the anterior teeth, which are the most vulnerable, carries the maximum risk of having root resorption. In your case, the anterior open bite, extrusion of 2 to 2 carries less risk, probably tantamount to the conventional amount of root resorption for other movements as well. The question when it comes to that type of a case, if you are carrying an anterior extrusion, is how stable is it going to be at the end? And again, this is now starting to get into the etiology of it. For example, if the case had previous digit sucking habit and so forth, then I think that's pretty good. You're going to get them back to where the teeth should have been. However, if it's skeletal in its origin, and you are now extruding the incisors to essentially camouflage the anterior open bite, there's a strong likelihood that those guys are going to relapse afterwards. If they've already had root resorption and you've got a reasonable anterior open bite there, that is the one to send in the records off for that case and get some clinical information and advice about that particular case, because there's some nuances there that need to be explored. And it may be that's best not to do that. You've got to bear in mind with anterior open bites, anterior extrusion is perhaps an easy one to deliver, not particularly predictable, but sometimes we think about going a bit more orthodontic and carrying out posterior intrusion. Usually roots are healthy, more robust there. That's another mechanism to be able to achieve anterior open bite correction. And that can be done with aligners, but it comes down to the planning of the case. So yeah, that's one to have a look at closely and ask for some more advice on.
Great. A couple more. This is maybe one for John. John's our resident digital expert. When we take a scan, how does the lab know the dimension of the teeth?
Hi everybody. The scans are very accurate, as you know, and we can measure between teeth within the software. And obviously we print the physical models as well, so we can do the normal measurements on a physical model as well as digitally.
Yeah, but I mean the scans.
Does that answer the question?
Yeah, I think so. The scans really go down into sort of fractions of a millimeter, and within the scan,
microns.
The software does allow the lab to measure very, very accurately, the width of the teeth and IPR, and you can go down to fractions of a millimeter.
Cool.
Last question then: can brackets or attachments be attached and easily removed from bonded or white crowns, e.g. Emacs?
Oh, good question. So it's never my preference. So I will usually try and avoid putting attachments onto those teeth. But the answer to the question is yes, you can bond onto those. So removing them is always super easy. Putting them on is the challenge. So then I will use a silane. I'll tend to use just a typical silane coupling agent, right? So I will usually use hydrofluoric acid. I will then use Scotch Bond, which tends to be my favorite. It's got some silane coupling agent in it as well, and then put the attachment on. And touch wood, when I've needed to do it, it has worked fine. The challenge always comes is how robust is that bond going to be. So it's, again, not my preference. Usually that's one of those teeth that I either try not to move for any reason, or think about not using an attachment. In fact, this reminds me of a case that I treated where she had quite moderate anterior crowding, and she had crowns on the upper lateral incisor, the upper premolar. I'll probably try and dig out the photos again. And in fact, can I find it? And what I simply did is we treated the case without putting attachments on initially to that particular tooth to see how we got on. And then we thought, well, if we need to put an attachment on, we'll then do it to that stage. She was quite keen to proceed with that. And I thought, well, let's see how we get on. And if I could just show you the photo, and it works quite well. In fact, I feel far more comfortable in heavily restored dentition, especially anterior teeth, using aligners than I would do using fixed, because there's far less bonding potentially required. And I can consider doing it without it. So if I can share this screen. Cool, so just this case here down at the bottom. So you can see it's quite heavily restored dentition generally. We've got crowns on the 6s, on the 5, and this lateral incisor as well. And I say we managed that case. Now, what I would suggest, what I did for this case, is I put attachments on all the other teeth. So I essentially tried to compensate for no attachment being there, and it worked well. So yeah, it's entirely possible to put an attachment onto a ceramic crown, to clarify, but there's also ways to work around it as well.
Yeah, and if I can just add, when you do your assessment using the assessment form that we give you, on there it does prompt you to let the lab know which teeth are ceramic, which teeth are crowns, and that way, because often with a scan, the lab may not be able to tell which is a ceramic crown and which is a tooth. So I generally don't like putting attachments on ceramic restorations. Try and avoid it, but it can be done. It's a fairly decent bond strength. It's something like 10 to 12 megapascals. You can use, as Farooq said, a 9% buffered hydrofluoric acid. That's the one you want to get, not the lab. The lab use a different one. Just, you definitely don't want to use. So it's a 9% buffered hydrofluoric acid. Optident, do a good one. And there's a help sheet on the CFAS forum which you can download, which shows you the sequence of doing that. But generally speaking, with the aligners, I try and avoid attachments on crowns. And if you want to avoid attachments on crowns, do let the lab know on the prescription which are crowns, so they can also avoid putting attachments on there. Okay, I think that's us.
Any other questions at all, Biju?
I think that's us. So shall we break for lunch?
Yeah, so if we give it half an hour, we'll meet back at 1:10. How does that sound?
That sounds perfect. Okay, enjoy lunch. We'll see you soon. Okay, everyone, welcome back. Just before Farooq starts the next section of the webinar, I just wanted to share a few things from my side of things. John, are you there?
I'm here.
Great. You can just let me make sure you can see this. Can you see my screen?
Yeah, you can see that.
That's great. Thank you.
Yeah, that's good.
So the first thing is that I want to just clarify is regarding the support. I do think that one thing that really sets us apart from a lot of the other companies out there is the support that you get. I think we really pride ourselves on the support. You can contact me directly. Okay, so this is my information, and at the end of this webinar, over the next sort of day or two, we'll send you all the information that you need to start and get the support. So there are a lot of mentors available either directly by email or on the forum And the forum, again, will show you how to access the forum, but you're more than welcome to contact me directly. This is one of the things that I do. I still practice, but a big part of what I do now is also supporting dentists with their treatment planning and their case selection, any aspect of really of aligner treatment or fixed ortho treatment. That's my email. That's my sort of email there. You've got my number if you want to WhatsApp me. Try not to send patient cases on here, but if there's anything very quickly you want an answer for, then you can get me on WhatsApp. I do have some social media, which really is, what I do on there is really just put up cases to give you a good idea of the scope of treatment and the kind of cases that you can treat. I also use my social media as a reference for my patients. So if my patients come in, there's usually something that I've uploaded that's similar to theirs. So that's a good thing for you to replicate as well. The dentist part of the CFAST website has a lot of good support material on there. There's downloads, there's videos, and there's also a forum. So this forum is, there'll be tens of thousands of posts on here. So that's a great tool as well for just for learning. A lot of the questions are the same because it's, you know, the problems that or the challenges that dentists encounter with aligners or any type of orthodontic treatment, they tend to be the same. So it's great to be able to go on there and have a look through the questions that have been posted and the answers to those questions. You tend to get a very quick response. So usually within, we say 48 hours, but generally you'll get something within 24 hours. So have a look on the forum. We'll give you all the details of how to log on and register yourself. One thing I want to touch upon, and this is something I spoke about earlier, is the difference between cosmetic tooth alignment and orthodontic treatment. Now, my background traditionally was restorative. That was my interest in the early days, and very interested in minimally invasive restorative treatments or cosmetic treatments. And what I realized was to do good cosmetic dentistry, and especially minimally invasive cosmetic dentistry, it's almost impossible to do that without moving the teeth. And in the early days, we were just taught to pick up the drill and start cutting healthy tooth tissue, which didn't really sit well with me. And I think in those days, if I go back maybe 15, 20 years, minimally invasive cosmetic dentistry meant I didn't expose the pulp, you know, and nowadays that has a very different connotation. So what we're looking to do with the majority of our adult patients is really give them a nice smile. So they're really coming to us for cosmetic treatment, not really orthodontic treatment. So that's something I just want to, again, just clarify. Something I talked about earlier is the difference between orthodontic treatment and cosmetic treatment. And it's very easy, because what we're doing looks like orthodontic treatment, it's very easy to confuse the two. Okay, and especially once you start getting good at anterior tooth alignment, it's very easy to think, oh, this is quite simple, I'll just extend that to the posterior teeth. But as soon as you start doing that, you potentially get into issues with occlusion, and it really requires a different type of training. So I would suggest with all your cases, try and keep them simple. Start with anterior tooth alignment, and it's really for adult patients. There's a great saying by a very famous orthodontist, and he said, children should be treated idealistically, but adults can be treated realistically. And that's a very, very good rule of thumb. For children, yeah, look, they may, for some of them, they may just need cosmetic treatment, but they have to be evaluated orthodontically to arrive to that conclusion. Okay, so try and restrict your treatment to adults. Now, the vast majority of adults that you see are looking for a nice smile. They're not necessarily looking for full orthodontics. They may say they are, but when you drill down, there's very few that actually want their posterior teeth moved. They're functioning okay. They may not have a perfect bite posteriorly, but they're functioning. And what they really want is a good cosmetic result. So cosmetic dentistry definitely has changed over the years. And fortunately, we are becoming much more conservative now. And the way we look at this is this ABC approach to smile design. The first part of that is to align the teeth, get the teeth into a nicer position. If the patient's happy with that, then stop there. The next most conservative thing you can do is to whiten the teeth. And if the patient's happy, again, just stop there. But most adults present with some degree of incisal edge wear. And now that the teeth are in a good position, if you needed to correct that, then you can do so with composite or ceramic. Majority of the time it's going to be composite. And this now really is minimally invasive, because if the teeth are in a good position, then it doesn't require any preparation or minimal preparation to then provide your restorative treatment at the end. Now, when I started this journey, I really only could do aligners, okay, because that's what I was taught. But over the years, and I've been doing this now for certainly over 15 years, I'm quite comfortable with the full range of orthodontics. So I can do, you know, everything from comprehensive orthodontics to simple short-term ortho using fixed appliances or removable appliances. So when a patient comes to see me, I'm quite happy to go through all their options. If a patient's coming to see a dentist and all that dentist can do is aligners, then they leave with aligners. But I try and be unbiased in my opinion, and it's assuming that the patient can be treated in a number of ways. I try to give them the pros and cons of each modality. And in my practice, it sort of breaks down like this. The majority of patients, when you try and do it in an unbiased way, will actually prefer a fixed labial appliance for simple anterior movements. And the reason for that is that what they tell me is that they can't be bothered with the hassle of taking aligners in and out. They don't feel they'll be disciplined to wear them the required time, and a lot of them are scared of losing their aligners. So for that reason, a labial appliance generally is the preferred way I think for about 60% of the patients that come to see me. The big bulk of the remainder tends to be aligners, okay? And aligners, that's what the majority of patients actually come in for. So, you know, I'd say about 90% of patients actually come in for aligners, but the majority end up choosing fixed when you give them the pros and cons of each one. I do lingual as well, and once you've done a bit of STO with using labial appliances, then come back to us and we'll show you how to do lingual. Lingual is the ultimate because you have this speed of a fixed labial appliance, but it's way more invisible than the aligners. Okay, it's completely discrete. It's a bit more expensive for the patients. So generally, again, patients that come in for lingual usually either leave with aligners or with labial, but it's great to be able to differentiate yourself from everyone else by offering lingual braces. And a small minority will actually go for full ortho. Again, this is something that I offer. Usually, for a lot of adults, they don't really need, from a functional perspective, full ortho, but there are certain cases, especially when you look at arch development or expansion, improving the width of the buccal corridors, that they would develop, they would benefit from a degree of comprehensive orthodontics. So I do offer that as well, but because of the time taken to do that, you'll find that the majority of adults tend not to want to go down that route. But it's great to be able to do, to be able to offer all these things. And if you haven't done any of the fixed work, then come onto one of our courses and we'll show you how to do that. So this is the way we look at now. I look at my cases. We talked about ABC, the progressive smile design approach. This is Cara. So Cara came to me. This case must be at least 12 years old, and she's not happy with her smile. She came to me, I think saying she wanted, comprehensive orthodontics. And when we drilled it down, actually, she had a short time frame, and that wasn't appropriate. So we just adopted a cosmetic tooth alignment approach. That's where we started off. So restoratively, that's really difficult. I suppose you could do it, but you wouldn't be able to do that minimally invasively. You'd have to do a lot of preparation to teeth to try and get them to look anywhere reasonably decent. So the first stage really was to align the teeth, and that's the result we got. Yeah, this is the result we got after the alignment stage. So you can see immediately once we get to the alignment stage, and you can do this with fixed or you can do this with aligners, it now becomes a simple restorative case. Okay, so that's what we got after the alignment stage, and then we just did some composite bonding to correct the wear, which a significant number of adults will have. Okay, so that's before and after. And most of your patients will follow this pattern. So always say to patients that they may need some composite bonding at the end, because very rarely will you get teeth looking perfect or near perfect just with the alignment alone. So it's very important to manage the expectation in that regard. Also, the way you want to position teeth at the end may be different for different cases, okay? The lab, when you send cases into the lab, they'll always try and do as much as possible to get the teeth in a good position with the alignment alone. But when I look at cases, I work from sort of the end backwards. You know, what am I trying to achieve with the end result? Where do I want my teeth to be placed so I can do good restorations? And then what do the aligners need to do? So this is quite different, this approach, rather than just looking at cases from a purely alignment perspective. So if you look at a case like this, you could just simply align those teeth and do some restorative work, but working backwards, actually, I need my teeth to be here. Now that looks possibly worse than where they started, okay? But if I have my teeth there, then this allows me to do the restorative bit. Okay, so it's important to have the end result in mind and think about, you know, where do you want those gingival margins? You know, in this case, I wanted the teeth to be, the centrals to be aligned. I wanted the gingival margins to be perfect as much as possible because I knew I was going to restore later. Okay, so you can see the gingival margins are off here. The goal for my alignment stage was actually to align the gingival margins, get those into a better position. The laterals were slightly microdontic, so I wanted to create some space around those. And that's what I'm communicating to my lab. So the lab wouldn't naturally set it up this way because this to them looks very strange. Okay, you would need to have input into here, dictate where you want the teeth, so then that when you do the restorations, actually the restorative bit looks good. So I hope that makes sense. We're starting up our hands-on courses now. So now that lockdown's lifting, if you want to come on to one of the hands-on courses, then again, we'll send you some information at the end of this course, and you can give us drop us an email, and we'll put you onto one of these courses. Now, one thing I want to talk about is consent. This is a perennial problem that a lot of dentists have. A lot of dentists are unsure about how to give good consent. And, you know, as long as I've been teaching this, there's the issue of consent always has come up. So this is a project that we started a few years back with Leeds University to address the problem of consent. And this is what we've come up with. It's I Consent You. And we have sort of launched it about 6 months ago, but we're about to, and that was really as a trial, as a sort of beta testing phase, but we're about to launch it properly now in a few weeks' time. So this is something that I would strongly recommend you get on board with. It's a web-based app, so it's not something that you download. You can purely access it through the web, okay? And what it does is what we've done with every single dental treatment. We've looked at what are the most common areas of confusion, misinformation, and litigation. And what we've done is we've taken, for every procedure, the most common causes of complaints, and we've animated those. This can be done in the practice or at home on the smartphone. Okay, so that smartphone version is going to be available in the next few weeks. At the moment, it can only be done in practice. And once the patients have watched the animation, the patients are then tested on their understanding of each procedure. So the issue that exists at present is you can give patients a consent form, and you can write that consent form in as simplistic language as you wish. But ultimately, if the patient turns around and says, I didn't understand, you really don't have a leg to stand on. Okay, so this is the thing that we've tried to address with this sort of web-based app approach. So a lot of the consent forms, all the consent forms are on there, and all the consent forms are written in industry standards. So it's the way that a consent form should be written, and we've taken advice from various different people, including some indemnity lawyers, on how to write those consent forms. So it all comes preloaded with consent forms. However, if you prefer any of your consent forms over the ones that are on there, then you can edit or upload your own as well. And at the end of treatment, at the end of the consent form, you can send out all the documents to the patient. And you don't need to worry about integrating this with your existing software. It's quite easy to upload documents into the patient's file if you wish. So how does it work? Well, actually, before we talk about that, let's talk about these guys. So this is the Dental Law Partnership, and there's other sort of firms like this that will do the no-win, no-fee thing. And according to the Dental Law Partnership, this is on their website. Problems with consent alone. Okay, so investigations relating to dental professionals failing to obtain proper consent. This is just the consent part, rose by 713% over a 5-year period. That's significant, okay? And why I think that's happened is because, and this is just my opinion, I don't have the facts on this, but if it's difficult to prove there's been any clinical negligence, it's always easy to get a dentist on consent, because literally all the patient has to say is, you know, I didn't understand. Okay, and as soon as a patient says that, it's very, very hard to prove that they did understand. Okay, so this is what we've tried to address and try to get rid of this issue of you know, going after the consent as being the weakest link. So there's 2 ways to do the consent. It can be done in the practice, or it can be done on the patient's smartphone. I think the majority of the time you'll probably send it to the patient so they can do it on the smartphone. One of the other problems with consent is not giving patients enough time to make informed consent, and that's one of the key things that you have to do. So if you send this to patients well in advance of their appointment, they have plenty of time at home, at their leisure, to go through the process and fully take on board what it is that they're consenting to. If you do it in the practice, then it takes about 10 minutes, which we found is a little bit too long. Especially if you're in a high volume practice where you're seeing a lot of patients, you know, sod's law, patient comes in 10 minutes late for appointment, and then it takes another 10 minutes to do consent. That it sort of drags on a little bit. So this is why we've really optimized it for their smartphones so that they can do it at home. But you do have the option to complete it in the practice as well. So the way it works is, again, this is done on the smartphone or on a tablet. The patient confirms who they are. They then watch a short video that covers what it is the treatment they're having done.
Your dentist has recommended dental implants to replace 1 or more missing teeth. Before we get going, there are some important things we need to let you know about your treatment, so together we can achieve the best possible results.
So we'll just fast forward this video here. Obviously the patients won't be able to fast forward the video. They'll have to watch the whole thing. And this video again is highlighting the main problems associated with each procedure.
Regular visits to the hygienist or dentist will help your dental implants last for many years.
Okay, so there's a similar one on aligners, bridges, dentures, all that kind of stuff. So once they've watched the video, they then take a quiz. Now the quiz is always in this format. There are 4 questions, 4 answers to each question. Now, assuming the patient chooses the right answer, they can then progress to the next question. There's always this option here, okay, of I am not sure, because this is giving the patient multiple opportunities to let you know that there's some confusion in any aspect of the treatment process that they're not aware of. So there's always that option. So if they choose that option, or if they choose an incorrect answer, then that clip is played again, just that clip.
Although dental implants are a good solution for missing teeth, there are alternative treatments you should be aware of. These include trying to save a tooth before it is removed, using a root canal procedure. If the tooth is already missing, the alternatives include bridges or dent.
Okay, so they just have to watch that little clip again. They don't have to watch the whole video, and hopefully then they should be able to make the correct choice. So basically, they just progress in that fashion until they've answered all their questions. Each quiz tends to be somewhere between 5 and 7 questions, depends on the complexity of the procedure. So once they've done that, you can then see which questions they've got right, which questions they've got wrong, and you now have the opportunity to go over that with them. Okay, and once you've gone over that with them, you can then mention in this little box here that you've done that. The patient then signs to say they're happy with the quiz and they're happy that they've had all their questions answered. They then take a photograph of themselves. So one of the things that, let me just go back here. One of the things that's not done particularly well, and I used to always forget to do this, was to get patients to consent to having their photograph taken. And with the new data protection laws, I think it's really important that you do get consent if you're holding photographic information on patients. So this is a form that's actually built into the whole consent process as well. So they take a photograph and that's then uploaded to their documents. Okay, and then they have the opportunity now to read the full consent form. This covers basically everything they've seen in the animation, but also some of the sort of less common issues associated with any particular treatment. So it's quite a comprehensive treatment plan written in an industry standard. Okay, so they tick all these boxes to say they've basically understood everything and had enough time to read the consent process. You can see the photograph here is attached to their signature. So sometimes with these digital signatures, it doesn't look much like the normal signature. So this just says that it is them that signed it. And that's it. You can then email the patient the documents and you can receive a copy into your practice as well. So that's it in a nutshell. There's obviously it's about 16 to 17 consent forms on there at the moment. It will become quite comprehensive over time. So if it's something that you're interested in, then just drop me an email. I would wait maybe 2 or 3 weeks before you actually register, because it's probably going to be about 2 or 3 weeks before we get the module that allows patients to complete the consent on their smartphone. And I think as soon as they can do that, that just saves a lot of time for them doing it in the practice. And if you're using the app, then we also have our Ortho Assurance Network. Now, what this Ortho Assurance does, and we're the only company, as far as I'm aware, that can offer this, is if for whatever reason you get stuck with a treatment and you can't finish it to your satisfaction or the patient's satisfaction with remote help, then we'll take over the case and do it for you. So we have a team of dentists all around the country and in Ireland that you can refer patients to if, for, like I said, for whatever reason, you're struggling with a case and you're struggling to finish it off, and we can't support it, just from remote, which 99.9% of the time we can. But for this, it just gives you that reassurance that we do have this this network in place, this safety net, which again should give you confidence to start your cases and start your treatments. That's my contact details there again. We'll email all this out to you, so please feel free to drop me all your cases, and I'll help you with your treatment planning and any aspect of treatment that you're not sure of. That's it. That's all I want to talk about. So I won't take up any more of Farooq's time, and I'll hand you back. Farooq, are you there?
I am here. I am here. I usually keep Biju waiting when I switch my screen on to make him think that I've done a runner. And the expression in his face is priceless. I'll have to remember that for next time. Thank you, Biju. I really like listening to that presentation. I think what gets me the most is just how dynamic that consent process is. Now, of course, we're talking about it in the realms of CFAS, but I mean, Biju, I've had conversations with orthodontists now in the UK and also external who are aware of the stuff that you're doing about the consent, and I think it's going to be really good. I think it will become, in whatever connotation and so forth, something that we are essentially moving on towards, a bit like kind of impressions and scans and so forth. Absolutely. I think it's a great thing.
Yeah, we're trialling that in Leeds University at the moment, and also Morecambe Bay Trust in the orthodontic department. So it's there's NHS trials starting, and actually it's also being adapted for things like orthopedic surgery. So we'll be running an orthopedic surgical trial for things like hip replacements and stuff in Leeds General Hospital. So it's, yeah, I think it has quite a good range of uses. I
think that's great. And like the support that's been offered, I know we've mentioned it before, and again, guys, I am external to the company, is that, and I'm going to probably be a little bit bold here and say that when it comes to aligners, guys, there is no magic in the plastic, right? The plastic is the same between one company and another company, and really what it comes down to is the planning that we do, the support you get in the planning, but also the support in the delivery of the treatment, and actually having an assurance program, you know, for me is it's your safety net. And I would say that is something that I've not seen offered elsewhere. It's something that when I was started using aligners, I very much wish I had, because those are the things that then put you off, or you feel as though you've got to sit on one side of the fence or the other. So I support the guys with CFast with that as an outlook. And again, I feel as though it gives confidence to the consumer of aligners as a clinician, in that this isn't something, it's not a one-hit wonder. It's not, we're just going to do something really fast, we'll do all the cases for you, and then they disappear. This is about the longevity in offering a service, and you can see you guys have developed to offer these things to meet the criteria for clinicians to feel comfortable. So great. Again, congratulations to you guys at CFast to produce such a structure.
Great, thanks.
Right, guys, I'm going to go on. So next, after lunch, perhaps not the ideal time, but we're going to go through some really hardcore stuff. No, we're going to go through some of the case setups next. Where we're going to look at 5 very carefully chosen setups, discussing different parameters of alignment, and hopefully there's some good learning points there that you guys can take forwards and then take to Monday morning when you see your cases. We'll go through attachments and IPR as well. We'll describe the premise behind them, but also how to clinically deliver it so it's predictable. We'll then break, and then we'll finish off with retention, some tips at the end to conclude the session with. So Biju's done his bit. So case setups. What I want to do is just go through a quick recap from this morning. Here we spoke about aligner tooth movement, and I've termed it here envelope of aligner movement. I'm fortunate to be working with some of the guys. We're trying to develop this to make it hopefully a very accessible, dynamic tool where you can kind of plug in information and see what the predictability is. So we're producing this aligner of movement, envelope of aligner movement. Simply alignment or tipping movements is predictable, extrusive movements are unpredictable movements to take place, and the rest fit in that range. Cases to avoid, we've been over these, and there are these key 7 components to avoid when it comes to doing our cases. When I say avoid, maybe the first 2 are ones to say, okay, great, we're not going to treat these, we'll throw them on. But for the other ones, it's about maybe a bit of time will expire and the TMD will resolve, or the active disease will resolve, and they go from being red to them being green for us. We spoke about SLAM, very much a tribute to the 90s chap that I am, but also the information we want to relate to the laboratory. Biju has spoken very well and developed the consent process, which is communication, right? And it follows us around wherever we go as a skill to have, including discussing it with the laboratory. Anything that we do external has to have good communication to get a good result. This is the way we do that. Cool, here's a case setup that we're going to look at first. So this is one of my favorite cases to treat with aligners. A patient comes in, so I've got no issues with my top teeth, I just want my lower teeth sorted out. And I go, great. And the reason why this is great is that those variables of occlusion, overjet, overbite, all are now dictated by the top teeth that I'm not moving. So I don't have to think about those ideas anymore. All I have to do is think about straightening the bottom teeth, and the occlusal parameters are no longer an issue. So let's have a look at this case. We've got crowding the lower arch. We've got approximately 3 millimeters of crowding. And in the lower arch, it seems to be more on the lower right quadrant than the lower left side. So it's a bit asymmetric in its presentation. We've also got a cross bite, which is present on the lower right 3. And those are our 2 key things in the clinical assessment of this patient. Now, when it comes to describing the limitations for this case, when we're talking about overjet and overbite, it's easy. I'm just going to keep it the same from the beginning. When it comes to looking at crossbite, yes, I want to correct that on the lower right 3. It's 1 tooth. That's really simple to do. When it comes to the center line, of course, I'm not changing the top. When it comes to the lower center line, I've put forward an idea of us accepting where the lower center line goes. We'll see that as we go through the case. So let's now populate the information for our SLAM. What we're now going to say to the laboratory, now that we've assessed the case, we've got an idea where we want to go. IPR. We want the solution to our spacing requirements in the lower arch to be resolved mostly by IPR. We don't really want proclination. And when it comes to proclination, we've still got to make a decision. Where do we want the lower incisors to finish? Because we've got two lower central incisors, slightly different position. We're going to write to the laboratory and say midpoint between those two. Expansion, we don't really want any expansion either because we're mapping ourselves to the upper arch. As I say, my favorite case is to treat with aligners. Now, limitations, we've been over this, that actually we're not really making any changes to the overjet. We're going to maintain the overbite, Booker segments. The only thing we're really doing is accepting the lower centerline going to the left side and correcting the crossbite on the lower right 3. Attachments and movement, well, there's no implants, no crowns, no nothing else, so we don't need to specify any limitations there. Great, guys. I'm now going to switch over to the online setup and we can hopefully see that. Here we go. Biju, can I just check you guys can see that?
Yep, looks good.
Perfect. I'm going to hide my face because even I don't want to see that on a Saturday morning. Right, great. So I can see the whole screen now. So here's our online setup for this case. We've seen our clinical photos. We know we've got this crowding present in the lower arch. So let's now play through this case. We've got our 14 aligners and we've delivered our alignment. Now let's have a look at it from the occlusal perspective. So let's have a look at the lower arch. Great. So there's the alignment taking place to those low incisors. It looks great. But remember, guys, our task when we're looking at this online setup is to see if it's delivered what we wanted to do so. So we spoke about our achievement of our space requirements is mainly through IPR. We've got 3 millimeters of crowding. Let's switch on IPR. Let's have a look. We've got 0.4 millimeters and 0.3 millimeters across all of our lower 3 to 3. And that aggregates itself to around about 3 millimeters of alignment. That is how we are 3 millimeters of space, which is what our space requirements are on the lower arch. We can also see that there's more IPR on the lower right side than the lower left side. That's because we're a bit more crowding there. It's great. It shows that we've accounted for the space requirements. Now, we didn't really want any proclination and we didn't want any expansion taking place as well. Well, let's have a look at that. Let's switch on our superimposition and see where have things gone. Well, looking at proclination first, we can see the lower incisors have met in between those two lower central incisors. That's exactly what we wrote to the laboratory. Let's meet in the middle, which they've done. There's no changes posteriorly, so there's no expansion that's taken place either. Great, the laboratory have delivered what we've done. This is a bit like getting back your denture and you are checking your attachments, you're checking the retentive components are as you've asked them to do. And it's the same thing here, but we're just doing it digitally. Now, one of the things I wanted to show you guys was also the occlusion. So we describe this being one of my favorite cases because we don't really change the occlusion, but let's check that's still the case. We wanted the overjet to be kept as it was to the lower left 1. As we go from beginning to end, the overjet remains the same on that lower left 1 distal aspect. So we've kept our occlusion the same. We've kept the key aspects of this case all mapped around the upper central incisors. We've aligned our lower teeth. Now let's have a look at these lower central incisors a little bit closer. We can see that the software, which is never great at predicting soft tissue response, we've got this black triangle, right? Now, when we were planning the IPR, we can see there is IPR taking place to those low incisors. So we are going to improve the black triangles that are there. Let's switch back to the case now. Let's have a look and see how things finished. Great. So that's our plan for the case on the right-hand side. That's the clinical presentation from the beginning. And that's where we got to at the end. We can see we delivered really great alignment to those low incisors. And this is a very predictable occurrence to then take place. Let's have a look from the front. We can see the crossbite to the lower right canine has been taken care of. Let me draw you guys' attention to the lower center line. Okay, so let's have a look at this. We can see the lower center line has gone from being slightly to the right side to being slightly to the left side. and that's fine. We accepted that those changes would take place in this case, and they've been delivered. Patient's not going to be concerned about it. They've been shown the images from the outset. It's a good way to reduce the amount of IPR we need to do. IPR is a great tool, but if we don't need to do it, I really feel as though we should avoid doing it therefore. And the lower centerline is not a functional or aesthetic consequence. Cool, I'm going to move on to the second case. So what have we got here? A little bit more going on. So this time we've got mild crowding in the upper arch, about 2 millimeters. We've got about 2 millimeters of crowding in the lower arch as well, generally around the lower right area. We've got some other things happening. So we've got this reduced overbite. We're less than 20% now with our overbite. We've also got these retroclined upper incisors and this class 3 relationship. To recap, that's when the overjet is reduced. Cool. So what are we going to look at for this particular case? We've got 2 millimeters of space requirement in the upper, 2 millimeters of space requirements in the lower, and we've also got the reduced overbite and retroclined upper incisors. So when it comes to managing our space for this case, we're thinking, well, IPR, maybe IPR in the upper incisors isn't the best way to do it. Maybe we can procline those upper incisors. We've got a reduced overjet as well. So if we procline them, we get more towards an average overjet. The lower incisors, yes, there's mild crowding there. Let's mostly resolve that through IPR. When it comes to our expansion, well, there's no crossbites taking place in this case. We don't really want any expansion to then be carried out. Our limitations. So what's our limitations? Well, we want to improve the overjet, and the way we want to do that needs to be specified. We don't want to necessarily bring back the lower incisors. We want to push the upper incisors forwards to get them to the right inclination. Overbite. Now I've put down here, maintain the overbite. Now Farooq, you mentioned that the overbite was reduced. Surely we should fix it. We can do that. We're using some form of lines. Well, I'll show you guys two setups. One where we haven't fixed it, one where we have fixed it. Essentially, by maintaining the overbite as it currently is, it's a more stable outcome. If we then want to improve the overbite, we're going to have to extrude the incisors. That's an unstable movement. And don't get me wrong, it looks great at the end on the online setup. However, on our spectrum of orthodontic tooth movement, actually extrusion falls on the least predictable side. So is it actually going to transpire? And the third question is, how stable is it going to be? We know extrusive movements tend to be the least stable of orthodontic movements. Even with bonded retainers and removable retainers, these guys can still intrude en masse. So we've got to bear those stability parameters in mind. Center lines, we want to maintain the upper center line, that's sacrosanct. And when it comes to the lower center line, again, my opinion is we can accept the lower center line moving to a degree. There's no crossbites. I've put down here, accept rotation of the lower left four. I'll come back to that on a separate case. Right, let's now have a look at this case. So we've got 9 aligners for the upper, 7 aligners for the lower. Let's tick these off, we're going along. Great. So if we go back to what our slam was, is that we wanted to procline the upper incisors and we wanted to use IPR on the lower arch. So let's have a look at the IPR. So it's localized to the lower right 2 region, which is where the IPR is going to take place. And there's no IPR plan for the upper incisors. So let's now have a look at how these upper incisors are unraveling. Great, we can see now we've proclined those upper incisors. And again, seeing needs to be believed. So for me, it's very much about being objective. Let's do the superimposition. We can see the purple where those upper center incisors start, the white where they've finished. We have pushed those guys forwards. There's no expansion taking place posteriorly because there's no white which is showing. Let's look at these lower incisors. Perfect. You can see we've relatively maintained them and there's been some IPR taking place in the lower right quadrant. Now, if we bring things together and have a look from the front, we can see that there's been no significant change. The lower center line is still pretty much where it once was. Okay. Now, let's have a look at a second setup of this case. Now, before I change, let's just bear in mind the overbite hasn't changed. The overbite has stayed exactly where it was. Now, in the second setup for this case, let's have a look at this. Let's watch this guy go through. So we can see that overbite's improved significantly in this case. We've got more blue attachments on this case to allow those extrusive movements to take place. Now let me just show you these lower incisors, guys. Cool. So the purple is where they started and the white is where they finished. They have been pulled up. They have been extruded. And we've described that as being 1, not predictable with aligners, 2, not being particularly stable. So this isn't a setup that I will be taking forwards. If this came back to me first, I'd write back to the lab saying, guys, I've had a look. There's lots of extrusion taking place. Please take away the extrusion for this case in the lower incisors, and let's accept the overbite. Okay. I'm going to stop this and let's go back to this clinical case. Great, so hopefully we're seeing that. So that's where we started off. We've got our upright or retroclined upper incisors, our mild crowding both upper and lower. And here's what we've got to at the end. So we've proclined the upper incisors, no IPR, done some IPR on the lower arch and aligned those lower incisors. Interesting, we look at the pre and post photos here. So there's a few things to notice. One is that the lower centerline is still off as it was planned from the outset. 2, we haven't changed the overbite. Now that's good because that's how we planned it. And I think it's one of the advantages of using aligners in reduced bite cases compared to fixed. One of the challenges with fixed appliances are, a bit like the analogy that I drew about placing an implant and not using a stent, is that you can go in different directions. Fixed appliances generally have a nature of being extrusive, and that also includes the posterior teeth. So they have a tendency to reduce the bite as part of how they work. So you have to be a little bit more tuned into that as a process. With aligners, that's not really a risk. As long as we've covered all of the teeth, we will be able to ensure we deliver that overbite without changing it. Also, from an aesthetic perspective now, if we were to home in on the patient's concerns, again, it tends to be we've come in, we're not happy with our smiles. But actually, it's the gaps that she spoke about at the beginning of her treatment. Now, there was no gap in between the teeth. This is simply due to a malocclusion. Sorry, this is simply due to the difference in the inclination of the teeth. And by straightening them, we can see that has now gone away. Cool. Let's move forwards to this more involved case now. So what have we got going on here? Well, we can see we've got a deep bite on this occasion. We can also see the lower arch crowding is more significant. We're looking at 4 to 5 millimeters of crowding. We've got some space present in the upper arch. We're also missing an upper right E, which this patient had removed, and they're missing the 5 there. Now, this time the upper centerline is to the left-hand side. So that's going to be a key thing that we want to try and resolve for this patient. So what's going to be our slam? IPR. So creating space, we want minimal IPR on the upper arch because we've got a spaced upper arch. In the lower arch, we want most of our space requirements resolved through using IPR. Proclination, we don't really want to push the upper incisors forwards. There's no need for that. In the lower arch, again, we've got to now make a decision. Which incisor are we going to choose? The overjet is average on the lower left one, so let's use the lower left one as our marker. Please procline the rest of the incisors to the lower left one. And again, I just want to clarify here, we're not proclining the teeth wholesale. We are simply getting the other teeth to meet the position of the other teeth. So there's no risk of exacerbating recession and so forth, because fundamentally the lower left one doesn't have a recession defect. And the rest of the teeth are just going to come to the same position. Now, when it comes to no expansion for this case, or minimal, when it comes to our limitations, okay, so we want to maintain the overjet because it's ideal on the lower left one. We've got a deep bite here, and what I've written here is to overcorrect to an edge-to-edge position. Saying, well, hold on, Farooq. No, we want to get it so it's 20 to 40%, like you said at the beginning. Yes, that is true. Aligners struggle to correct deep bite cases. And one of the ways to counter that is when we see a deep bite is to overcorrect. So rather than in the setup correcting to the 20 to 40%, we overcorrect it to the edge-to-edge position. Now I'll show you in the case setup how that looks and how clinically it expresses itself. Essentially, there's a bit of slop or there's a bit of give in the system. We need to over-egg it to make sure we get what we want from it. We're going to intrude the lower incisors. That usually tends to be the way of correcting deep bites, as it tends to be the etiology. Buccal segments we're going to maintain. When it comes to the center lines, we want to make sure we correct that upper center line to the right-hand side. The lowers, I'm happy to accept in any direction. I've put down here to maintain the space of the upper right E. Now, yes, they're missing teeth. They're not bothered about that, but I still want to tell the laboratory what's going on with that space so they don't try and close that gap, and something we're going to maintain for our prosthetic treatment at the end of treatment, potentially implant or a bridge. Either way, I'm happy with that space as it is. Let's have a look at this case. Perfect, so hopefully we're seeing the setup there. Cool, so here we are with this case. Let's make sure it's the right patient. Excellent. So here's a cheetah's case. So let's watch those parameters take place from our SLAM. To recap, we wanted to overcorrect the deep bite, we wanted to correct the upper center line to the right side, and we wanted to resolve the crowding of the lower arch through IPR. Great, so it looks as though we've got what we wanted there, but let's break down the arches. So let's now have a look at the upper arch. So we can see alignment's taken place and the upper center line has moved. And again, if I want to work out how much that has changed, I'll put my grid on and I will see how much that has then changed. Let's have a look at the lower arch and see if we delivered our space requirements through the IPR as we had planned. Where's the proclination taking place? Great, so we've aligned those incisors there. Let's put our superimposition on. We can see there's no changes taking place to the lower left one, and the rest of the incisors are meeting that tooth. Now, one of the key things we wanted to look at again is the occlusion, and I will continue to do that. I think it's the best way to us to ensure we don't get caught out. So let's now have a look at the occlusion. So we mentioned at the beginning, we had an ideal overjet on the lower left one, and we get to the end and we still have that overjet maintained. Now, the overbite has been overcorrected. There is a 5% or even a 0% overlap between the upper and lower incisors. Let's have a look clinically and see how that has now manifested itself. Great, so here we've got our predicted plan at the bottom here, correcting the upper center line, closing the space in the upper right too, and in the, oh sorry, my laser's not on. And in the lower arch, we wanted to align the lower incisors and procline the rest of the incisors to the position of the lower left one. And here's clinically what we delivered. So we've closed our space in the upper arch here, we've aligned our upper incisors, we've aligned our lower incisors as well. Now I mentioned to you guys about the deep bite. So we overcorrected in the plan, but look, clinically, we've improved the bite. It's probably around 40% now, but we haven't got it to that edge-to-edge position because the aligners are going to struggle to deliver deep bite correction completely. So we over-erg it. We always aim for edge-to-edge in our deep bite cases so we can deliver this amount of overbite correction. And that's a neat trick when it comes to aligners. And then there's always a kind of a background thought, well, Farooq, if it's not that precise or we can't quite get it right, why should we do it? Well, I think that is an interesting thought process, but actually it's the same with fixed appliances. It's virtually impossible to treat a fixed appliance case without doing some form of wire bending or bracket changing towards the end. And we've just accepted that's how fixed appliances are. We will have to customize the case at some stage. And customized setups also feature as part of that process. But that's unfortunately how alignment of teeth are, regardless of which appliance you use. There's biological variation. There's also issues with delivering things 100% when it comes to forces. I think rather than saying that's a bad thing, we should understand it, and then we can find out ways to work around it, like we've done in this case. So next, this is a bit more of an evolved case now. So we're looking at a class 2 division 1 case. This is where we've got an increased overjet now, 5 millimeters. We've got mild crowding in the lower arch of approximately 3 millimeters. We've also got mild crowding in the upper arch as well. We've also got this rotated and wickedly rotated lower left 4. Now that rotation is around about 30 degrees. If you recall right at the beginning, we compared posterior tooth rotation correction, a bit like a boulder. And by pushing on one side, we're not going to be that predictable at sorting it out. So let's look at this. I'm sorry, the overbite is increased. So how are we going to put together this patient SLAM? Well, we want to mostly resolve our space requirements through IPR. We don't want to procline the upper incisors. They're already further forwards. The lower incisors, we want to procline them to the most forwards position of the lower left one, and no real expansion. Now, when it comes to the overjet, how do we want to correct this? Well, partly it's through proclining those adjacent teeth, but also we want to retract the upper incisors. We want to bring them back to close that overjet. Overbite, as you know, we want to correct to an edge-to-edge position. Buccal segments we're going to maintain, and we're going to maintain the upper centerline and accept the lower centerline. What I've highlighted here is we're accepting the rotation on this lower left 4. And I'm going to show you 2 setups next, one with it not corrected, one with it corrected, and we'll look at the different outcomes. Biju, I find if I don't pretend to say it's slick, it actually is quite slick to then transition. I think if I talk, that's a problem. Talking's a problem. So here's the case. And if we look back at our SLAM, it was to go back, want to retract the upper incisors, bring the lower incisors forwards to the greatest position of the current tooth. So essentially we want to do that. And also wanted to overcorrect the deep bite as well and maintain the lower left 4. So let's see that taking place. We can see we've overcorrected our deep bite there, and we've got the alignment of our dentition. We want to do it mostly through IPR. We can see the significant IPR that's taking place there for our crowding. We also want to retract the upper incisors, right? That was the key way. I know it's one of the questions we had earlier on as well, is that, well, how do we predictably work out which way we're going to move the teeth? As mentioned, we will dictate that. So here we wrote to the laboratory and said, retract the upper incisors. So we look at the very beginning of those 2 central incisors. Again, we can correct the alignment in 2 ways. We can bring the upper left one further forward, or we can retract the lower upper right one. So here we've retracted the upper right one into a smaller position, into a more palatal position, and that's going to help us with our overjet. So therefore we've gone from that position to that position there. Sorry, that's the upper left one. We retracted the upper left one to meet the position of the upper right one. And we could have gone the other way. We could have took the upper right one forwards to meet the position of the upper left one. So that's our decision as how we do it. And passing on that information to the laboratory, make sure that we get it in the right way. Now it comes to low arch, we mostly wanted to resolve it with some IPR. So we've got an IPR there. We also wanted to push the lower incisors forwards to the position of that lower left one. And you can see that's what we've done. That has helped us with our space requirements as well in that process. Our superimposition confirms the lower left one has stayed where it is. Everything else has come to meet it. Now let's have a look at the occlusion. Again, we can't get away from the occlusion, guys. Great. So we wanted the overjet to be maintained on the upper left one, and that's where we got to at the end. So we delivered our occlusal parameters. We've also overcorrected our deep bite as well for this case. Now it was that lower left 4 that was annoying. So let's go back and have a look. We can see the lower left 4 has not been corrected through treatment. It's been kept exactly where it was. Now I'm going to draw you guys' attention to the number of aligners. So we've got 9 aligners at the top, 11 aligners at the bottom. Okay, let's have a look at the second setup, which I've got here. Perfect. So this is a case where we've asked them now to carry out full correction, including derotating that lower left 4 as well. Let's have a look at, and we've also incorporated some expansion into the case as well. And I want to just demonstrate what changes those 2 then make. So when it comes to looking at the amount of IPR, that's also changed as a consequence of those movements. We've had a bit more, we've had to add some on this lower left side for that rotated lower left 4. On top of that, we've increased our number of aligners massively. We've gone from having, let me just recap my memory, 9 and 11 to now having 17 and 22. So we're looking at much longer treatment for this patient. Let's have a look at that lower arch now. So you can see that lower left 4 specifically is being derotated. We've got a whole host of attachments now to help that movement take place. Derotating a tooth isn't easy posteriorly, so attachments are there to make it more predictable. Grand. Now let's have a look from the front. So when we're looking at this case now, and we're describing the process of carrying out orthodontic treatment for alignment or comprehensive correction as well. When I'm now describing these two options to the patient, I will get the setups done and say, okay, well, which one of these two would you like? Actually, the anterior teeth, there is no difference between the two. We've got an increase in duration and commitment from the patient on one side. Also, we've got a reduction in predictability because sorting out a lower left foot is not easy to do, even with the attachments and the IPR. So now put it to the patient as to what they want. And again, I will be very careful not to steer the patient. And again, recently, as I mentioned, that one case I saw, didn't expect the chap to be interested in any form of comprehensive orthodontic treatment, especially not lingual appliances, and that's what he went for. So I put it to the patient, if you want to have all the bells and whistles and get it textbook perfect, this is the option for you. If you just want to get the anterior teeth corrected, here's a second option. I've done both of them, happy to go with as it is. And if the patients choose a comprehensive option and you guys aren't comfortable delivering it, say, great, I'm glad you've chosen that, you know what you want. Let me now pass you on to somebody who can do that. Or if you've done the further training, then you're the person for it. Great, next we're going to go on to the last case. And this has come about again through some of the questions that you guys have asked previously about what about spacing, Farooq? Can you treat a spacing case with aligners? So let's have a look at a spacing case. Great. So this example ties in a few different ideas. So when we're looking at this chap's case, we can see we have spacing in the upper arch. It's about 2 millimeters in the upper arch, and we've got some space in the lower arch as well. Slightly less, around about 1 millimeter or so. Also, if we draw attention to the shape of these lower incisors, we can see they look quite conical in their shape. So it's starting to question mark, well, can we do IPR in this case in the lower arch? So what's our slam going to be for this space case? Well, we don't want any IPR on the upper arch at all. I've put down here minimal IPR on the lower arch. I'm saying, well, hold on, Farooq. He's got spacing in the lower arch. He doesn't need any IPR. We've got to bear in mind the arches work together. So if you've got more space in the upper and less space in the lower, to close space, we will bring the teeth back. We will bring the teeth back to close those gaps. If there's less space at the bottom than there is at the top, the bottoms will be brought back, the uppers will be brought back to a degree, but not any further than that. So therefore, there will be some space to left in the top. And the only way to fully close the space at the top is to essentially create more space at the bottom to make the spaces equal. Once we've done that, we can predictably then bring both top and bottom teeth back to close those gaps, and there's no spaces left over. And I think that's a really nuanced point, because patients will come in and say, I don't bother about the gaps in my top teeth. And they go, okay, great, I'll just do braces on your top teeth. But actually, when we break down how do you move teeth, that when you have a class 1 relationship, which is most patients, they move synergistically, they move together in that process. We don't really want to procline teeth, we don't want to do any expansion for this case. When it comes to our outcomes of occlusal measurements, actually it's a class 1 case. We want to maintain the majority of our parameters that we have. Maintain the upper centerline, accept the lower centerline. Now what I've put down here in red is I want to close the space by retracting the anterior teeth. Why have I specified that? Well, the laboratory need to know, are you going to want to push the back teeth forwards into the space or pull the top teeth back into the space? It is always easier clinically and more predictable to bring the top teeth back into that space. There's less teeth to move, it's easier orthodontic movement to achieve. Sometimes we do want to bring the back teeth forwards, but it's more involved as a case. Sometimes we think about using elastics and other things to help us out. But essentially, this should be the default for the average case to bring back the anterior teeth. Let's have a look at this chap's case. Great. So I'm just going to show you those lower incisors again. So I showed you in the photo, it's a bit difficult to work out. And this is again why I do enjoy the online setups, is because you do get to have a second go at looking at the assessment of teeth, and you can tinker and tweak the plan as well. So look at these lower incisors, really quite conical shaped lower incisors, and that is of concern. Now let's have a look at this guy together. So here we are at the beginning, and here we are at the end. So we've closed our gaps. To recap, we wanted to retract both upper and lower incisors into those gaps. I mentioned about IPR, so let's click it on. So here we go. We can see there's IPR now. There's about 1.5 millimeters in the lower arch. That's now created an equal amount of space from the beginning in the upper arch, and now is also in the lower with that IPR. So we can bring them both back together. That's really good planning from the laboratory side of things. Let's have a look at just the upper arch. Cool, that's beginning to end. Superimposition shows we have retracted those lower and upper incisors. They've been brought back into that space. The back teeth have stayed where they are. The lower incisors, we've gone from having them further, we've gone from having them further forwards to them being brought back into that space. Our superimposition confirms that information. Now, why is the IPR on the 6s? Well, it's because, on the 3s. It's because we wrote to the laboratory and said, actually, we don't want any IPR on the lower 2 to 2. They're conical in shape. Please move any IPR posteriorly. So they've aggregated the IPR and moved it in between the canines and the premolars. Now, typically, we will hear the term 0.5 millimeters is the maximum IPR you can do. And that is true on a contact point. But that relates to Sheridan's work and also just the anterior 2 to 2 teeth. When we go posterior, there's far more enamel anatomically available to us, and we can push it to 0.8 millimeters. Now, very rarely do I go to those full parameters. If I do see the full amount, 0.8 posteriorly or 0.5 anteriorly, I usually then tend to tell the laboratory, can you add more teeth to the IPR? Let's just divide it up, make my life easier and for the patient. If there's lots and lots of IPR on all the teeth, I'm now starting to lean towards extraction therapy as part of my treatment. But it's great I've been through the process of doing the online setup to work that out. So that's why we went for the lower canines, in this case for the IPR. And it comes down to the prescription and specifying these teeth are conical, no IPR on the lower 2 to 2. Please move IPR posteriorly. And let's have a look at the outcome for this patient. So here he is at the beginning, and there they are at the end. It's not the true case. So I actually took this patient from the first image here to the second image in the middle. The third image is actually when he completed his overall smile treatment, and that's where he's had some composite buildups now to the centrals and to the laterals, because the shape of those centrals and laterals is also tapered and slightly rectangular. Again, I think this is where GDPs are in the ideal position. You can take them from all of these stages, whereas I'm restricted to go to just the second image that's there. And the patient's really happy with their outcome. Not only are the gaps been closed, also we've now given him a very broad smile. He's a tall chap and quite a big chap as well, and that really suits his facial appearance and what we planned from an aesthetic smile perspective. Again, he came in on the top left, I just want my gaps closed. He's left on the bottom right, having had his teeth aligned, having had the spaces closed, and also having had some bonding. And that's what he wanted. He wanted the smile to look broad and to correct what was the discrepancy, small teeth and gaps in between them. Great, I'm going to move on to attachment, guys. So changing tact now. So attachment, so these blue things that we keep referring to, the idea of them is that it essentially creates a more predictable outcome to the result. It features part of the 4 system. Again, we're going down the orthodontic wizardry. Let me break this down. There's a door. I like doors. If we wanted to open this sliding door, we would put a handle on the door. How would we orientate that handle? Well, it would be vertical, right? We would do that instinctively. We would put the handle in that position. And what is that? Well, that's perpendicular to the direction we want to move the door. Attachments follow the exact same premise. We are creating a handle on the tooth perpendicular to the direction we want it to move. And I think what I quite like about the CFAS lab is that they have different attachments in different orientations, showing they've engaged with this as a concept. They're not just the same ones on all teeth. So here in those central incisors, for example, we're going to derotate those teeth perpendicular to the direction of movement. Again, I'll show patients them actually on patients' teeth, and look, they aren't blue, they are clear, and they are inconspicuous. Now they come in an attachment template for both CFAS and for most companies that are using attachments. They come with a reservoir, essentially the red area, where composite is poured and then put on. Let's go through it as a process. With the paperwork that you guys will get, you will see where the attachments are on the teeth. Now, this is really useful. I always have this out on the side of the surgery. So the nurse and I both have this information in front of us. That's important because our nurses are usually loading up the template tray whilst I'm doing my etching and my bonding inside the mouth. And both of us know exactly where we need to go with the attachments. What we have here is the number, and the number indicates how long those attachments are on for. Now, for nearly all cases, they're on from the beginning to the very end of the case. So how do we do it? Well, here we have our attachment template. I use a variety of composites, and I just want to talk through them. So venous pearl tends to be my stable one. It's filled composite. It's relatively thick with respect to flowable composite, but it's relatively flowable with respect to conventional composite. So I find this is the right one for me to use for most cases. If you want to use flowable composite, which I know some of my colleagues quite like doing, Tetric EvaFlow is a good one to use. And I use that in one of the practices where I work. It tends to be a little bit more viscous compared to some of the other flowable composites, doesn't go everywhere. And Genial is one that Biju told me about. So it's one I haven't moved on to yet. He recommended it from last time. Essentially, I'm waiting to finish my Tetric EvaFlow, and then I'm going to get some of this. So as Biju tells me, it's quite a hard composite, very unlikely to come off, and it's got the properties of flowable when we're putting it into the attachment template. So here's me putting in some conventional composite. This is going to be my venous. So I'm putting it in, and essentially I've gone past the reservoir. I've created excess around it, and that's important to make sure it's fully filled. I've removed my excess after that. So that's ready to go. Next, clinically, we're going to carry out best practice. We're going to polish the teeth. I really like to use these pads for respect to isolation. I like the Optigate guard. I know it's a bit Marmite, but I quite like it. Isolations in mouth, I quite like using conventional etch in a two-stage total etch system, and Scotch Bond is one that I really quite like using. My reason for Scotch Bond is it's also got silane coupling agent in case I do need to use it for ceramic appliances. They're also there as well. Ceramic restorations. Then I light cure. Then I insert the template. I press firmly. I go around the template with my flat plastic. I'm pushing really quite hard. And this is to ensure there is no gap between the template and the tooth. Once I'm happy with that, then we light cure it. I'm maintaining my finger on there whilst the light curing is taking place. I then remove the attachment template, we light cure it again for another 10 seconds or so, and then I'll polish the attachments. And I can't stress how important it is to polish the attachment. I don't think anybody would now put a composite on without polishing it. And it's the same process here. There can be some shards, there can be something else which isn't quite right with it, it's overflowed. And the idea is we want to remove it, especially the excess, because the aligners that have been digitally planned haven't allowed for the tooth anatomy to be varied outside of the attachment. So if it is excessive, it's going to impact upon the fit of the aligner. I tend to use this tungsten carbide multi-fluted belt, which is very much the belts and braces for orthodontics. It's a staple of what we use when it comes to removing composite. I really quite like it. Sometimes I'll use a white stone as well. If there is a sharp edge on the actual attachment itself, I'll run my finger over it and I'll just polish the tip of it. It's really important not to make any gross changes to the shape of the attachment. If you do, it won't fit well, it won't deliver the movement predictably. And the only way it works predictably is by having a tight contact with the actual aligner itself. So what are the problems? Well, sometimes they come off and it's not the end of the world. If they do, I will then put it back on. I'll then ensure I'm using venous pearl, something filled, to ensure I get a better bond the second time. If the old aligner is passive, we can use the old aligner as our attachment template. What happens if the aligner is not seating? Well, if I've just put the attachments on and now I'm putting the aligner in, it's usually because I've not taken care of all the excess. So then I will go back over that tooth and remove any excess which is there. And again, I'll use the white stone for any sharp and uncomfortable areas. And I find myself doing this more now than I did previously. At the beginning, it was just about getting the attachments on. Yes, they've all stayed on, off you go. And now spending a bit more time to avoid the patients coming back. The very few things patients in aligner therapy will complain about. Having a sharp attachment is one of those few. So let's get rid of it from the beginning. I'm going to go on to interproximal reduction. So we've spoken about IPR, we've alluded to it. Now we're going to go through the clinical components. Before I do that, why do we want to do this? It's that argument of having a conformist approach to occlusion versus having a reorganized approach. So let's have a look at boxes. If we wanted to straighten up these boxes, there isn't enough space to be able to do it. So we have to make the boxes smaller to be able to deliver that. So let's make the boxes smaller. We've got the more than straight line, we've done our job. It is the same when it comes to the alignment of the dentition. That overlap of contact points we spoke about at the beginning, are the boxes overlapping? To get them into that straight line, we need to reduce the size of the boxes. So therefore, we carry out our interproximal reduction. Now, what happens if we don't do it? Which is a worthwhile question to ask. Well, we tend to then push everything forwards to accommodate all of those teeth. Now, where that line lies, there is no buccal mucosa which is visible, which means we've pushed those low incisors outside of that soft tissue envelope potentially. There's risk of recession, but also we've now taken a reorganized approach to the occlusion, especially in the anterior segment. We can think about having non-axial loading. There are the consequences of that as a process. Doesn't mean it's a no-no for all cases, but it needs to be very much carefully planned around the patient's biology. And actually what we want to do, a bit like our restorations, is most of the time go for a conformist approach. It's the same for planning tooth movement, which is why interproximal reduction is so powerful to maintain that. Great. How do we deliver it? Well, there's 4 general ways of doing it. The top left is my stable, is what I'll do most of the time, is using hand strips. And we'll spend some time going through that. There are some other ways to deliver that as well. So we have here, we've got a reciprocating saw, which is a glorified hand strip inside a reciprocating hand piece. At the bottom, we've got the bigger ones. We've got the IPR disc, which you may have seen, and there's an IPR burr. Now, I have the fortune of having all of these in my armamentarium. And I will, as I mentioned, mostly use the hand strips. I'll occasionally use the others, and my burr is generally restricted to posterior IPR. And that's the way I break it down. Let me now go through each one of those to give you some tips about it. First of all, using the hand strips, you can cut them in half. Now, the ones that I use are the ones that you see generally available, which are the Comet ones, available from Henry Schein and lots of other places. And the idea is that they are single-sided serrated strips. What that means is that they will deliver in different courses a certain amount on one side. So 0.13 millimeters is the heavier side and the yellow one is the lighter side. I will typically start with the yellow one to break the contact point, then I'll move on to the blue IPR strip. At the top here, I've written when I do it for what sizes. So 0.1 millimeter to 0.2 millimeters of IPR. Now to deliver 0.2, I simply double up the blue strip and then go in between that contact point. But I'll work through it sequentially because I don't want to have a difficult day. So starting off with the yellow is easy, moving on to the blue single-sided, and then doubling up gets us to 0.2 millimeters. That's a really predictable process to take place. The advantage of using hand strips, okay, well, we can do this. If we have teeth which aren't aligned, we can curve it around the tooth and carry out the IPR. Guys, if there's one thing to take about IPR from today, it's that IPR is scheduled for the interproximal contact point. It is not scheduled for where those 2 teeth may well be lying. And I'll explain that. So if we've got 2 teeth which are malaligned in this position, if we carry out IPR, we will take off some of the labial face as well, just doing it at the contact point. It's the interproximal area we want to aim for. Let me show that. So here we have our strip. We're going to curve it round. We're going to do the lower right 2, and we're just doing it at the greatest bulbosity of the tooth. We're then going to flip the IPR strip and we're going to curve it round. So now we're doing the same thing on the lower right 1. Because it's single-sided cutting, we aren't taking any surface away on the opposing tooth. Now, if we use something which is firmer and we didn't curve our strip, we're going to end up following this trajectory, which is going to take away the labial face of the lower right 2. It has to, because that's where it's making contact. That is the key advantage of using hand strips, is that when we have rotated teeth, we can individually carry out the IPR in the space we need it, which is that interproximal maximum point of those incisors. Now, when it comes to using things like reciprocating strips, discs and burrs, that becomes a big challenge to do. So using the reciprocating disc that we can see here, it's usually for greater IPR, 0.2 to 0.4 millimeters. Usually I've aligned the contact points first and then carried out this type of reduction. Let's have a look. Oh, sorry, let's go on from there. So when it comes to using the reciprocating strip, the key point is that it's parallel to the occlusal plane. If we aren't holding the disc parallel to the occlusal plane, then we can start to create ledges, and also we are now starting to change the tooth anatomy. What we really want to do is just reduce it from where it currently stands. IPR discs. So IPR discs, again, are used very similarly to reciprocating saws at 0.2 to 0.4 millimeters, again, parallel to the occlusal plane. Now we're going to take a step back here. When it comes to using discs, I will always ensure that I have a protector around the disc. And that's because I have lacerated 2 patients now, not using any form of protection around the disc. The cutting area is just the lowest aspect of that disc, and that's what I want to do. You can buy these plastic ones which are disposable. You can also get metallic ones as well. I prefer the plastic ones because it's easier to see where I'm going with my contact point. Now, when we're doing IPR, specifically with the discs and reciprocating saws, we want to make sure we're doing it in a safe fashion. And it's the ABC of IPR. We want to avoid soft tissues and cheeks. We want to ensure we are braced with a contact, with ensuring we've got a good finger rest. We want to check the contact point is broken. A, B, C. Let's see that. So here we're using a disc on an upper central incisor. We can see we retracted the soft tissues, both labial and lingual. We've got a firm finger rest. So firm finger rest. Once we've finished doing our IPR, we then, without turning on the actual disc itself, go through the contact point to make sure the gingiva blanches. So it's a neat trick. If the gingiva blanches, it means we've definitely broken that contact point. What can sometimes happen is whilst we're doing it, we just do it to the tips of the contact point. We don't do the rest of the contact point at the bottom. Actually, we've not created space in between those teeth, only part of the teeth. So going through at the end without turning on the actual disc, we can ensure that we are making contact with the gingiva. We have broken the contact point. When using the burrs, so burrs for me are things that I generally tend to do in the posterior segment only, tends to be around canines and posterior teeth. This is where I need a lot of space, 0.4 millimeters or greater. Here's how I typically use it. I'll hold the fast handpiece perpendicular to where I want to go, and I'll go in vertically, a bit like a crown prep. That tends to be the way. I use the STARS kit, and these burrs are readily available. Some of my colleagues will, for anterior segments, use the burr and they'll go in a labial lingual fashion. I tend not to do that anteriorly. I feel as though if I need to use it, I want to do it in bigger areas, and usually posterior is a safer place. Anteriorly, I can generally deliver it with hand strips and the discs or the strips. Now, measuring. So I would say that this is as important as actually doing the reduction. How much IPR have we done? So very kindly, the guys over at TOC lent me this video to be able to play. And we can see somebody using the IPR gauges here. And we can see it was too tight and it just goes in. That's when we know we've delivered the actual IPR that we needed in that section. So guys, that is key. What I like about the CFAS guys is that in your start kits, you will get an IPR gauge. You will get one of these. So you can then ensure that you are delivering it. And what I do is similar to what Biju was mentioning, is that once I've done my IPR, I've measured it, I'm happy, I'll then write it down on that form where it was prescribed for me. So I know how much I've done. Let's go on. What are the risks of this as a process? Well, there's risks of ledging. So here we can see a classic example of that happening. Now this tends to be when we've gone straight in with an IPR disc or burr or gone in with a reciprocating saw. I will always start off with the hand strips, and that's important because it creates my path of insertion. So I know I'm getting a feel of where the contact point is, but I'm also making sure that when I take my disc through there, I know I'm going to be in the right place. When we go straight in with the disc or the burr, there's always a chance that the tooth may be tipped or our hands may be tipped, and we're having to create that contact. We're having to create that line of access. Far easier to do that with a strip because it's so predictable. Poor contouring. So here we've just gone in too much. We've poorly contoured these upper central incisors now. And there's no real way back once you've created this inverted V shape on these central incisors. Soft tissue injury, things that I have done, and I wish I could, whatever I can say to avoid it, it would be to follow I would say, using the ABC approach is key. And also if you're using the disc specifically, using a guard for it. And being excessive, you feel as though you need to create more space, you carry on doing the IPR, you leave the prescription, or you haven't measured it, or you haven't made a note of what you've done previously. I mean, these appointments are weeks and weeks apart. Then it can lead to excessive space. And rough surfaces. So once I've used the reciprocating disc, the reciprocating saw, the disc or the burr, I will always go back in with a yellow hand strip. It's 0.06 millimeters. It makes sure the area is smooth. It also makes me confident that I've not created a ledge. A bit like when back in the day, when perhaps most of us were doing hand filing when it came to our endodontic treatment. Oh my God, it's been so many moons. But the idea of checking to see if you've created a ledge or not by reciprocating the hand file that you're using. The same way we do that with using a hand file when it comes to hand strip, when it comes to IPR. Let's go in there and check, have we created a ledge? And there's always a reprieve from it. So if we have done it, we can spend a bit longer with a hand strip. We can go back in with a disc, and now we know where the ledge is, we can polish it out. So what's our contraindications when it comes to doing IPR? Well, small teeth. Small teeth have less enamel. We've spoken about the tooth shape, specifically rectangular and conical shaped teeth. Severely rotated teeth, and that's because we just can't get access apart from to the labial face. But it's okay, we can work around it. We can ask the laboratory to stage it. Please can we only do 0.2 millimeters at the beginning? I can do that with hand strips. And can I do the rest of the IPR at a line of 4, at a line of 7, after the tooth has undergone initial alignment? And the laboratory can help plan that. Enamel hyperplasia. Also young patients, because their pulp are quite large, we want to do minimal IPR. That's perhaps going back to what Biju mentioned earlier on. For younger patients, perhaps looking more towards comprehensive correction of their malocclusion. And hypersensitivity teeth. If patients have already complained to you about the sensitivity of the lower incisors, please don't do IPR on their lower incisors. Move it to the posterior segments elsewhere where that sensitivity is not present. So when it comes to IPR, we know when it comes to caries and periodontal disease, and also changes to the pulpal tissues, it does not take place. That's on the premise that we stick to good practice. So not exceeding 0.5 millimeters on contact points anteriorly, 0.8 millimeters posteriorly, and it ensures that we are breaking the contact points and following those practices of measuring where we are. If we don't do that, those risks are entirely possible. So here's a table of me summarizing how I think about IPR. If I wanted to do 0.1 to 0.2 millimeters, and we use hand files. 0.2 to 0.4, I'm going in with hand files to create my path of insertion, then with my discs or my reciprocating saw. 0.4 millimeters and greater usually tends to be posterior areas. I again start with my hand strips, path of insertion, and then go in my burr. For both the discs and the burrs, I will always check with a polishing strip, which is a yellow strip. And for the guys when I'm doing 0.4 millimeters plus, I'll put some fluoride varnish on to ensure the sensitivity is reduced, because it's significant IPR at that stage. Now, how does it work? Well, actually for the strips, we're going backwards and forwards to create our IPR. With the discs, once we've gone through the disc vertically, we then want to go mesial and distal to make that space larger, same with the saw. And for the burr, it's the same. Once we've gone into that contact point and we've created enough space for the burr to go in, actually then we're going to carry on polishing the mesial distal side of the tooth to create that space to make it larger. Here's the paperwork that comes with it from an IPR side. And you can see here, for example, the upper left 3 and the upper left 4 region. We have 0.3 millimeters that's required. And it's telling us when we can do that. 0.2 at the beginning and 0.1 at a line of 2. If I had a severely rotated tooth, well, I'll actually ask them to delay doing the IPR until the contact points are better. So for example, if we look down here at the lower right 2 and the lower right 1, we've got a reasonable rotation. We've delayed IPR to a line at 11. It doesn't mean I have to wait till line 11 to do it. It means that's when the aligner movement has been scheduled to utilize that space. So I could do it at the very beginning, and that's fine. That will be maintained until we get to line 11 to use it. But it gives me that flexibility. And cool, just to reiterate that on the online setup, we'll also see this information about how much IPR and what stages to do it. So we don't have to wait till we get it and go, oh my God, I wish I would have changed it. We have it on the online setup. And then we can say, okay, cool, that's quite crowded there. Let's ask the lab to delay that to line 11. Now, black triangles, I mentioned this as being one of the risks of orthodontic treatment. So here's where we can correct it with IPR. We've got a black triangle that's there. We can use some IPR to make those sides parallel to those triangular teeth, and then use the aligner then to close those gaps. Guys, what I want to show you here is that this black triangle is small. It's not a massive black triangle. And these are ones where we can be far more predictable at reducing / closing it. But anything more significant, we are only ever going to be able to get partial correction to it. And I do inform patients that the processes that will carry out alignment, there is a likelihood we're going to get black triangles. We'll do what we can in treatment to minimize that, but I push it back to the patient. It's because your teeth are crowded, that gingiva never grew. I can't regrow that. We can try and disguise a little bit of it, but that will be it. Now, sometimes if it gets left at the end, there's also the option of having composite bonding taking place. But again, I try to tell patients it's only there to reduce it. To contour something that close to the gingiva can be quite a challenge with composite. Cool. So patient delivery, I'm going to pause there, guys, because that was quite a hardcore session. I am not running too bad. So it's we're going to have a break next. We'll have it for 10 minutes and then we'll come back and we'll go through retention, some tips, and also patient delivery at that stage as well. Biju, are we okay to stop there?
Yes, I think that's great. There's a few questions here, but we can maybe deal with those at the end.
That's fine. Let's do it at the end. Let's just aggregate those. Or we can do it at the start of the session. I'll let you choose, Biju.
Yeah, I'll tell you what we can do is, John, if you're there, maybe at the beginning of the next session, you can do a quick 5 minutes for us. I know John has to dash off.
Yes, no problem. We can do that.
Brilliant.
Perfect.
Okay, see you all in 10 minutes.
Thank you.
Okay, I think we're back. I'm just going to, before Dr. Farooq starts again, I just want to bring in John to cover a few things from the lab aspect. John's got something on this afternoon, so he's going to dash. So I think John, if you can cover some of the aspects in terms of costs and things, and there's one question also that's come up, which I think I'd like you to answer as well. But if you can
Okay.
talk about the lab side of things.
Okay. Hello, everyone. Let's go through the costs of the clear aligners. So we essentially have 3 packages. We have a 14 aligner package, a 21 aligner package, and then an unlimited package. There are many different ways to price aligners. We found this to be the simplest and the fairest. So with a 14 aligner package, you get up to 14 aligners. It can be single arch or dual arch. The 14 is the total number of aligners. So you can have 7 in the upper, 7 in the lower, and that will come within the 14 aligner package. And that costs £395. And remember, there's no VAT to pay through the UK lab. Also with that 14 aligner package, in fact, with all the packages, you get a free bonded retainer, a free removable retainer, and also whitening. So you get 2 5mm syringes of whitening at the end of the case as well. For those of you that are new to CFAST Smile True, when you first registered with us, we will also provide you a free set of IPR gauges with your first case so that you can measure you have done the IPR correctly. The 21 aligner package comes in at £695, and again that can be split over dual arch or single arch. It's the total number of 21 aligners, and again it's free bonded, free removable, and free whitening at the end of that. And we have the unlimited liner package, which is exactly what it says. It's £895. That's an unlimited number of aligners, dual arch. Again, with free bonded retainer, free removable retainer, as well as the whitening. Now, sometimes you'll get a case where you have 15 aligners or maybe 22, and you think that's a little unfair or just sneaked into the next bracket. And we do understand that. So, for instance, if you had a 22 aligner case, we would allow up to 3 extra aligners at £50 each. So rather than jump from £695 all the way up to £895, if you had 22 aligners, you'd pay £695 plus £50 for that additional aligner. And we allow up to 3 on each for those packages, just in the interest of fairness. There are no refinement fees with an asterisk. So if you're doing everything you should be doing and doing the correct IPR and the patient's wearing them for the time they should be wearing them, and for whatever reason the case isn't tracking, which can happen, everybody's different, then there's no refinement fees with any of these. There is a £75 setup fee for each case. So I noticed earlier that Farooq mentioned about 2 setups. So if you want to be able to compare a single arch and a dual arch setup, we can do that, but it will be 2 setup fees of £75 for that. So each case has a £75 setup fee, then whichever package it goes into. The only time we don't do a digital setup is if you're doing a fixed cased aligner package. Now, this is a small refinement package that we've put together to help you at the end of your fixed cases. And that's up to 3 aligners, and that's a fixed cost of £177. But it's always good to factor that in if you are looking to do your fixed cases. There's no digital setup. We'll provide you with 3 aligners every time. If you only need 1 or 2 active, then you'll get extra retainers to make up the number of 3. So that's it for the pricing, guys. It's very simple. I think you'll find it very competitive compared with some of the others out there. And we hope to see your work soon. Now, Biju, you mentioned a question from somebody.
Yeah, just to add a couple of points there regarding it's gone from my head. Turnaround times. Can you give us an idea of turnaround times?
Oh yes, thank you. Good prompt. Now, normally we would turn around within 10 working days. We are seeing unprecedented demand at the moment, and our lead time has risen. So please allow us up to 15 working days for this. We'd like to get the setup times back down to 5 working days and the actual line of production to 10 working days, but it is taking longer at the moment. We have taken steps to improve this, and it will be coming down. We've just ordered another state-of-the-art 3D printer that's twice the speed of our current printers. And these are not cheap items, and that's on its way to us. That should be with us in the first week of June, and that's going to help us enormously. And we have recruited extra staff. Running out of space, so I'm trying to get more space in the lab as well with the cabins, but we are doing what we can to meet demand. But the sudden spike following COVID, I don't know if you're experiencing this in your practices, but we've seen the demand for aligners just go through the roof since last June, which is a fantastic problem to have.
Yeah, and just to clarify, all the pricing that John has talked about, we'll email that out to you, so you've got it in one place, so you can just review the pricing for the different packages.
Yeah. And it's on the lab slip, so you can't go wrong.
Yeah. And John, just one question here from Benjamin Seidel, if you wouldn't mind answering this one. If attachments are very important to achieving desired movements, why is 1, the variety of attachments limited? Although I don't think it is, but we can answer that. What is 1, the variety of attachments limited, and 2, the shape and or design of the attachments different between Smile True and Invisalign?
Okay, it's a good question. With regards to attachments being limited, I wouldn't say that our attachments are limited. We have a various range of shapes and sizes, from semi-conical to rectangular to square. There's a number of different attachments that we do use. This is based on our own R&D, our own experience with clear aligners. So it will be different from Invisalign. We're not just copying Invisalign with what we do here. We're doing what we think's best and right. So there's a wide range of different attachment shapes and sizes that we do use, and they prove to be very effective.
That's great. Okay, thanks for that, John. I think was there anything else you need to cover, or we're good to go?
No, I'd just like to say we look forward to seeing your work in at the lab. And don't forget, we are there to help. I would ask that you put as much detail, please, on your lab slip as possible, especially when you're mentioning veneers and crowns, anything like that you can tell us to help us get the setup right first time. It's good. Having said that, if you get your digital setup and you're not 100% happy with it, please bear in mind this is our interpretation of what you've asked for. So if it's not right, just pick up the phone, drop us an email, we can change it. There's no fee for changing the digital setup. So if you want something rotated a little more, I'm doing things with my hand, but because I've got a background on, my hand's not showing up. That's a bit odd. So imagine my hand rotating. So yeah, if the digital setup isn't exactly what you're looking for, let us know and we can change it for you, because we're here to work with you. And we look forward to working with you all.
That's great. Thanks a lot, John.
Thank you.
Now, Farooq, are you back with us? Oh.
Sorry, I left it there for a few seconds just to create a bit of suspense.
You give me a minor heart attack again there. Yeah.
And then, yeah, I was thinking of just leaving the microphone off for a few minutes as well to see how you'd cope with that, but I didn't. I spared you. Cool. So right. I'm just going to go back to share my screen and not winding up Biju anymore. Okay, so looking at patient delivery and monitoring now. So this is going to take us home, guys. So we're going to look at this. We're going to do some troubleshooting as well. I'm going to look at retention. So this is the end of the journey, really, and hopefully that's what today has been. We've taken from the beginning of doing our assessment and our records and doing our case setups, and now delivering the actual liners to the patients, retention, and then troubleshooting. So we have instructions again with that I have, but also Smile True have them as well, as to what patients should do. So it's a full-time appliance. Now, wear of them is always a bit variable. So I'm going to describe as to perhaps why there's a variation in what people say about wearing the liners. Typically, the CFAS Smile True documentation will describe 10-day changes. Okay, so I'm going to go into that in a bit of detail later on. We advise patients to always keep one of their older liners in case they lose or break one of their liners. They have an option to go back, so that's what they need to do. They take it out when it comes to eating, drinking, and that's anything apart from water. You had a lady yesterday, and she was trying everything under the sun to try and work out if you could keep it in for other things. Can I have hot water? Can I have warm water? Can I have water with lemon? Can I have carbonated? No, just normal water, please, or nothing. Taking it out when it comes to brushing and taking it out when it comes to swimming as well. What's the experience for patients? So this is also something to describe to them so they know what to expect. It gets tighter after it's fitted. How strange is that? So after 24 hours, they'll get the maximum discomfort. And after that, it usually then tightens down. I'll tell them to use pain relief, whatever they normally take for a headache. Nothing spectacular. Speech. So speech for most patients actually isn't affected. For some patients, when it's inserted, they feel it's affected, but you can't tell the difference. And for some, it's genuinely affected, but it's few. For any of those scenarios, it's always idealized within a week. So patients go back to sounding perfectly normal. Their mouth can feel quite wet initially as the brain starts to think it's saliva, but like a denture, same thing, but then gets used to it. Now, mobility is something that really worries patients. So as the teeth start to move, we've got to think about what's the physiology of what's taking place. So if this is bone and this is tooth, the tooth moves by essentially reorganizing the bone around it. And it follows this process of moving through the bone. As that happens, sometimes the bone is expanded and is remodeling. And actually, there's quite a bit of space for the tooth, and it does become mobile, usually grade 1. But you have to be reassured that that process is going to resolve as the tooth continues to move. So we don't need to start taking off the appliances, taking off the attachments and getting worried. We've done our background checks. We've done our BPE, we've done our OPG. We know there's good quality bone there, and it's simply the process of tooth movement taking place. What I would say is, even with those assurances, if you're still unsure, then do take pictures, send them in, take some radiographs. At least it'll give you that reassurance and we can have that conversation with you. Homework. Now, patients have to do 2 main things once they're in their line of therapy. Well, 3, they have to wear it, but 2, they have to use chewy beans and floss. And these are really important for tooth movement. Chewy beans, let's go through that first. So the idea is the patient puts it in with the aligners in place. So I have some who take their lines out and then use their chewy beans. It doesn't work. And the idea is that they're simply applying a vertical force to push the aligner in. And it helps it to then stretch around the tooth and then helps to then get it back into the position that the plastic wants it to go. They use it for about 5 minutes and do it 2 to 3 times a day. And a neat trick is to get the patients to put it into their liner box. So when they're out and about, they have their liner box with them. Whenever they take it out, they put it back in. The aligners, they see the chewies, and then they are then stimulated to use it each time they take it out and put it back in. The floss is important. So floss, as teeth start to move, they can start to bind together and get stuck. And the idea of flossing is it just maintains patency through that space to a very small degree, allows the tooth movement to take place without binding occurring. What do the patient need to do to look after their aligners? Well, they need to brush them twice a day. So the light's quite bright there. They need to brush the aligners twice a day. So when they brush their teeth, they brush the aligners. To use soap, not toothpaste, because it can mark the aligners and makes it dull. Using retainer bright's a great idea, and using an ultrasonic bath. Both are available and easily accessible. And the idea is they simply get the sachet from Retainer Bright, put it into the water bath or into a pot, leave the aligners in for 15 minutes, and it makes it really bright. The ultrasonic bath, the reason why this is a good idea is because it's an automated process. They dip it in, but essentially it shakes the aligner, and it means that it's a very consistent way of essentially scrubbing and also having the effect of using Retainer Bright as well. So it's a really easy way for the patient to do it. A bit more investment from their side, but I find patients, when they start using their aligners, they're really keen to try and do everything they can to maximize the aesthetics, but also to get predictable outcomes.
Can I just come in there, Farooq?
Please do.
Have you come across this aligner cleaner, which is a white foam? That's it there, if I can hold this up.
I haven't, no.
I just got this. It's a company that starts to sell them over here. I think we should be able to we'll have them in the lab quite soon. But this is a bit of foam. Now, I have tested this on my wife, who's having some aligner treatment at the moment. I appreciate that's not a double-blind clinical trial with a huge data source, but anecdotally, she says it's nice, and it's got a small amount of whitening agent, so peroxide in there as well. So I think it's less than 1%, but theoretically that should clean your aligners and whiten your teeth while you're wearing them. So that's something new that I just came across the last couple of weeks. The company sent me some samples, so just if you want to, I'll send you some. You can try. Let me know what you think.
That looks good. I'll give it to my wife, and then we'll have two wives. That's it. That's pretty much all the evidence anybody needs.
Absolutely.
Oh, thank you for that, Biju. And finally, what we've got down here at the bottom is that what happens if they lose it? Not common, but what happens if they lose it or break it? Well, the idea is that they're going to contact the practice. If they've worn their aligner for 7 to 10 days, then we progress them to the next one. We essentially jump to the next one. If it's less than that time frame, then we ask them to go back to the old aligner. We get a new one ordered from CFast Smile True, and there's a cost incurrence there, and the patient then has to absorb that. What I say is that in the first instance, tell the practice as soon as possible, and take a picture of your teeth, and then send that into the practice, and then I'll have a look, and I'll decide what's the best stage. And I usually contact them back in the same day, say, yeah, great, go back to your old aligner or go to your next aligner. And then we go forwards from there. So monitoring and reviewing. So we've got our treatments. What are we doing when the patients come back in? Well, they're really straightforward appointments. It's probably the best thing about aligners is that we've done all the planning from the beginning. We've clinically delivered the aligners. We've done our attachments of IPR. And now we're essentially making sure that it's taking place as we've planned it. So we get up our online setup, we move to the aligner that the patient's on, and we simply see, is that what's happened to the teeth? A neat way of doing that, because it can be difficult looking at the screen and then looking inside the mouth, is simply get the patient's aligner, take it off the teeth, and look at the position of the teeth on the aligner, look at the position of the teeth inside the mouth. And you can see whether or not it's been delivered. Now, tracking is a terminology which gets used, and I want to explain what that means. Tracking is the tooth moving according to the online setup. How do we assess that clinically? Well, we describe looking at the tooth and the alignment, but also we get an indication from looking at the aligner itself inside the mouth. So when a tooth is tracking, there is no gap between the tip of the aligner and the incisal edge. There is no gap which is there. And that's because the tooth has moved to where the aligner was planned to be. Now, if there's a gap which emerges between the tip of the tooth and the aligner, and it's been in for, say, 10 days or 2 weeks, then that tooth has now lost tracking. It's not going according to plan. It's not the end of the world. And I'll describe to you what my tips are about how to manage loss of tracking for patients. We also want to check the attachments are all in place when the patient comes back. We're going to carry out any further IPR if it's been staged. And what I do for all cases now is that I will have some floss to hand and a yellow strip. And the idea of the yellow strip is just to ensure that the teeth aren't overly crowded together and there isn't any binding happening. Yes, we've planned this case digitally, and yes, we've delivered the IPR as has been planned. But sometimes teeth can just get stuck together. And the idea of using the yellow strip is to ensure that there is some leeway there. If the patients have been flossing well, then usually there's not much to do. But if they haven't, and actually it's quite tight, I may then go with the blue strip just to relieve that contact point for the teeth that are actively moving. So there's space for it to move forwards or backwards. Now, when it comes to the stages of CFAST Smile True treatment, it will be divided up in stages. So say you've got 14 aligners for a particular case, you'll be sent the first 7. And what will be required is that at aligner 7, you contact the laboratory to get the next set of 7. That's a really key point that you have to be engaged with. But also it gives you an opportunity to get some extra aligners, and I'll describe how that process then works. So let me talk to you about wear first. So initially I get patients to wear the aligners for 10 days. So 10-day changes. Now I review them after 4 weeks. And I do that very specifically. Now some patients, their biology will be such that actually they only need to wear their aligners for 7 days at a time. Other patients 10 days, other patients 14 days. And we just don't know that from the outset. We've had some questions at the beginning about the age of patients. Now, unfortunately, it's not a predictor. Older you are, the slower tooth movement, you need to take longer. We need to evaluate each patient. And I think that is a fair, and this is a fair way of doing it. So they wear it for 10 days each to begin with, and then they're wearing the third aligner for 7 days or 8 days. They get given 3 aligners at the beginning. Now, when they come back in and they see me at that 4-week interval, they've worn aligner 3 for about 7 to 8 days. If the aligner is passive, i.e. there's no gap between the tip of the tooth and the aligner, and it's tracking well according to the system, then we're down to 7-day changes. I give them next set, pat on the back, and say, off you go, you're good for 7 days. You're good for 7-day changes. Now, if they see me and actually it's nearly there, but not quite, I ask them to continue wearing for 10 days. They will now be on 10-day intervals through their aligner treatment. If they come back at that 1-week interval for aligner 3, and actually it's not passive at all, then go, hold on guys, we don't want to go too fast here. Let's go back to 2-week changes for your aligners. Now, most patients I find will fall into the first and second category, but very few, and there are some that will fall into the last category. And I think it's about having that awareness that biological responses can vary. So we should also vary our plan for their aligner wear according to that. Retention. So retainers, so we've got vacuum form retainers, which are very similar to the aligners. We've got bonded retainers, which go behind the teeth, and Hawley retainers. Now they are generally the most spoken about retainers. I'm going to focus on just vacuum form retainers and bonded retainers. I find that this is generally what most people will use these days, and it's the gold standard to have both retainers in place. Now I mention that because if a patient decides not to have one of these retainers, for me that's a real alert that we're going to have to talk about this. Now, if a patient only wants to have one retainer, then I'll say you have to have the vacuum form retainer. We'll also make a note in the clinical notes that the patients refuse to have the bonded retainer, and there's a risk of relapse as a consequence. Now, with the vacuum form retainer, the patient has to commit to wearing them every night if there's no other retainer that's there. If the patient decides to have no retainers in place, well then actually from the beginning we're saying let's not carry out orthodontic treatment. Because if you're not committing to lifelong wear of retainers, there's no point doing braces. You're going to end up having crooked teeth at the end after a while anyway. So retainers are absolutely key in the consenting process, but also key for us to clinically deliver at the end as well. So how do they come? Well, they come on a jig. So the jig is something which goes over the incisal tips and essentially houses the bonded retainer there. And there are a few different ways of getting a bonded retainer. This is probably the most straightforward. You can also get them that there is no jig and they're simply customized to the actual tooth and they come just with some wax to hold them in place. There's a third way, which I know Biju quite likes, which is to use Flex Tech, which is essentially a ribbon which is quite flexible, and that gets inserted and is essentially customized inside the mouth, avoids any indirect things coming from the laboratory. So there are 3 different ways. I'm going to focus on this one as I feel it's the best way to start off doing bonded retainers, and you can explore other ideas after that. So we're going to carry out, and Biju, thank you for giving me these slides. We're going to etch the surfaces, we're going to bond them, like yours we typically do. Nothing spectacular at this stage. Next, we're going to insert the bonded retainer using the jig, and we're going to put flowable composite onto it. Now, sometimes I'll use flowable composite, which is most of the time. Sometimes I'll use filled composite as well. But the idea is that composite then goes on. Now, how does the composite go on? Well, here's a picture. There is the wire going on the midpoint of the tooth. And what we essentially want to do is try and cover as much of the incisor lingual surface as possible, essentially like a palatal veneer. We want to keep some margin from the incisal edges and also the mesial-distal sides. So it's about 1 millimeter clearance. This is what I find looking back at my cases tends to work the best. Why we're doing it this way? We want to maximize the coverage of the composite to the tooth. And that makes sense to ensure that our bonding strength, our bonding is as much as possible. The more we have, the better. We don't want to encroach on the mesial-distal sides because actually if it goes interproximally, it's a nightmare to clean for us. Also, the patient can't clean interproximally either. So only the wire is supposed to go interproximally and the composite is on the tooth surface. And that's the best way I found to do it.
If I can just
once we've done that, we want to please do.
We just go back to the previous slide. One thing I would suggest, which is not very clear on this, is before you seat this stent, I just put a little bit of flowable composite on the tooth first, and that way the wire is sort of sandwiched between composite. So this tooth composite wire and then composite. You don't need to put much, just a little bit, and that I feel you get a better result. If you do it this way, sometimes I feel that there's a gap between the wire and the tooth, and I don't think you get as good retention. That's just anecdotal, but I tend to be, it's just a small drop of flowable composite on the tooth before I seat the stent, the retainer.
Thank you for that, Biju, and thank you for coming in there. I did miss that bit out. Yes, absolutely. I mean, I think there's a poor quality slide here because this is actually Biju. But yes, absolutely. I also follow the sandwich technique, and it's again to see great that Biju and I have an agreement on how we do that. Is that I'll put a little bit of flowable on first. I know Biju prefers to use a filled composite underneath, and then have that sandwich process. So tooth, composite, wire, composite again on top of it. And I absolutely agree, even theoretically, Biju. I mean, I think the idea of having the wire against the tooth without anything bonding the two together means actually we've got less to keep it in place. So I think that's a really good trick, really good tip to bear in mind when it comes to bonded retainers. And then essentially it's become more like a composite splint. We're essentially using the composite to do most of the work, and the wire is essentially just for the interproximal area and to maintain that shape. After that, we're going to trim distally to where the actual bonded retainer is on the jig. We want to take it off the jig now, of course. So we use a burr to then drill that off, polish the end off the actual wire, maybe add a bit of composite to cover over that sharp edge. And then we're going to polish the excess composite that's there. And I try to, and again, at the beginning, I was just quite keen to get it onto the patient's teeth and then to kick them out the door. I do a lot of kicking in my surgery. But again, as time's gone on, I find with the liner therapy, we've got two main complaints I find. One tends to be the attachments are an issue. The second tends to be, well, actually, when it comes to the retainers, the wire retainer is noticeable. Why is it so lumpy and bumpy on the side? So now I try to make sure that I polish away the excess and try and get it so it's quite smooth at the point of insertion. So at the margins of the composite restoration, it's relatively smooth for the patient. It's a gradual increase up to the actual wire itself. So what's the retainer pathway? Well, here's where there's a knack to it, I feel. We want to give the patient a bonded retainer. We want to give them a removable retainer. How do we coordinate that with using the laboratory? Well, when your final set of 7 aligners, CFAS laboratory will usually send out the final VFR as well as part of that final 7 aligners. So the idea is that when you're requesting your final 7, you ask them not to give you a vacuum form retainer. At the end of your 7th aligner, you're happy with the position of the teeth. You then take an impression for a bonded retainer. You send that to the laboratory. You ask the patient to carry on wearing the final aligner as a retainer. You get them back a few weeks later, you fit the bonded retainer. You then cut a window in that final aligner because it won't fit now, the bonded retainer is in place. So you make a small window just like this, using a BB scissors, quite easy and simple to get hold of, to act as a temporary retainer now. They've got the wire in place, they've still got the nighttime retainer to wear. and then a new impression is taken for a final vacuum formed retainer, which goes to CFAST, and they then make that final retainer over the bonded retainer. Now, the key point in what I've described there, as particular and peculiar as it is, means that the patient at no point in time is without a retainer. And that's really important. If we leave them for a week, there will be that case where the teeth do move, and then you have to go through retreatment, and it gets quite complex. And this is also the advantage of using aligners, is that their aligner can act as a retainer. So we can afford that. With fixed appliances, it can become a bit more of a challenge to get these both synchronized. And how are we going to look after them now they're in their retainers? Well, I will monitor them for a year afterwards, and that's part of the treatment that I offer. Alignment treatment, and then also a year of monitoring in retention. I'll see them at 3 months, and I'll see them 9 months after that. That's to check to see how they're going, also to ensure they're still wearing their retainers. I think it's quite powerful to have an appointment for your retainer. The patient realizes that it's not finished, they are still contributing to the process. I'm going to go into troubleshooting. So lack of tracking, which is a common thing to hear, a common concern to have, and it's rightfully there. We've got to diagnose what the cause of it is. The main cause usually is the patient. It's them just not wearing the aligner well. And this is a typical presentation where we can see in all of the incisors, there is a massive gap between them. So this patient hasn't worn the aligner for a while, potentially since they last saw you, they're coming to see you, they whacked it in just to try and trying to keep you on board. Now, lateral incisors are peculiar teeth. They're quite small. And generally, if there's a lack of tracking on one tooth, it tends to be lateral incisors. I mean, my theory is it's because they're in between a large tooth, central, and a canine, and therefore the plastic just struggles to engage with it and is better suited to bigger teeth either side. So it loses out. But it's quite common to have lateral incisors have this lack of tracking. How are we diagnosing this? Well, actually, there's no lack of tracking on the central incisor, you have to believe it, but no lack of tracking on the canine either. And it's simply just that one tooth. So now I'm not really blaming the patient at this stage. Now looking at, well, actually, it's probably just this tooth which is a problem. We'll talk about how to correct it. When it happens, what to do? Well, like this photo, take photos, record what's taken place. Contact for support. Now you've got the imagery to have that conversation with the laboratory with. Now here, this is actually from John. John gave me this information that 40% of calls that they get of problems of patients in treatment are to do with lack of tracking. Half of those are to do with patients not complying to it, but the other half is actually the tooth movements that were planned were quite complex. They didn't really stick to that process of alignment of the teeth. Maybe it's posterior teeth that go in alignment. It's complicated movements at that stage. So what happens if it takes place? Well, now we're looking at how much plastic is overlapping those incisors. What's the quantity of this lack of tracking of the incisal tip to the aligner? And here's my thoughts on how it works. So if it's up to 1 millimeter, we're going to continue to wear that same aligner. And we're going to wear it for 14 days though. So we're going to extend our time with it. If it's 1 to 2 millimeters, we're going to go back an aligner. We're going to wear that for 14 days. We're going to see each other again to make sure it's all on board. If it's greater than 2 millimeters, we'll do the same thing. Now, the difference here is that, oh, sorry, just describing that. Now, if it persists after we've carried out this intervention, I think this is where, again, CFAST have it tuned in quite nicely, is that when we're requesting our next set of aligners, we finish 1 to 7. We've got lack of tracking on our lateral incisor. When we are about to request our new aligners, rather than just requesting it, we'll take some new impressions or scans. We'll send that to the laboratory and say, guys, I've lost tracking the upper right 2. Can you make the next set of aligners based upon the position now of the upper right 2? So when those aligner 8 comes back, actually, it's seating really well now on the upper lateral incisor and we're on the way. So it's really nice to be able to have that break in treatment to be able to refine things as we're going along, rather than just doing it at the end as some other aligner companies have. If it's 2 millimeters or greater, there's something not quite right there. And that's the point of time I'm advising patients, we may be in treatment longer than we initially planned because it's not working that well, either because of your compliance to it, your biology, or the tooth movement that we've planned to do. So tips. So what are we looking at for when we're doing our cases to summarize the type of patient we want to treat? God, sorry, I've got my laser pen on it stopping me from being able to see. Okay, so we're looking at patients. Are they going to have aligner therapy? Well, do they have crooked teeth? And if the answer to the question is no, then don't proceed. And it sounds strange, but actually some patients are just very concerned about their teeth, and what they want to achieve can't be done through alignment of their teeth. They require other therapy, whether it's through bonding, through bleaching, but actually this isn't what they need. Aligners are fashionable as items, but it doesn't mean that they need to have it. It's still a health intervention and it still carries iatrogenic risks. If they have got crooked teeth, great. Are we able to obtain good consent? Have they understood what's taken place? If we can't, we don't go any further. If they feel by having alignment of their teeth that it's going to now give them better job prospects, the alignment of their teeth is going to give them a far better prospect when it comes to them finding a partner. Well, we know those things aren't true. So what is it are they getting what we're able to deliver? Periodontal health and TMJ, we're going to ensure that they are healthy to have this treatment take place. Can it be completed in less than 12 months? And I think this is interesting. This is a conversation I had with Biju, that actually when aligner cases go beyond 12 months, we're looking at quite complex tooth movements at that stage. Aligners are great, but there are limitations at delivering complex tooth movements that we've described. So at that stage, we're saying, well, actually, if we're looking at this quantity of aligners, we're going to now looking at 30, 40 aligners. Is this the right treatment for this patient to deliver their outcomes? And maybe we're worthwhile thinking of changing over to fixed or referring on to have that done for the patient. Have they been assessed by the forum? Has it been given the green light from the laboratory? If so, then they are the case for aligners. When it comes to case selection, so we've got a tiered process as to the cost of aligners and also, well, which ones, how many are we going to need for a case? So I want to give you guys a quick run through as to what I feel fits into 7 aligners, 14, 21 and 28. So 7 aligners are usually mild relapse cases. They've usually had orthodontic treatment before and it's really mild. We're looking at less than 2 millimeters of contact point displacement. When it comes to 14 aligners, we're looking at mild crowding, less than 5 millimeters, and now maybe 3.5 millimeters or so of contact point displacement. Why am I using contact point displacements? Well, actually, that is what we really want to correct. That is the clinical diagnosis of crowding. It's the contact points which aren't straight. So let's now get those guys straightened. So the 3.5 millimeters fits quite well into a 14 aligner case. 21 aligners, we're looking at more involved crowding, about 6 millimeters, and contact points which are greater now, around about 5.5 millimeters. 28 aligners, so these are the guys where we are looking at severe crowding, 9 millimeters or so, and we're going to have to think about expansion or advancement of the incisors, more complex tooth movements for these cases. Now, when it comes to planning appointments for these cases, this is how I break it down clinically. We'll have consultation. I always take photos of my consultation. We'll have records appointment, which are 20 to 30 minutes. Then we'll fit the aligners. So I give them aligner 1, 2, and 3 at the beginning. And we spoke about the 4-week interval we're going to see them at. I put my attachments on and start my IPR. And that's the longest appointment in the equation is the fit appointment. Now, I tend not to go less than that. Conventionally. Now, every so often I feel as though, yeah, I've got time left over, I'm going to make it shorter and I pull it down to 30 minutes and I'll always run late on that day. So the fit is an essential appointment. Getting the attachments on, delivering the IPR, making sure everything's been measured and you're comfortable then having set up the case. And that's what aligners are. It's very much about the setup being the cognitive, the grey matter being used actively. Clinically, it's more involved at the beginning. After that, it's a really nice journey to have. I know in my clinical practice, I'd rather have an afternoon of just seeing aligner reviews than seeing fix adjust. It's just a much easier way to spend one's time. Then I review the aligner. So they come back to me at 4 weeks' time. We make that decision. Are we doing 7-day changes, a 10-day changes, or 14-day changes? Carry out any further IPR, so relatively quick appointment at this stage. I review them at aligner 7. So at aligner 7, they come in to have it fitted. At that point, I'm requesting further aligners, or I'm taking new impressions to say, actually, guys, we've lost a bit of tracking here. Let's now get some other aligners made for aligner 8 to fit well. End of treatment. So we're going to have removal of attachments, photos. We take the impression for the bonded retainer, as I've mentioned. Patient keeps wearing aligners. They don't stop because it's no longer active treatment. And I tell them the process of your alignment does not stop until you've had both your retainers fitted. Fit the bonded retainer a week or so later, take the impression for the VFR, and then fit that VFR. Guys, that is the summary of the entire journey of aligners from beginning to end. Now, it isn't about what you use, it's about how you use it. There are a multitude of aligner companies out there, and I have and do use them. I teach with Invisalign. I teach Invisalign at Guy's Hospital. I use Spark aligners. I've used ClearCorrect, and I use CFast. It really isn't about there's no magic in the plastic. What there is planning the case carefully. There is having good support in that process. So it really isn't about what you use. I'm preempting a question which usually comes up: is Invisalign better? And the answer to the question, it doesn't make a difference, right? It's about how you use it. So this is my daughter at my wife's graduation. Her photos are probably still better than mine. And the idea is it's just how you're going to use the tools that you're given. The tools are able to do it now. There is nothing different about delivering a force through using plastic. It really is about how we're going to use it.
That's great. Thanks a lot, Farooq. That was, as always, fantastic. I think always learning new, so I picked up a few tips and tricks again, as I always do. Are you okay to answer some questions?
Yeah, can I just do the last two bits? There's 2 bits that I added on.
Yeah, sure.
One of the things I like about, actually, I just seem to like lots of things today, is with CFast is that you guys are very open to education. And I asked Biju about popping in this bit of work that I'm doing with dental tubules, about describing more aligners and go through aligner cases. And he was happy to do that. And I think it shows a company that's not trying to keep education as part of the process. It's about developing you guys as clinicians, and that involves also going to external sources. So I'm doing this aligner panel with a group of orthodontic consultants, specialists, and GDPs. We've got a real mix of people there with a variety of experiences. And that's going on the 7th of June. And it's free to view on dental tubules. And what I like about this, we've got some people there who talk with Invisalign, who are not employed, but are key opinion leaders for Invisalign. We've got people in the panel who are anti-Invisaligners, who do everything in-house. And we've got some people who are very experienced when it comes to just general orthodontics. So we've got a mixture of people here. And what I find really informative about this panel that we do is we usually end up agreeing the same things when it comes to tooth movements. The products may be different, but actually how we plan the cases are the same. And I think that's quite powerful to experience. I've learned a lot from these guys in hosting these particular aligner discussions. And finally, I just want to put acknowledgements in here. And I think this is my get out of jail clause. So basically anything that's gone wrong in this lecture, look at these guys. No. So I mean, this process has been evolving, and I acknowledge very much so Biju and his input, both in slides, the academic side, and our conversations. We learn from each other through the power of conversation as adults. John in the laboratory and Gary, who have allowed me essentially to say whatever I want here. And again, from your side as guys who are receiving this webinar, to have a company that lets a person who is experienced in aligners and orthodontics come and essentially teach to their own wishes, it shows that they're confident in the product, and also they understand that education isn't something limited to a particular brand. Mohammed Al-Muzian. So Mohammed Al-Muzian is the most intelligent orthodontist I've come across. And I met him, I met Biju and the team through him and some of the courses that he's done. And he's very much somebody who's academically inspired me. I'd like to thank you guys in coming to today, asking those questions which you have, and I will take them back and refine this lecture. As I say, this is a journey that you guys are starting today. Some of you may have had some orthodontic experience, but please do continue the journey from today, as do I, as does Biju as well. And we're always talking about different ideas, some new concepts, because we are still learning how to make ourselves better and also how to learn about aligners. It's still evolving as a science. Finally, to a friend of mine, Abu Bakr, who I've never met, who through my podcast, we made contact, and he shared some of the images which I've used today, and has been very keen for me to use it for education. So I'd like to thank him for his help in helping me put this together. That is it, Biju.
So yes, thanks for that again. Inspirational as always. And if you're okay, can we go through a few questions, quite a few questions?
I'm more than happy to do so.
Right, okay, so this is in no particular order, okay, it's just as I received them. First from Rebecca. Rebecca says, will you be able to give us the support to be able to treatment plan whether to procline or retrocline, and would like assistance on this decision? Rebecca, that is my raison d'etre. Okay, I live for that. So, as does a lot of the people in the lab. So, yeah, of course, that's why we're here. And feel free to email me, contact the lab, put it on the forum. We'll talk about how to do that. But yeah, the support is absolutely essential. So delighted to do that.
And I think what John mentioned about tweaking the setup as well, that's important. I mean, John gets really annoyed by me because I like to tweak and tweak and tweak. It's part of what drives an orthodontist, I feel. But the idea is that you can be unsure about something and submit a case, right? Because you have that flexibility in the setup to then alter it. Actually, I've now spoken to Biju. He recommended I do this. Okay, cool, I'm going to do that. Now I'm happy with it. It's not as though you have to have all the answers from the beginning. And I think that's also what's quite powerful about aligners, is that you can learn as you're going through the process without risking it on the patient.
Yeah, orthodontics is really conducive to that. It's not like implants when you've placed an implant into the sinus and you can leave it for 4 weeks and say, what do I do? Orthodontics actually is very conducive to that, learning as you're treating. Yeah. Nothing really moves particularly fast in orthodontics.
No. Nothing goes particularly wrong fast in orthodontics as well. And I think that's the key, right?
Yeah.
But yeah.
So from Pietro, when doing IPR, a couple of people have asked similar sort of questions. When doing IPR, must the gauge fit snugly or be loose?
Yeah, so it's fitting snugly. So if we go back to that video, again, thanks to TOC for letting me have that video, is that it's about it fitting snugly. So that is when you've got it. If it's loose, then you've got to go up a size. So what that video essentially showed is using one which is too large. It doesn't quite fit. And then going to one which just fits in. And that's where you need to be when it comes to using the IPR. Because I'm appreciating these increments are small. You get some with 0.05 in, 0.1, they are small. So yeah, get it to fit snug, and that's the measurement that you take. And if you're unsure, go up one or go down one, and then you will know exactly where you stand.
Yeah. How do you plan around resin bonded bridges from Cefacour?
Good question. So I make sure I plan around them. so it depends. So if the abutment tooth and the resin bonded bridge is in the ideal position, there's no alignment which is needed, then that's fine. I mark them as unmovable teeth. The laboratory don't change anything there. The challenge comes is when the abutment tooth is rotated, because of course derotating that is now going to change the position of that resin bonded bridge. And that's that conversation I have with the patient from the outset. I can align your teeth, but then we're most likely going to have to change that resin bonded bridge at the end. So it usually falls into one of those two camps. Either we're not really going to move it particularly, or actually if we are going to move the abutment tooth, it's going to have a consequence to the resin bonded bridge.
Yeah. Is fixed, Kathy Byrne, is fixed labial generally quicker than aligners?
Yeah, I mean, I'm going to give my 2 pennies on this. And I think overall, no, not for anterior alignment. Now, in particular cases, I feel fixed has an advantage. For example, when we take teeth out, teeth can drift into the gaps, and it's an open system to allow that to happen. But actually, generally for alignment, I don't think there's any difference. And also what I'd like to say on that topic is that there is no perfect system to move teeth. So there are some advantages with aligners and there are disadvantages, but the same with fixed. Now, in my mind, overall, those two then balance out. So the overall journey, I now tell patients, is the same between the two. Maybe there's a fraction of difference overall when it comes to fixed. So if the patient says, I absolutely want to have the most minimal time, I say, great, let's go for metal fixed appliances. It's the quickest way to get you there. But actually, if you're willing to have another month or so in treatment, then actually you can open up the doors of having aligner therapy as well. But for me, there's not a case of actually there's 3 months or 6 months in between the two. Actually, for anterior alignment, I feel as though they're both relatively the same. Biju, what's your thoughts?
I mean, I think we differ slightly here. I mean, I do a lot of fixed, and I've actually done a small study of about 12 or so cases where for every one that I treated with fixed, I got the setup as if it would be done with aligners. And there's a tipping point, and it depends on the degree of crowding and the degree of rotations. And I find that where you've got, as the crowding increases and as the degree of rotation increases, fixed generally is a lot quicker But there's a tipping point, and I can't tell you exactly where that tipping point is. But the things that really affect it are the type of movements and the degree of crowding. So I think, for instance, canines that are rotated, fixed generally is great for that. If you need a lot of extrusions, fixed is generally great for that. But there's a point where, for a significant number of patients, as you said, it's going to be about the same.
Yeah, no, and I think that's a great point there, actually, specifically canines and premolars. Actually, even to align those teeth well, fixed is going to be able to deliver that predictably. So forget about timeline, just predictably doing it. And this idea of some teeth not aligning well, it's not something which is generally discussed when we learn about fixed appliances, because generally teeth will align well with fixed appliances. The challenge comes with fixed appliances is getting the minutiae of the position of the teeth correct, which is a challenge to do, which is actually quite easy to do with aligners. So I feel as though it swings and roundabouts, but yeah, for specific teeth, specifically canines and premolars, fixed is the better option. But also patients generally don't come in concerned about the lower left 4, right? It tends to be the anterior 2 to 2, which is in question.
And I totally agree with you there. I think for very minor cases, I would prefer aligners every time, because aligners are very good for that fine control.
Absolutely. Absolutely.
And of course, these days, especially with things like the CFast fixed brace, you don't have to go for metal these days. We have our own self-ligating brackets, which are tooth colored. And for a lot of patients, when they see the aesthetics of the self-ligating bracket, like I said, I try and give patients an unbiased opinion of the pros and cons of each modality of treatment. And for me, still the majority, 60% plus, will go for fixed over aligners, even though aligners is what they came in for. So that's just, do you give those options?
Yeah, so ceramic appliances do feature, but I did an audit recently of my own work, Biju, and I find that I'm getting about 50-50 when it comes to aligners. So patients will come in and I will get about 50% of my work now is aligners, 50% of it is fixed, and it's usually label and usually ceramic. I've taken a few lingual cases each year, mostly just so I have some drama in my life. And it keeps me kind of, it's a humbling experience. I don't know how you are with lingual, but for me, I mean, I do take them on, but yeah, it's always a bit more involved.
I mean, I must admit, lingual is my go-to. I would always prefer lingual. I really do enjoy it. But I'm a bit masochist that way, so I don't know.
Biju likes to work hard. There's a difference between us and outlooks here.
But yeah, so no, I think, yeah, as you said, it's the key take-home point, I think, for this is be able to do everything, a bit of everything, learn those skills, because try not to be a one-trick pony. People will come in for various things, and if you can offer a range of things, then it really helps you stand out. How much extrusion is predictable?
Oh, good question. So if we're talking in terms of aligner therapy, is that the numbers we don't have a specific one for. What I would say is that what we have a number of is the predictability about how much you plan to do and how much you deliver. I hope that's making sense. So it's not as though it's 3 millimeters or 4 millimeters. What we have is that if you plan to, say, extrude the upper incisors 3 millimeters, we will predictably be able to do that with aligners of 1 millimeter. So it's about a third of what's predicted. So that's how aligners work, is that's the least predictable movement that they can do. So you may say, well, actually, great, I'll just plan 9 millimeters of extrusion of the anterior teeth, and therefore I'll get 3 millimeters. But actually, we've got to bear in mind that process results in lack of tracking taking place. So each time you are not getting what you've predicted, you're losing the attachment onto the tooth, you're getting it not fitting in well, which also then affects the adjacent teeth and the alignment. So unfortunately, it's not just a single way of looking at it. So extrusion are movements generally to not consider doing with aligners. Yes, it's been planned particularly well, and also you've got stability planned on the other side of it. Whereas, as Biju was mentioning, with fixed appliances, actually, it's really straightforward to do that. Still doesn't make it any more stable at the end, by the way, guys, whether it's aligner or fixed, but actually you can clinically deliver that better.
Great. You're going to smile when I tell you this next question. From David, I'm aware there's no evidence for ortho causing TMD problems, but is there a risk of causing a restricted envelope of function?
Oh my God.
The overjet and overbite.
So me and Biju were talking about this yesterday. And I'm going to say that there is no strong evidence, and I'll ask Biju to come in this because he knows the topic better. But we've got to bear in mind, guys, that when it comes to restricted movements, if we talk about wear and TMD, which seems to be where it's popular, is that there's no relationship that we understand from research looking at large samples of population where this restricted envelope of movement that's been proposed has made any pathological consequences to them, whether it comes to function, whether it comes to wear, and when it comes to TMD. So that is the studies of the population. At the same time, guys, having TMD, having wear, we know is a multifactorial process, right? It's not one thing which has caused it. And it may be occlusion has contributed, but how much is still debated? It may be 5%, it may be 10%. But the question is to perhaps address the larger etiological factors that these patients have to do with their diet, to do with other components of what's taking place, because those are going to have a far greater impact, I feel. Biju, what's your thoughts?
So just for those, just to clarify what we mean by a restricted envelope is, if I can use my hands here, when a patient chews, usually the mandible goes forward, up and back. So it's this sort of function. Okay, now where sometimes you have this retroclination, which I think what Dave was talking about, you get this sort of thing happening, or a premature contact, and then you get this wear. So you can see wear on the incisal edges, on the palatal surfaces of the incisors, of the upper incisors, and on the labial aspect of the lower incisors because of this restricted envelope. The main thing, I think, is my understanding of it is that there is very little evidence, or there's not a lot of sort of concrete evidence. There's been some studies done by, I want to say a couple called Lundeen and Gibbs, maybe 2010, 2012, that sort of, and you know, they came up with a figure of something like 0.37 millimeters was the envelope required to give some, you know, people function. So it's a difficult one to answer, but if you are seeing wear, then it's indicative that there's something going on. Okay, whether that's, you know, a bruxing habit or a restricted envelope or whatever you want to call it. So it's generally speaking, you know, I try not to pull anteriors back. I'd rather be more protrusive than retrusive. But yeah, if you see these things going on, then you want to maybe ask the question is what's causing that? And with our treatment, can we do something to prevent it from happening? Farooq?
I think also the key there is also looking at the parafunctional habits, right? And I feel as though that's one of the bigger etiological factors as well. And again, wearing a nighttime retainer that you get at the end acts like a mouth guard, so therefore, and that can get reinforced. So there's ways to then start to control some of those etiological factors of it, but it's not all in one. And I think to be bold enough to say, actually, I'm going to move your teeth forwards. I'm going to now stop the wear of your teeth because of the position I put them in, I don't think can be a supported statement because of we haven't studied the subject well enough, but also we haven't studied the patient well enough, right? Have we sat there and looked at how much wear has taken place over that period of time to come to that firm conclusion? So I think that will always remain a grey area. And I feel as though we should be informative to patients, say, actually, we don't know if this is going to make a difference to that, rather than shying away from the topic.
Yeah, and then just really following on from that then, this is a question from Burhan. Is moderate to advanced attrition-based tooth wear a contraindication for aligners?
Good question. It isn't a contraindication to the process. So I actually, now again, I'll ask Biju his opinion as well, is that for these cases, I actually prefer to use aligners for them because they have that interocclusal clearance created through essentially a mouth guard, which is the aligner. So their habit isn't manifesting itself any further onto the dentition, but also because they're changing the aligners between every 7 to 14 days, they aren't able to wear it through. Nobody I've seen so far has managed to wear an aligner down within that period. So I don't see that as an issue. Now, the issue on the other side, though, is that if the patient's got bruxism and has now got active TMD as well, right? So they're going through an acute phase of having problems with their jaw joints. That then is a contraindication because it's acute TMD, both for fixed and for aligners. We want that to resolve, the acute phase to settle, and then when they're in a healthy state or in remission, then carry out orthodontic treatment.
Yep, I would agree with that. Again, you know, if you're into the more sort of rehabilitative side of restorative dentistry, then being able to move teeth back to their original position or close as they were to the original position gives you great room to then restore these teeth. So doing these intrusive movements anteriorly, because what happens with often when you get wear, you get this passive overeruption, you can get those teeth back. You've suddenly created a lot more space to allow you then to do the restorative bits. So yeah, whether you use aligners or whether you use fixed, it is a great tool to have in your kit. Right. Other than costs and maybe number of aligners, you've answered this question, but I'll say it again. Other than costs and maybe number of aligners, is there any significant difference between Smile True and Invisalign? There's always that question.
The I word. They said the I word. So in the clinical outcomes, no. And I think that's the premise to start from. In the plastic, it is different, but is it better? It's still a question mark. And are the attachments, and I think we had the conversation with attachments, I think, John, it was great. And it's, again, partly why I work with you guys, is that there is a variability with attachments. And that is true, is that different attachments do different things. And the laboratory at CFAS Smile True are tuned in quite well to what those movements are. So in summary, I don't think there is a difference between the two. You mentioned about branding, and some patients come in going through the branding process. I want that, I want the brand. And I give them the options of brand / different brands. And then if they want to, there's a premium for that as a process. I don't dissuade them from that. But they need to have that awareness. But outside of it, no, I don't. There isn't one that I've come across yet. And I think if there is one, then I don't think we'd have users using other products, if that makes sense. Mm-hmm. Like if there was one which was actually truly better, there wouldn't be something else out on the market. But there are, and I, as a user of aligners, use a variety of aligners and aligner companies. And occasionally I use in-house aligners as well, which I'll design myself, and it's a really simple case, and then I get the laboratory just to print them. So in that respect, no, I don't think there is.
From Benjamin, a little bit of a complicated one, but I think I get the gist of it. I'm going to sort of paraphrase. If you've got a rotation anteriorly, where maybe the central is in front of a lateral, mm-hmm. How do you manage the contact area to minimize the risk of dark triangles forming, especially when the contact points are not really good to begin with?
Oh, yes. So it's about planning where the IPR is going to be. So say, for example, in the anterior label segment, it's come back from the lab tech and it's 0.2 millimeters 2 to 2, for example. What I'm then going to do is I'm going to ask the lab, actually, can we now change it between the upper 2 and upper 1 to 0.4 millimeters? Let's do more IPR there. And that way we are able to reduce that black triangle then occurring. But again, it's about reduction of it. We aren't able to stop that process. Fundamentally, the papilla has not formed to the ideal position because of the crowding that's there, or it's been lost over time, or periodontal disease historically. So it comes down to, it's great that you're tuned into knowing, okay, it's likely to occur here. We know what we can do to try and minimize it, but it's about counseling the patient. There is going to be a black triangle here. Here's what they usually tend to look like. Are you okay with that? It's down to your gums, because we don't need to be the all singing, all dancing, we will fix everything about it. And as I say, there are options at the end to consider bonding. And again, when we have done that for some cases, we haven't completely eliminated, but we've reduced it. So it's an option. But again, it depends on the two-shape form and how close it gets to the gingiva by that stage. So those are options which I put forward to the patient.
Yeah, and actually getting into that contact point, obviously the lab will design the case such that IPR will be done elsewhere to get some movement, so you can better get into that space to do IPR if there is a rotation. The other thing is with contact points is what you're trying to do is really trying to get the contact point 5 millimeters or less from the bone. And strategies have shown that if you get the contact point 5 millimeters or less, then you get papillary ingrowth 100% of the time. If the contact point is more than 5 millimeters from the crestal bone, it's less predictable. But that's not, it's just not always able to do that for lots of reasons. You may not be able to. make the teeth more square. You may have started with narrow teeth already. There may just be too much bone loss here. So there's lots of reasons that affect that.
Absolutely. And I think that's, you know, what's interesting is that that study was by Tarnow, and it was a great periodontal kind of landmark paper. And what it, I mean, translating that information as well, is that it means that if patients have undergone some loss of crestal bone, actually for them, it's not possible to do it. It's just not possible that they're ever going to get that 5 millimeter distance between those two outcomes. So it's helping us tune in. Actually, for you, we are going to have a reasonable black triangle. So bear that one in mind.
Great. From Monica, I'm planning to purchase a digital scanner. Which one would you recommend, please? Do you use a scanner, Farooq?
So I do. So I mean, at the hospital, I use a 3-shape scanner, the Trios. Yeah. And my practice principle is buying an iTero where I work elsewhere. Do you know what, I don't think I'm the right person to answer this question. I'll tell you why, because I get a bee in my bonnet with the iTero being housed into Invisalign and not having access to the bits. I mean, that really politically bothers me. It's a good scanner and I have used it. I like the Trios scanner. Those are the two that I've had experience with, and they both get the job done.
Yeah.
And I haven't noticed anything really different between the two. So my answer to the question, now trying to be apolitical, is that I think those two scanners work well. It's up to you which one you want to go for. You have more experience than I do about this. Biju,
yeah, it's quite a subjective question. When it comes to anything, you know, regarding these kind of things, it's user choice, isn't it? I've tried maybe half a dozen scanners. You know, the Trios, the iTero, the Medit is a good one, which we've come out with, the CareStream. So I've tried a few of them over the years. I find the iTero a little bit bigger. The scanner head is bigger. The good thing about that is you can scan more teeth, but it's harder to get in at the back. You know, it's hard to get sometimes the distal of the sevens. It's also very sensitive. I find you've got to really have dry teeth. Maybe that's just me, but I found that one. So that's iTero. Yeah, okay, it's still a good machine. The one I really prefer though is the 3-shape, the Trios. Yes. I've been using the Trios now for over a year. We have one in both of the practices that I work in, and it's just, I think that's just phenomenal. And nowadays, I must admit, I would struggle without my scanner. There's very few things in dentistry over the decades that has been game changers, but this by far for me is just, having a scanner is just phenomenal. You know, you can scan in about a fraction of the time that you can take an impression. And it's just really accurate, and to be able to show this to patients, it's great. The Trios scanner, I have no commercial interest, by the way, unfortunately. The Trios scanner, you can show what the end result potentially. It has like a predictive setup in there as well, which is not always brilliant, but it's a great thing to show the patient, being able to send it to the lab immediately, and if you want to discuss things with the lab, then they can upload it and you can have the conversation. So yeah, scanners are definitely the way to go. If I had to make a choice, Trios, but it's expensive. The newer one on the market what I've used is very good, is the Medit one. So if you have a trial of the Medit scanner, it's a fraction of the price. Again, very good.
And one thing I'll just add in there, again, coming back to the I word, is that Invisalign don't accept scans for most other scanners besides the iTero. So that needs to be borne in mind as well. As to how that will be, which is a shame, I feel.
However, we can accept scans from iTero. So if you have iTero and you want to send us a scan, then just contact us and we'll let you know how to do that. Cost of treatment to patient.
Oh yes, so it's something that we've had conversations with about as well, and you know, there's so many variables when it comes to it. But I think I've got a slide actually where I did actually put this information on. It's really about looking at your local area and seeing what are the types of costs and so forth associated with the region, and pricing accordingly. So this is what I generally tend to charge. Now, again, this is very much, I mean, I work in North London and in Central London, my prices are higher than this. But this is generally how it tends to break down. So having the laboratory fees and then about £200 per appointment. that a patient pays. So I've hopefully given you guys a structure of how the appointments generally tend to work for a straightforward case, given the number of aligners. So this is how I then piece it. So if I'm having 7 appointments, for example, this is what we're looking at when it comes to 7 aligners and the treatment for it. And I put the laboratory fees on top of that. So I've got my costs. And of course, the lab fees are different now from what I've written down here for CFAS with their discount. But that's how it tends to work for me. But I wouldn't be too, I don't know what the right words are now, is that I wouldn't be too rigid with what I've just shown you there. What I would say is have a look at your local area and starting off your first few cases. You know, I think the cost is always secondary. It's really about being comfortable with knowing what you're doing. You may wish to make it even a little bit cheaper, or starting off on nurses and so forth. You know, get yourself up to the skill set first. That's generally how I price it, £200, because that's how it works in my region and how my colleagues who practice in and around me do it as well. But look at your area. I don't know about yourself, Biju.
Yeah, there's such a variation across, geographically across the country. So what I suggest is, rather than me giving you a price, that doesn't make sense. What we're charging in the west of London is going to be very different from what we're charging in the islands of Scotland, say. So do like a secret shopping thing. Get one of your nurses to phone around and say, right, how much are you charging for aligners? And then you get a feel for what people are charging, but don't feel you have to undercut the competition. Okay, when patients are coming to you, they come to you because they trust you, and a lot of your patients that come to you will be either recommended to you or be existing patients. So don't feel that you have to undercut what everyone else is doing. I'm what I call reassuringly expensive. I charge significantly more than those around me, and I make no excuses for it. And there's no shortage of patients out there. And quite often, if you get the patient that's shopping around looking for a deal, those tend to be the really difficult patients. Their expectations seem to be very high and they're difficult to manage. So charge what's appropriate, and don't ever feel you should undercharge, or try and beat the competition. That's not really, I don't think you have to go there given the demand for aligners at the moment.
I think that's such a powerful thing because, it's interesting. The specialist referral practice that I work in is that there are patients who will shop around and what have you. And it's interesting that some of them will settle then to have treatment with me, even though I know that they have been quoted a much cheaper price elsewhere. And it's interesting how those dynamics then work. And I think it is an important variable to put into place, is that you are charging for your time. Now, I very much came from the NHS hospital side, and kind of charging money to patients always seemed like it was the wrong thing to do. But actually, in the fullness of time, patients actually do value your time and expertise. And I think it's not necessarily about being the cheapest available. And there are premises and business models where they do operate off that process. I know there's a colleague of mine who owns a practice off that premise, but that's not really what I want to do. What I really want to do is get you a really good outcome and a really predictable outcome. And for that, I've got all these things in place. I'll see you a certain number of times to make sure that we deliver that. And that's really what I'm about. There are certain other models which perhaps are very, very super duper cost efficient, but may not offer the same outlook in their planning for patients. So, that difference has to exist in the price point as well.
Absolutely. From Chi, please advise the pros and cons of the solid metal wire and the braided bonded wire.
Oh, okay. So most bonded retaining materials are usually braided. They're either coaxial or the multi-stranded stainless steel wires. So generally they follow that format. The ones where it's a solid wire, I've only seen the nitinol one, which I haven't used myself. But generally they tend to be of a flexible nature to a degree. And the reason why some of the other wires perhaps haven't done so well is because they tend to either be too stiff, and therefore actually with the wire retainer there, we want to have a little bit of flexibility there. One, so it's easier to make. Two is that teeth naturally physiologically have their movement when we're occluding, right? So they've got to have some allowances for that, but not so much that the teeth actually then move position completely and are no longer straight. So I think it's just through the fullness of time is that multi-stranded stainless steel wires have turned out to be ones which are physiologically great, but also are able to maintain enough rigidity to keep the alignment of the teeth. But there's no perfect bonded retainer. There's no one which you can put on and say, actually, you won't have any problems, there'll be no debonds, and it'll stay there forever. They have to appreciate that there's a complement of the removable retainer, because there's no perfect retainer in the world. Teeth can still move. If the bond retainer fractures, you're not aware of it, okay. 6 months later, your incisors move forward. I didn't realize what's going on, and they haven't tweaked it. So there isn't a perfect one, but usually it's multi-stranded stainless steel wires.
Yeah, and the one that the lab uses, which is on the stent, is called Hilger's wire, which is a more of a solid wire, but it does have a degree of flexibility in it. You don't want your wires to be too rigid, basically. You need the teeth to be able to move a little bit.
Yeah, absolutely. And that sounds contradictory, right? But it's about physiological understanding of what teeth do when they are functioning. They will move to a degree in occlusal forces. Likewise, having something which is too flexible, of course, that doesn't make too much sense. And actually, it's more likely to cause tooth movement. So that's where we are.
Great. Do old but adequate root-filled anteriors present any problems with attachments or aligners?
Good. Well, it's an interesting one. So there was this thought process some decades ago that root canal treated teeth can't be moved, but actually that was quickly dismissed, and root canal treated teeth are fine to move. The only challenge that comes with any orthodontic movement with a root canal treated tooth is if there's any active pathology there. So the idea is that if you see a tooth, it needs to have a root canal treatment done. That takes place, and actually you're looking for apical resolution to have occurred before you then go on to using your aligners or your orthodontic treatment. And again, just to break down why is that the case? It's because orthodontic treatment induces a controlled inflammatory process at the periodontal area. So if you have some pathology that's there and it's not resolved, you can exacerbate symptoms for the patient. And the idea is waiting at least 3 to potentially 6 months post RCT, if there's apical pathology, before starting your line of treatment. It's different if there's no apical pathology, say you had trauma, loss of vitality, there isn't anything going on apically, do the RCT, you should be fine to then start your root canal treatment. To clarify, there's no issues with tooth movement with root canal treated teeth. There is an issue of moving teeth that are ankylosed. So if this was a traumatic tooth, which now has some form of ankylosis, of course that tooth's not going to move. So in itself, the question, there's no issues with root canal treated teeth and having orthodontic treatment. There are issues with having ankylosed teeth, yes, and apical pathology, which is still there for teeth.
Yep, brilliant. From Poonam, should the first aligner fit properly on teeth after bonding attachments, or would there be some slight play?
Yeah, so the first aligner is usually going to be an active aligner. So it is going to be moving the teeth to a degree. But remember, it's 0.25 millimeters. So we're going to try and quantify what that appearance would be. And it's a very slight gap between the tip of the tooth and the incisor. Now, what I tend to do is that when I get my aligners, before I put the attachments on and anything else, I will simply just put in the aligner to make sure it fits well, or reasonably well. And then I put my attachments on and so forth. So then I know whether it's my attachments that are causing the issue and the way I've put them on, or whether it was the fit of the aligner. Now, the idea is that if we are planning a case, we're having our impressions taken, the patient hasn't got anything active happening inside the mouth at that stage. The teeth shouldn't move. If in that interim, the patient has a restoration done and it's high or something else is happening, then the teeth can move. Teeth are very dynamic and they will move through whenever there is an occlusal issue that occurs. So the idea is all the restorations and so forth should be done. The occlusion should be stable. And that's when you take the impressions and then fit the aligners.
Yeah, and also remember, before you do place any attachments or do any IPR, make sure the first aligner fits. Okay, just make sure it fits first before you put on attachments. The last thing you want to do is put on the attachments, do the IPR, and then find out the aligners don't fit. All right. Yeah.
And I don't know if Biju is talking about the same experience I have, because I learned that the wrong way. I learned that the hard way. That, oh my God, what have I've like done all the hard work and it doesn't. What am I going to do? What do I? And then you have to take impression and try and look as though that your brow isn't completely covered in sweat. So yeah, do try it on as soon as it comes. That is your insurance policy. And then if it doesn't fit, it's not the end of the world. You've not done anything to the patient. New impression, speak to the laboratory. 2 weeks later, we'll do the same thing again. It's fine. There's no issue.
Yeah, that's never happened to me. From Daniel, great talk, learnt a lot. Thanks, Daniel. Just wants to ask, having listened, been through the webinar, can we start providing or using CFast aligners? or would we need to go on any further courses, like the training day for fixed aligners?
So you'll be accredited from today. The documentation will come through, so you are ready to go Monday morning. See the cases, take the impressions, take the photos, send it through to the forum, send it through to the lab, and you are good to start providing your care. What I would say is about case selection is always important whenever trialing something new. So finding the cases, I mean, lower arch alignment for me is the easiest case, or mild crowding once you've carried out your orthodontic assessment in that relatively class 1 case. So those are the cases to really kind of cherry pick at the very outset. If it's something more involved, take an image, send it into Biju. And I think what I've enjoyed about Biju and the conversations that we have about him looking after the forum is that if it's a new person who hasn't got much experience, then actually there will be a case that they wouldn't recommend for them. If there's somebody who's got more experience, they will recommend doing certain cases for them. So it's tied to you guys as well. So if it's your first time, make sure you make that clear. And then the laboratory will help you through that process.
Yeah, there's a few of us that help with on the forum and on the emails. But Daniel, for your first cases, I'm more than happy for you to send it to me. Just email me the photographs first. So I think that's the first thing to do, is take some photographs, send them to me, and I'll talk you through whether the case is suitable or not, and the kind of movements that we're looking for. And also, when you get your treatment set up, send that to me as well, and then we can go through that as well. And once you've done that a few times, you're pretty much good to go. From Pietro, when asking for advice, what information do you need? That's a really good question. If I can just answer that, we do need photographs. Okay, that's the first information. It's also good to get an idea of what it is that concerns the patient and what you're hoping to achieve from treatment. Quite often we'll get emails that says, please advise, and that's it, right? Or words to that effect. And that's, we can sort of guess, but the problem with guessing is we really don't know what the patient wants. Is it an upper arch? Is it a lower arch? Is it both arches? Is it a single tooth that's the concern, or one tooth that's more concerned over anything else? So the more information you can give us in that regard, the better. But photographs are essential. Also, when you do send your cases in, please do start a new email thread for each case. Otherwise, when we're giving advice, you can get confused. So generally, we'd always ask to start a new email thread for each case. But photographs and a brief description of what you're trying to achieve that's enough, really. From Poonam, would you contraindicate probably a case in which ideal overjet overbite can't be achieved for a bonded retainer?
Yeah, so the challenge comes in 2 ways, really. One is that if there's not enough space, so that if we say we've still got a deep bite, and we're making contact essentially where the wire needs to go. The ideal is for the incisal tip to be 20 to 30%, 40% of overbite, and there's enough space to put the bonded retainer. So there's 2 ways around that as a process. And I know me and Biju have slightly different thoughts on it. So for myself, usually that's not an outcome of treatment that I will deliver. Right, so we've got to bear in mind I will overcorrect my intrusion to ensure that's delivered. If it does occur, I will then think about dialing in the bonded retainer. So I'll still put it in the ideal position. I won't compromise on it. Now, there are some ideas about putting the bonded retainer quite gingival and having it gingerly contoured. I don't think that works very well from a hygiene perspective. Also, the wire has to go through phenomenal amounts of contouring. I mean, the ideal thing for the wire is to be relatively straight. Because it's been contoured more, there's greater wire, there's greater chance of fracture and all sorts. So for me, that doesn't work well. I don't want to compromise my bonded retainer. So I'll still put it in the ideal position. The patient will essentially be jacked open, posterior teeth won't be in occlusion, and I'll wait for them to dial into position. But as I say, I will clinically avoid that being an outcome by overcorrecting my deep bite to an edge-to-edge position. Now, if there's an increased overjet, we actually tend to be okay. So if we go back to our classification of a size of relationship, actually a class 2 division 1 or an increased overjet, the low incisor on the cingulum plateau. Remember, that's where the bonded retainer goes. So it's going to be behind it. So usually with increased overjets, we're fine to then put on that bonded retainer. Biju, I know you've got your thoughts on it as well.
Yeah, I mean, when you showed us the treatment setup, looking at that palatal view, so from the sort of the tongue view in as the patient bites together, that's one I always check, because I want to see how much room there is for a palatal retainer, and always try and give the patient a sort of lingual palatal retainer, fixed retainer. If there's going to be contact, then quite often I'll ask the lab to either intrude or procline the centrals maybe a little bit, just to allow room for that. I occasionally do the dial thing, but I just don't, and I don't feel as comfortable with the dial thing, because I think patients don't like that feeling of biting. And I almost feel like they think that I've not done it correctly, and I'm just, it's like a bit of a fudge at the end. So if you are going to let it dial in, I think you need to let the patient know well in advance that the bite is tight, and that the bite may need a period of settling in, rather than telling them at the very end, oh, by the way, you can feel that the bite is tight, and you just say, oh, it'll settle in, don't worry. Yeah. So better not to deal with it that way, better to deal with it up front. So have a look at that view, check where the incisors meet, and try and plan for that in advance, either by saying to the patient, look, you're going to feel the contact point, we're going to let the bite settle, or speak to the lab and ask them if they can do something.
Yeah. And I think prevention is better than cure, right? So, I mean, if we can then plan that case so there is space for that bond of retainer, that is what we should be doing primarily, I feel. And there are a few cases, as I say, where I feel as though I've had to go through that full doll process. Yeah, so I agree with Biju in that respect.
Yeah. So from Rebecca, if someone has an existing composite bonding on a lateral to disguise a palatally placed tooth, do I remove the composite before or after alignment? That's a really good question, actually.
This is a great question. I'm actually treating a case where patients had that happen on two of the upper incisors, lateral incisors. They've had composite veneers essentially. And it comes down to you in a planning process. So I'll tell you what I've done for this case. Is because they're so far palatal to begin with, what I've actually done is staged the process. So what I'm going to do is, what I am doing is that I'm bringing the lateral incisors forwards without any attachments on and with the composite still there. So I'm essentially going to bring them further forwards. It's going to start to look as though it's malaligned, right? And then when I get to either the line number 7 or line of 14, and they are now starting to stick out, that's when I'm going to take them off. I'm then going to take the impressions for some further aligners at that stage, and then that's when we carry on from there. And for me, aesthetically, that is the ideal. Yeah. I could take them all off at the beginning. It's possible. It's still going to work. The same tooth movements taking place. But aesthetically, I mean, this is basically why the patient's coming, because they don't like that, and you're going to essentially make them look like that. So for me, that's a really good halfway house. Bring it forwards so they may stick out a little bit. Take them off so they don't look as far back as they once were, and then continue the process. I did toy with the idea. And Biju, I'll ask your thoughts as well. I did toy with the idea of doing it sequentially, but I thought, it's just going to be too much of a faff. Let's just do it once, but let's bring them halfway forwards first, take them off, and then do the final bits of it. And it seems to be going well.
Yeah. Again, there's a few ways to it. I've done it several ways. What you can do, if you plan not to remove the veneer beforehand, then you would ask for the lab to get the tooth in the right position. All they need to do is align the palatal surfaces. So if you ask the lab to align the palatal surfaces of 2112, you know pretty much the labial surface is going to be roughly in the right place when you take that veneer off. You can take the veneer off first. The other thing also, if you're going to replace that veneer, I ask the lab to leave the lateral a little bit back, and that way you don't need to prep. Okay, because if you bring it perfect into occlusion, you then need to then compensate for the subsequent veneer by doing some prep. So plan that a little bit in advance, ask the lab to leave it half a millimeter to a millimeter behind the central, so you can actually do a minimal prep on that tooth, or no prep if you want to go down that route.
I think that's a great idea. I think it's a great idea. For me, sometimes, well, how we may need to remove it to work out if we're going to replace it. So for me, taking it off kind of halfway through lets us make that decision together with the patient. And also I can then tell the lab, actually, guys, we do want to keep it a little bit palatal, actually fully align it because we don't need to put anything on. These teeth were fine underneath it. It was just a position. So I think it's a great thing about aligners is that we can make that decision. With fixed appliances, the real challenge with those guys is that they are essentially designed to align things from the buccal surface. So actually it becomes quite difficult. We have to start putting wire bends in and other things to be able to achieve that. Well, with the liners, we've got control both palatal and buccal. So we can push the tooth outwards, and it's relatively straightforward to do. So again, we spoke about minimal crowding cases. This is one where actually my preference was to use the liners because my life is so much simpler.
Yeah, or fixed lingual. Brilliant. That ticks that box, because actually with fixed lingual, as the tooth comes forward, you can slowly reduce, but you're aligning palatally. Because you're aligning palatally, it just ticks both those boxes. As the tooth proclines, you're slowly reducing and reducing. Another trick.
And if you want to work really hard, that's the way to do it.
But you charge appropriately. From Poonam, do we need to worry about lower incisors losing lingual bone support when they are retroclined in upper spacing cases? Do we need to worry about lower incisors losing lingual bone? Okay, I got that. When retroclined.
So if they're already retroclined low incisors, and if I'm right, the question is if we're going to now close space in these low incisors. Is that what it is?
So it's a little bit ambiguous, but do we need to worry about lower incisors losing lingual bone?
Yes.
When they are retroclined?
Not really. So I mean, if you think about the way that tipping movements take place, if we talk about this as the crown, we talk about this being the root, is that a tipping movement essentially is a rotational movement about the midpoint of about a third from the root. So it's essentially that movement. So actually, when we're retroclined teeth, ironically, the root is going labial when we're doing tipping movements. So the answer to that question is no. What tends to be more of concern, actually, usually in those cases, when they're retroclined low incisors, is actually the lower gingiva is usually quite thin. It's been stretched because of that tipping that's taken place. So it's more about the labial face in those types of cases. So you can still retrocline those low incisors further, but you got to watch out what's going on at the front surface of the teeth. And the risk is, well, the answer to the question is you can risk affecting bone in either scenario when you're carrying out orthodontic treatment, either proclining or retroclining. But actually, when we spoke about using the conformative approach when it comes to planning our cases, if we plan to keep them relatively where they are, we're in an ideal scenario. And when it comes to making retroclining and proclining movements, we've assessed the gingival biotype. And again, if it's a thick, square-shaped gingival biotype, we're in a pretty good setting from the outset. If it's thin and scalloped and we're concerned about how friable it is, then actually we need to think about, is it the right thing to do for this patient?
Yeah.
So it's not right or wrong, guys. It's about our assessment process to make that decision.
So use that form, because that form does actually cover that question. Okay, so it just prompts you to at least be aware of what's happening there. From David, with rotated teeth, how necessary is incision of transeptal fibers to achieve stability and longevity of the rotation? You can explain what that is to begin with. I used to do this all the time. I never do this.
So I mean, so guys, there was. I mean, it all comes down to this one study by a guy called Edwards, many decades. I think it was 1970 something, and essentially what they did is that there was a tooth. They rotated the tooth, and they looked how stable it was without any form of retention. And then they also did some circumferential pericision. Essentially, they got a blade and they went around the gingiva of the tooth and they cut the supracrestal fibers, the periodontal fibers, right? And what they found is that the tooth was more stable at the end. Now, that was a very historic study. That was before really the advent and popularity of bonded retainers and also vacuum formed retainers in the current connotation. So this was at a time where actually things did relapse quite a bit. And we were trying to find ways to make things more stable. The answer to the question is, at this point in time, we don't know if that's going to be make any difference to the equation, because we're providing indefinite retention to these guys. We don't take these bond retainers off and say, okay, let's see what happens now. We're keeping it on. So the idea of circumferential fibers being separated means that the elastic, which is pulling them back to where they've started, is removed, but it shouldn't really be applicable if we're providing bonded and removable retainers. Now, ironically, when we look at some of the literature, that Cochrane review by Simon Littlewood, it does state that in his Cochrane review, but that was because it was one of the very few studies that looked at that, and then nobody looked at it again. So I mean that's a long time ago to base clinical practice on, and I don't think it's applicable to current day clinical practice.
Yeah, I mean, like I said, when I first started out, maybe going back in the day, that's what I was told, was to cut. But I tell you, it's not a practice builder. Yeah. Okay. The one thing I like about orthodontics, it's blood free. It's just a nice way to practice. You don't get messed up. And you certainly, I don't want to be cutting anything really in ortho. Maybe I'll stick in the odd tad every now and again, but that's about it, as much as it goes.
Yeah. Oh my God, Biju, you should have seen me giving local. Like I used to do oral surgery. I used to do a bit of, I used to do some a surgicalist back in the day before I started orthodontics, and I do put in TADs. But when I'm giving local anesthetic, honestly, it's there's a lot of there's anxiety there. I tell you, I wish I could call. I wish I could refer for the local. Somebody else put the local in, please.
From Chi, can you give us the link for dentinal tubules, Farooq? And if you send that to me, then I will send it out to everyone. So we'll make sure you can get it. So we'll send that link out to you, Chi.
Cool.
From Jyoti, how much space or overjet do you need to leave to allow for the bonded retainer?
Good question. So when it comes to having an ideal occlusion, the idea is nothing. So if you've got an average overjet and overbite, there is space on that single plateau to put the bonded retainer. So essentially nothing. It's only in those compromised type cases where the overbite is still deep, we need to leave some space. And for me, it's about leaving about 1.5 millimeters. Anything less than that is not enough space to put anything on. So about 1.5 to 2 millimeters of space. That is probably what I would suggest. But again, I think that's now going down more that compromised option, where you're trying to sort it out afterwards. I think when you're planning it from the beginning, it's about trying to get the occlusion sorted first, right? Trying to overcorrect, trying to get that greater intrusion to take place so you have the space to be able to put the bonded retainer. And that would be my ideal case scenario. But yeah, I don't know if you have a quantity that you work to. I tend to eyeball it, if I'm honest.
Yeah, eyeball it, really. I just asked the lab to, the retainer wire, especially the one that I use, the FlexTech, OrthoFlexTech is, God, what is it?
That's right.
0.2 or something of a mil. It's not even as much as that, probably. Yeah, it's very thin, so you don't need much.
Yeah, and my wife, yes, it's very small.
Yeah. From Laura, are the attachments decided by the dentist or the lab? If it's the dentist, can you give us more information on attachments themselves? Laura, I would not do that to you. I read that document. It's about this big, right? It's got to be the most boring language. Whoever wrote that has no understanding or appreciation for the finer points of English literature. It was just written in the most dullest prose, and it was just that long. And geez, I had to keep myself awake just reading that document. So if you really want it and you need a good night's sleep, then I'll send it to you. Otherwise, the lab does it for you. We've R&D'd this to death. So you don't need to worry about it. But if there are specific areas that you prefer attachments, for instance, I always like attachments on the 6s. I like the aligner to sit. So if there's specific attachments that you like, then by all means tell the lab, but usually they work it out for you. Farooq?
Yeah, I mean, I think that's it really. The actual science of attachment design is, one, it's quite extensive, and two, it's very theoretical, and three is that the clinical research that looks into attachment design is very unequivocal as to what makes a great deal of difference. And I think this is down to the laboratory's experience using attachments and attachment design and the clinician. So for example, for me, I was of a preference for lateral incisors. I had to put big bulky attachments on them because the tooth shape is small. And for me, that makes me feel comfortable. I have a colleague of mine who doesn't do the same thing, and we still seem to get reasonably good results. So it's an experience building process. What I would do is ensure that you go with the laboratory from the outset. And it's a good thing to consider learning about, right? Ask the laboratory, why did you use X, Y, and Z attachments, and try to build that knowledge base from the process. But the lab have got hundreds and thousands of cases under their belts, right? So let's use that experience and let's not nullify that as a process. And you'll pick up ideas and tips as it's going along. Attachment design is still a developing science, guys, which is why we now see different shapes of attachments, very simply. Historically, there were literally just one shape of attachment. So we are still growing and learning as that process then takes place.
Yeah. We always get asked this question, so it's another one. What are your thoughts on the likes of Smile Direct Club?
Oh, God. God, that's the next word, the I word.
Wrote about it, didn't they?
So Smile Direct, I mean, it's so let's just, I need to say the objective stuff first before I go into it, don't I? So it's an unsupervised delivery of orthodontic tooth alignment. So it is non-clinical engaged. The planning process hasn't taken place through orthodontists or clinicians who've got experience as dentists in that process. It's tech driven. It's nighttime only now. They've got it down so it's just 12 hours of wear, which there is no evidence to support it. That tooth movement can take place. And it doesn't make sense for that to happen, right? Nighttime aligner treatment, if you're moving it and you've removed it for 12 hours, once you take the force off, it will move back because you've stretched all the periodontal ligaments. It's going to spring back. There's some serious question marks about the theory behind it and also the clinical application. Now, don't get me wrong, I've seen patients come out of Smile Direct Club and their alignment is not bad. I've had other patients come out from Smile Direct Club who now have retreatment and it's now more complex treatment. The idea of being unsupervised, I feel, is the biggest challenge in the process. Forget the rest of it, how it's delivered and so forth. It's the unsupervised nature of it. Now, guys, if you see a case and you are up to -7 and it's lost tracking, right? You're going to take photos. You're going to contact the forum. We're going to give you a way to work out how to do that. You're going to get them to go back to aligner, wear them for 2 weeks, concentrate on chewies, or get some new aligners made. If that interaction doesn't take place, I'm not sure how you can ensure predictability to the outcome. And we started today describing how to deliver a predictable result to a treatment. I don't think that can be done without clinical involvement. Teeth are not an algorithm. They need biological and clinical monitoring to see what's happening. There are legal challenges taking place with Smile Direct all across the world, and I think it's going to fade away. To what context, I don't know, completely or partially. But I wouldn't want my own family members to have that as a process, whereas I would be keen for my family members to have aligner treatment. And that's probably where I'd conclude to.
Yeah, I mean, unfortunately or fortunately, depending on which side of the argument you stand on, it is such a big business. You know, it's $1 billion business and growing. So I don't know how much teeth the GDC have in doing this, because a lot of the companies aren't even based in this country. So we just have to watch this space. But you know, you are going to get a significant number of patients who are basically going to shock on cost, and it is where it is. We just have to let's see what happens. But don't get me wrong. There's those cases are only non-IPR cases, right? So that's a small minority. This vast majority of patients need IPR, or they end up with a very protrusive sort of setup. You know, so which doesn't look particularly great. So it's not going to affect dentists, you know, in a significant way, because most patients do need IPR. And secondly, it may even work to our advantage, because what it does do is it raises the awareness of this modality of treatment. And if patients do get a setup, a significant number I know won't be suitable, and then having gone down that route, their next stop usually is the dentist to get it done, because they need IPR. So, you know, there's two ways to look at that, but I don't think it's going to go away in a hurry.
Yeah, and I don't think it's something for us to worry about either, right? I don't think it's not going to stop patients coming for alignment of teeth to ourselves. But yeah, I mean, I harbor my clinical concerns. And I think, to be honest, if they were doing it and they were getting good results without any issues taking place, then hats off to them. They've solved their own issue. But I do get patients who have had treatments through the process and it's not good. And to resolve it now, I mean, the patients were never going to have such complex treatment to begin with, and now they are. So, I mean, that's my biggest issue. If patients get harmed in a process, for me, it doesn't matter what the title is, what the brand is, you know, we've gone to the wrong direction at that stage.
Great. That's 4:30, so it's pretty much on time. Sorry I've not been able to get to your question. There's still quite a few on there, but if you want to email me directly, then I'm more than happy to answer. We will contact you by email over the next few days, and we'll send you your CPD certificates and lots of information on what the next steps are, where to send your cases for any help or support, how to log on to the forum, and if you can send me your link for the dentinal tubules webinar, we'll include that as well. So it just remains for me to say thank you so much again, Farooq. It's always, I so look forward to these webinars. I think they're so well received, and I learn a lot as well. So thank you for your time.
No, thank you, Biju, for inviting me back. I'm always question mark if I do if I'm awkward enough to Biju, will he actually invite me back next time? And he does, so I'm just going to carry on doing it, really. I just thank you guys for being, for attending today. And also with the feedback forms that you guys get, I look at those in really lots of detail. So as I say, education is a journey and we are delivering it, but we're also learning. So the cases, for example, we chose today has come back through conversations with you guys. Well, I've got a spacing case, I've got this case, so cool, we've incorporated that in. And anything that you think can make the course better, we'll of course take on board. But I look forward to seeing your guys' feedback. I hope you've enjoyed the day, and I hope you enjoy doing your aligners on Monday morning.
Yep. Well, thank you, everyone. Have a great rest of the weekend, and please get in touch. And like I said, we'll be reaching out to you soon. Thanks again.
Take care, guys. Bye.